Yeah. Yeah. Ay. Hello. All of you, please settle down. I request everyone to please put your phones on silent mode or switch off. No, sir. Start now. Our conference is Global Development and Trends in Physiotherapy. As we know, physiotherapy is a healthcare profession concerned with human function and movement and maximizing physical potential. It is concerned with identifying and maximizing quality of life and movement potential within all the spheres of promotion, prevention, intervention, habilitation, and rehabilitation. In today's scenario, the scope and dimensions of physiotherapy is expanding exponentially across the globe. So indeed, it is necessary to enhance ourselves in order to deliver the best healthcare services to the society. So as we have some delay in the arrival of our chief guest, so once the chief guest will arrive, we'll start the official inauguration ceremony. Till then, let's not waste the time and we'll start our sessions. Okay, so this is a 2 days conference. We all are here. We all are gathered here for the GAPTCON 2021. In this 2 days mega event, various scientific sessions will be held in which legendary physiotherapy professionals, renowned academicians, and expert clinicians will give insights on different dimensions of physiotherapy. So, to begin the session, I may call our keynote speaker, Professor Dr. Umashankar Mohanty sir, President, Manual Therapy Foundation of India, and also the International Executive President of International Executive Board, GAPT. I welcome you, sir.
Very good morning to all of you. Mike. So indeed, very happy to see you all for the first annual conference of our Global Association for Physiotherapy. I appreciate all the delegates, our organizing chairperson, Dr. Prabhat, Dr. Navneet, organizing secretary, members of organizing committee, Dr. Mayank, Dr. Harpreet, and all the Dr. Mehul. So I'll be presenting on the topic manual therapy in present era, unraveling the barriers of mechanical enigma. In the present times, the mechanical dysfunctions are very common, and as physiotherapists, we frequently come across the various mechanical issues like neck pain, back pain are so common. I think worldwide, 60 to 70% of our physiotherapists are working in the OPD setup. They have their own clinics, and our major chunk of people are working in that. So that's why, and I being a manual therapist, I thought I'll share some important aspects with a restricted time of 20 minutes. So I'll be sharing some important aspects of neck pain and low back pain. And if time permits, I'll discuss something else. Some other. So coming to the neck pain, neck disorders are very common and rivaled only by the low back pain. And other problem, what we come across is osteoarthritis and other disorders of musculoskeletal problem. Neck pain is going to take over, or near to the low back pain because of uses of computers and mobile phone. Almost anywhere you go, right now this conference is also being live, and so many people are watching, and I appreciate their efforts also to watch this talk. Or many people will be watching this afterwards because it is recorded. So, and you see, that is the utility of the technology. But then every positive thing also has its some kind of drawbacks is there. So if you are constantly bending for a long time, either using the computers or mobile phone, you are definitely getting the problem of bifocal posture and neck pain and thoracic pain, shoulder pain. Those are the consequential progresses. International figures indicate that at any point of time, 10 to 15% of the population will be suffering an episode of neck pain, and 40% will suffer neck pain during a 12-month period. And when we talk about neck pain, in the present time, something called as cervicogenic headaches are very, very common. Dr. Sunil, is he here, Dr. Sunil? Yeah, please be here, so that I'll be just taking him as a model. Little side, just please be here. Be here. Just come this side. Come. Please come up. Just turn this way. I thank you for coming and helping me in better understanding. You see, when somebody is having a mechanical problem, and when we talk about the mechanical problem, two problems are more common in the cervical spine. One is the facet involvements. Next is cervical disc prolapse. What is the cause for cervical disc prolapse? Constantly, going for a flexion position. And coming to the facet involvement, facet joints are very small joints, and when there is a bifocal posture, you see somebody is using the computer or mobile phone and head is translated forward, and when his head is translating forward, or there is a thoracic flexion, or there is a more position towards slumping, so head is translating forward. So we will just observe here that if he's slouching, just slouch. I mean, no, not using just mimic the use of a computer. Now, right. So when he's going for a thoracic flexion, obviously the neck is translating forward, and when the neck is translating forward, what it will do? It will create the stress on the facet joints, and facetal irritation is going to create the muscle spasm. And when there is muscle spasm and trigger point, it develops over a period of time, it develops something called as trigger point. What is one trigger point? A trigger point is one electrically hyperactive point exhibited or found inside the skeletal muscles. it is found in form of a band or in form of nodules. When you palpate, you can find there is band or you can find there is nodules. That is electrically active. Why it is electrically active? Because so many C fibers take origin from that focus. And of course, there are volumes of books on the trigger points. Now, what happens is when you have got a trigger point in the traps, that is going to produce the occipital headache. You know, upper traps is having attachment to the superior knuckle line. And sometimes when you do the palpation, the person may tell that I am getting headache and there is some kind of swelling. When you palpate, you can find there is enthesopathy also. Swelling appears there. Headaches are there. Another muscle, which is of more importance, is the suboccipital muscle. The suboccipital muscle, you can do a small palpation. You just put your 4 fingers just below your occiput. And you just try to poke the chin out and tuck it in. Especially when you poke the chin out, you can feel the muscle contraction. That is the suboccipital muscle. Sub means below occiput. We have a lot of research works are going on. And you know, the global trends and developments in the physiotherapy is the theme of our conference. Now, what are the major suboccipital muscles? You see, we have got the obliquus capitis superior, obliquus capitis inferior, rectus capitis posterior major, and rectus capitis posterior minor. These are the 4 major muscles. Out of this, rectus capitis posterior minor is very significant because it is attached to the dura mater. So when it is tight, suboccipital is tight, it will pull the dura mater. Just observe here, when the dura will get pulled, that will affect the venous drainage in the sinuses. You know, sinuses means, you know, the venous sinuses. Otherwise, air cavity sinuses, that sinus I am not talking about. I am talking about the venous sinuses. So inside the cranial cavity, we have the superior sagittal sinus, inferior sagittal sinus, and transverse sinus. So when the suboccipital will get pulled, that is going to create the impede or in the restriction of the transverse sinus, and that can cause also the headaches. So headaches felt due to the involvement in the cervical region are called as cervicogenic headaches. There is a difference between migraine and cervicogenic headaches. Okay, so that I'm just touching some points. That's it. So, but many times people are wrongly diagnosed as migraine. Usually the cervicogenic headache is unilateral. Migraine is like one tsunami which can be originating at any part of the cranial cavity. Right? Okay, please go down. Yes. Just sit down there. I'll call you when required. Thank you. So that's about the cervicogenic headache. More elaborate description. It was first described in 1926 and all. Muscular trigger points, I just explained about that. Another important thing, sternocleidomastoid. There can be sternocleidomastoid trigger point, and that will produce the headache over here. Frontal headaches. Frontal, parietal, temporal, and greater wing of sphenoid junction is called as pterion. So headache is felt at the pterion, and pterion person is coming and telling that I am having some headaches here, neck pain. That is a classical presentation of cervicogenic headache, and due to the trigger point of the sternocleidomastoid muscle. And out of sternocleidomastoid component, it is a sternal component which gets primarily affected. There is a nice book on Travel and Simons. There are 2 volumes of books on trigger points. You can, for the reference, you can take. So talking about the lateral joint involvement, we have the occiput here, occipitoatlantal joint, C1, C2 joint, C1, C2 complex. I was talking about the rectus capitis posterior minor. You can see the rectus capitis posterior minor. I'm just moving the cursor. You can see that arrow, this one, that is the rectus capitis posterior minor muscle attachment to the dura mater. Coming to the cervical facet joints, and you can see the vertebral artery. Something very important we have to remember. If anytime you are applying any cervical manipulative techniques, you must check for the vertebral artery, VBI, vertebrovascular insufficiency. Because there are publications in the literature about the complication of the cervical manipulations, and especially when you have got vertebrovascular insufficiency like dizziness, diplopia, dysarthria, dysphagia, drop attacks. So if any of these presentations are there, so then you can go for mobilizations, especially rotation manipulations, you must not apply because that is quite risky. And you can see the facet joints. Inside the facet, we have got this synovial fat pad due to inappropriate positioning. Sometimes this fat pad comes out of the joint. That causes extra articular entrapment. So what we do is we give gentle mobilizations to put the structure back to its original position. That is something what we do in manual therapy is because every structure has its has its optimum structural and functional position. When it is deviated from its position, that creates the problem. Let us do one small experiment to understand this. Now you all are sitting. Just or whoever are listening to my talk online or offline, you can do a small experiment just to see how the position affects movements. We'll make a neck movement, neck position. You just sit straight and do the abduction of your shoulder. Well, if you do that, it's nice, movement is something very, very important. Brings dynamicity, and dynamicity is the alternative of life. Now, what you do is just slouch, just slouch and do the abduction. Immediately check that. With slouch or neck coming forward, you can see immediately there is a restriction coming in the shoulder joint. Yes. So that is something, posture and the problems. Now, if a person in this slouch position will constantly abduct, over a period of time, there will be a tear of rotator cuff. Right? Somebody may go for rotator cuff repair, but that is not a solution. Even if after repair also, the problem is existing. So that, think globally, act locally is something very, very appropriate for the profession of physiotherapy. So that's about the facet joints. And next you can see the possible source of neck pain. Drawing, you can see the whichever area is affected and how the pain comes and all that. We can see that. This is something one common presentation we will come across. See this presentation. Somebody comes with neck pain, and then you see there is a prominent line or crease, because obviously you have to do the observations. Posterior observation, lateral observation, just to analyze the first in materia medica medicine we read. First thing is the observation before you go for palpation and other examination procedures. If you find there is a crease, many times you will observe above that crease and below that crease there is some kind of swelling. People think that is some fat accumulation. It's not fat accumulation. What has happened is, now in this case, suppose you find out that at C6, C7, suppose there is a crease. Above and below there will be hypomobility or stiffness, and that will cause the neck pain. So what is the aim and objective? Where you have got hypomobility, you have to get back the normal mobility. Each and every vertebra, even if we say grossly, we are existing in 3 dimensions, right? X, Y, and Z. So also each structures, right? If you take one individual vertebra, this is the Y-axis. Around Y-axis, we have got, see, one rotation movement to right, rotation movement to left, translation movement to right, and translation to left. 4 movements. 3 axis, 12 movements. If there is any deviation, that is going to cause the problem. The skilled manual therapist has to identify. Now, let me be more specific. Around Y-axis, C2 is rotated to the right side. The most appropriate thing to do is to give a transverse glide in the transverse plane from right to left. If you apply left to right technique, then the problem is going to escalate. So that's why in definition of manual therapy, the 2 words are very, very important, given by Irwin Kaur in 1978. Manual therapy is accurately determined and specifically directed force. That is something, these 2 words in the definition is one of the classical definition given by Irwin Kaur in 1978. Manual therapy is accurately determined and specifically directed force to correct the dysfunction. Right. So when you observe, you will get at least 40 to 50% of the things, what is the problem and what you are going to do. observations, lateral aspect, then you are going for various movements. You go for the combined movement. Okay, now coming to how to identify if it is a facetal involvement or it is disc involvement. Now for facetal involvement, what you do is, we have something called as the combined movement pattern. We have to differentiate, because in evidence-based practice or in clinical reasoning, what is evidence-based practice? To pinpoint the exact specific diagnosis. That is the aim and objective of the evidence-based practice or clinical. So if you have got a facet involvement, you are going for combined movement. In combined movement, we have got something called as compression pattern. Can you please come? Just sit down here. Yes, so you can just observe here. Suppose I am going for a combined movement compression pattern. The compression pattern will tell me whether it is a facet involvement or not. So what we have to do? Go for extension, side flexion to same side, and rotation to same side. Now I am checking for the right side. Extension, the facets are approximating. Side flexion, it is approximating more further. Rotation, further approximation. So if the joint is incriminated, the pain is going to increase. That is called as compression pattern. Very, very important. Then coming to the stretching pattern, you want to know whether it is a muscular involvement or it is combined. So you have to go for something called a stretching pattern. So for example, right side stretching pattern, flexion, side flexion to left and rotation to left. If the pain is increasing, that confirms periarticular tightness. Of course, we have to differentiate. Is it a muscular or it is capsular? Then we have to go for something Enfield and all. That is more intricate, pathway to identify or detect the problem. Right? Thank you. This is the BPI I was talking about. Then you can go for the transcranial Doppler. I have a video. Just yes. You can see this. This is the transcranial Doppler. Yes. So you can hear the sounds. So this is the transcranial Doppler. In transcranial Doppler, you will identify to what extent there is compromise. There is compromise to the vertebral artery. Like you have got nerve compression, you are doing the NCV. So transcranial Doppler, we can see systolic velocity, diastolic velocity, mid systolic velocity, mid diastolic velocity, amplitude and latency. Now, if the amplitude shoots up, that will tell you that yes, there is compromise to the vertebra. That is a tool of investigation. You are doing a clinical examination, dizziness, diplopia, dysarthria, dysphagia, drop attacks. Then you want confirmation, you can use the transcranial Doppler. So you just saw that, or I just play it once again. This is the transcranial Doppler. I have done a couple of researches using the transcranial Doppler studies of the real time, the vertebral artery blood flow. So that's how in a real time that you can just, the blood pumping is there, and then you can hear the sounds. And further, you can go for something called as PPI VMs. That is the passive physiological intervertebral movements. My mid finger is kept in the interspinal space. Index and ring finger is placed on the facet joint. I am going for flexion, extension, lateral flexion, rotations, and then you see that whether the joint is functioning effectively or not. We go for the lateral PA glides. Just to more specific, that is the next step of we have done observation, combined movements, PPI VMs. We are going for the PI VMs. So when you are palpating the joint and the same pain is felt, you are checking for COC1 joint, and the person is telling that yes, I am getting the same pain for which the person has come. That gives an exact pinpoint diagnosis that COC1 of right side is affected. You are doing that C2, C3 pain, C2, C3 is affected. This is the mobilization techniques, the transverse glides I was just talking about. And this is something very, very useful technique and very safe also. The cervical AP glides. Occiput is supported, pistol grasp, anterior to the mental tuberosity. You go for the barrier and give the glides. So very, very useful for suboccipital muscle tightness, joint involvements, right? So you can Go for that technique. Joint manipulation technique. You can palpate, say you have got involvement of C2, C3 joint. You place the lateral aspect of the index over the articular pillar, take the primary leverage of rotation to opposite side flexion to same side, extension, and apply the thrust towards the opposite side eyeball. So we have to check whether it is upslope restriction is there, downslope restriction is there. So downslope manipulation means we have to apply to the opposite shoulder, and upslope means towards the opposite side eyeball. You have got right side involvement, thrust applied to the opposite side, left side eyeball, or downslope restriction is there to the left side shoulder. So we have the technique in the sitting position also, sitting manipulations. Same primary leverage of rotation to opposite side flexion to same side, rotation. I'm applying the thrust. That was a upslope restriction, applying the thrust towards the opposite side eyeball. And what we require is, as I said, precision and accuracy. You see the exact precision and accuracy. That is something, that exact placement of the structures, whether it is joint or it is muscle, that is what is extremely essential for appropriate functioning. Now, in present times, ergonomics is something very, very important. As for the present work guidelines, world over, any industry, they require the ergonomic evaluation. So I give ergonomic consultancy to so many companies. So also you have to explore, because that is the requirement. So what we have to do, same postural corrections, what exercises they have to do, you have to analyze the workplace. So there is a protocol for anthropometric analysis and workplace evaluation, documentation and planning. Right. So that is, I told about bifocal posture, and there is something in this thing called as upper cross syndrome that also leads to, and I was talking about the trigger points. You see, this is a pincer palpation. This is a pincer palpation to identify, that is the clinical confirmation test to identify the trigger points. So when you palpate, due to intense pain, the person will jump. That is called a jump sign. Jumping means not what you see in dubbed Tamil movies or in movies and all. Due to intense pain, the person may do like this. So that confirms a trigger point. That is the only confirmation, because with ultrasound, MRI, we cannot identify the trigger point. The levator scapula muscle, and another thing, there is something called as tensegrity concept. So I'm just putting some, basically the conferences are meant for sparking. The initial ideas you get the seeds and you go and explore them further. The present times, we have got something called as tensegrity concept. Tension integrity, tensegrity. You see this video stand, that is balance, that is on tensegrity. The building is maintained, tensegrity. This is maintained, tensegrity. Podium, tensegrity. If there is imbalance, it will collapse. You would have seen certain times the buildings collapsing. Some buildings suddenly collapsing. Some structures collapsing. Construction going on, something collapsing. Two important points I'll touch here. Okay. Tension and compression. You have seen the metros, Delhi metro or any metro. You see the bridge or any bridge. Metro, suppose somebody is not aware of metro, maybe listening somewhere. You see the bridge, the pillars of the bridge, that is long and slender structure. Or you see this, the videograph stand, that is long and slender structure. Down that structure is broad. Pillar, down it is broad. Long and slender structures are designed to take the tension. Broad structures are designed to take the compression. So let us see the morphology of some of the muscles. You see the deltoid, large, gluteus maximus, large, meant to take compression. That's why you are comfortably sitting. It's a natural cushion the universe has given us, right? Sternocleidomastoid, sartorius, levator scapula. These are all long and slender muscles. They are meant for tension. So when you are planning prehabilitation and rehabilitation, you have to keep that in mind, whether you have to encourage the compression activities or you have to encourage the tension activities. Same thing with the bones. Femoral shaft, long and slender, designed for taking tension. Condyles, broad and large, designed to take the compression. So those factors we have to keep it in mind. The soft fracture is there. You are doing the rehabilitation. You have to give exercises planning for tension. You are rehabilitating the joint. Condyles are damaged. Compression component, because that is the natural function. So that's about the tensegrity concept and balancing. Right. So you can go for the myofascial release techniques for the trigger points, tightness of muscles. You go for the layering palpation. I have developed, I'll talk about this. I have developed a new grading system in the world in 2007 called as Monte flat palpation. There are so many publications on this. Various layers are palpating because quantification of the fascial dysfunction. You know, joint status, we have joint status Paris grading. Muscle status, we have got MRC grading system. Right? So similarly for the fascia, this is the grading system. Layer 1 is skin, layer 2 subcutaneous tissue, layer 3 superficial muscle, layer 4 deep muscle. And grade 1, adherence of layers 1, 2, 3, 4. Grade 2, adherence of 2, 3, 4. And adherence of 3 and 4. Grade 4, toughness in deep fascia, normal. 5 is normal. I have done already the ultrasonographic analysis of that. So, Manik sir, how much time I have? Can you help me to just find out? I want to be restrict with the time. Right? Okay, fine. Thank you. Thank you. Right. Okay, another thing is that once you have done the mobilizations, you have done the manipulations, then you have to do the core stability. Stability. What is the meaning of core? We think that core stability means it is transversus abdominis and multifidus. No, we have got core stability also for shoulder joint. We have the stability for neck. For any region, you need to have a stability. But core means the. The word core means THED. It means the stability of ankle is called as core of ankle. That's it. That's a terminology. So we can use the pressure biofeedback unit. A lot of researches have been done across the world. A lot of meta-analysis, systematic reviews are also there. This is the we can use that for activating the endurance of the neck muscles. Okay. So there are techniques. I have taken a training for this particular method from Dr. Gondlin Joule. So the pioneer, she is the person who started the biofeedback this thing training, and I was trained under her. So that is quite elaborate. So we have to go for checking at 20 millimeters of mercury, then activate between 20 to 30 millimeters. So there is a procedure completely. So it is difficult to touch on that. Next, I'll touch 2-3 techniques of the low back pain, and I think my 2 minutes are over. 3 more minutes are there. Okay, there is a nice organization called as IASP, where I am one of the part of International Association for Study of Pain. I'm a member, and then I participate in a lot of their activities, and it's one of the very classical organization, very professionally managed. And our IASP classifies the low back pain as pain felt between the T12 transverse process and the sacrococcygeal joint. What is low back pain? Pain in low back. Which is low back area? From where to where is the scope of low back pain? T12 to sacrococcygeal joint, or one upper side on the low back pain. Kindly note. Then what are the main causes of low back pain? Obviously, lumbar region problems and pelvic complex problems. So lumbar region, again, we have got facet problem, disc prolapse. And for pelvis, we have got various dysfunctions like upslips and all. I'll just touch some important aspects of the low back pain, that is disc prolapse. Prime cause for disc prolapse: flexion, compression, and rotation. Somebody, classical history, early morning, somebody bent forward, do brushing, sudden catch is there. Or somebody was trying to lift something, sudden catch. That's the classical history of low back. Flexion is the prime cause. Extension is the remedy. So you have to encourage the extension exercises and mobilizations towards extension. Nucleus pulposus, annulus fibrosus. Okay, so this is how is the classical look of the disc prolapse. You can see here the crack appears in the annulus and the disc prolapses. People think that it is just two-dimensional. No, it is a three-dimensional structure. You see, it has created the depression. You see the extent of that last one, that E, is the severe extent of disc prolapse, where the nucleus pulposus has come out through the crater, right? That is the severe form. This is one of the very famous experiment done by Nakemson et al. Intradiscal pressure is highest when you are bending forward. That is more into the research aspects. Flexion, compression, rotation is the prime cause. And these are the chemicals which can lead to the pain: cytokines, TNF alpha, phospholipase. What to treat? Going for facilitating the extension exercises. You can go for a springing technique. You can put the person on a physio ball and then apply the gliding. This was developed by me in 2007. Then you go for the listings, then correction of listing. You can see this. Can you come? That live streaming is there, no? So it takes little time. So turn. I stand like this, yes, list. So there is a listing like this. Okay, this is a presentation of a disc bulge in the left side, where left side is painful, the person is bending to the right side, listing to the right, scoliosis in the left. Okay, so you go for turn this side, yes. Wide base stance, therapist, support the turn this way. Visibility will be there. Turn this way, yes. So this is the dysfunction presentation. You support the axilla, hold from the pelvis. Pull the pelvis, twist from the axilla. You give a transverse glide and the lateral flexion in the same side and go for extension. Now what it does, you have got a bulge in the left side. You are going for a transverse glide and side bending to the same side. It's a viscoelastic structure. It will get pushed. From the lateral aspect, medially it is getting pushed. Two components. Posterolateral component. We are correcting the lateral component first, then going for extension. Extension will push it anterior. Right? Thank you. One last slide I'll show. These are the procedures, PPIVMs, PIVMs. These are the various axes. Y axis, X and Z. One easy way to remember, because you have seen the graph paper. Put a vertebra in front of a graph paper like this. In graph paper, this is the X. X axis is along the transverse process. Y perpendicular to the vertebral body. If you remember these two, the third one is obviously to the spinous process. So that's one easy way to remember. Y is like this in graph paper, so perpendicular to the vertebral body. X to the spinous process, transverse process, X, and Z through the spinous process. Right? So you can you find out any. Suppose you have got involvement of the L4, L5 facet, then you can go for this facet manipulation, subject in side lying position, and you do the specific palpation. I'm pulling the arm, locating the segment, holding the upper spinous process, then holding the lower spinous process, upper process, applying the force towards the couch, lower spinous process away from the couch. So there will be minute distraction and thrust you apply that, because the space adjustment in the spine is 1 to 2 millimeters. 1 to 2 millimeter this side causes problem. You create that space, pain goes off. Right? Lower cross syndromes, spinal stability, core stability. So I was talking about the tensegrity concept. SI joint involvements. I'll just put one last slide, and core stability training, activating the transverse abdominis and multifidus. Well, this will just, whether you have got any kind of low back pain, after you correct the skeletal component, next you have to correct the active component. Passive, active, and neural component. First, correct the gross one, that is the skeletal component. Second, correct the next one, muscle and the fascia. Third, correct the neural control. Do a small palpation on your abdomen. Right? This is one of my drawing for the core muscle. abdomen, there are three layers. Just tighten it, or you just palpate the innermost layer. Can you feel the hard one, the innermost hard layer? That is the transverse abdominis. So you are trespassing or moving through external oblique, internal oblique, and transverse abdominis. Okay. So there is a Grakovetsky's model. So more elaborate, you want to do research work and all, there is a Grakovetsky's model. Two models are there: Grakovetsky's model and Barteling's model. The Grakovetsky's model is more advanced model, where in the calculation it comes to tan 30. The transverse abdominis standard angulation tan 30, that comes to 0.577 of TL. The force required, because this transverse abdominis, the force is required to stabilize the spine. So when you calculate, the vector calculation is there. When you calculate, that comes to 0.577 of the transverse abdominis force that approximates the spine. If the angulation goes less, when the muscle becomes weak, that muscle is going and getting inserted to the dorsal-lumbar fascia, making 30 degrees angulation. So when the muscle is weak, angulation is reduced. It may go to 15 degrees or 20 degrees. The tan 30, tan 10, tan 15, the value is lower. So the spinal stability reduces. That is why we activate the core. Okay. So there are again two ways to activate the core. One is bracing method, another is talking method. So we usually use the bracing method, is more effective. And sometimes some old photographs of me doing some core stability exercises. Piriformis muscle, the last one. I have got one, this video on YouTube, which is viewed by, I think 5-6 lakhs of viewers are there. This is one of the very popular video in YouTube. You can see that. Piriformis muscle, this is how we are lengthening. Piriformis is a deep muscle. The person complains of pain here, deep into the gluteal region. And when it is tight, it compresses the sciatic nerve, leading to sciatica. Correct? Very small, but significant. Piriformis is an external rotator of the hip joint. So when it is tight, it is going to limit the internal rotation. So while checking, evaluating, we are subject prone lying position, knee flexed, we are checking it for internal rotation of the hip. Now you find out the left side going till this and right side till this. That means right side is tight. Then I'm going for the intervention. How to palpate? You want to palpate your piriformis muscle? You can palpate ASIS to ischial tuberosity, join one line, another line PSIS to GT. That intersecting point is the palpatory landmark for the piriformis muscle, right? And then you saw that, you can further see it in YouTube, right? So one small message by a great personality, Swami Vivekananda: take up one idea, make that one idea your life, think of it, dream of it, live on it, let the brain, muscles, nerves, every part of your body be full of that idea, and just leave every other idea alone. This is the way to success. So you take one single focused idea and take a goal. Make a goal, probably in this conference, some kind of goal you can do. You want to write one article, you want to publish, you want to start your clinic, you want to excel, you want to read more, you want to perform better. Take up one idea and nirantar prayas karna. A constant, persistent effort is something very much essential to achieve the success in life. Success is not a single buggy jump. Success is just one investment every day. I have not understood what is success. I have understood one thing, that I have to work and I have to keep working. Nirantar prayas jari rakhna hai. That's it. So wish you all the very best. So you can just take the website or details, or you can just type my name or anything. You can see a lot of things and details. We conduct regular courses in almost 10 countries in the world, and you can visit our website and see the details. And in this area, Dr. Navneet, he takes care of our courses, but that is a different thing completely. Wish you all the very best and be proud to be physio. Thank you.
Thank you, sir, for such delightful session. Now I request Dr. Mayank Pushkar, sir, to please facilitate Dr. Mashankar Bhavanti, sir. I request Dr. Mohanty sir to please come up on the stage. Can we have a round of applause for sir? Thank you, sir. Thank you, sir. Now to proceed our session, I request Dr. Poonam Mishra ma'am, Senior Physiotherapist, Department of Trauma, All India Institute of Medical Science, to please come up on the stage and chair the session. We welcome you, ma'am. And I request Dr. G. Nikhil Nelson, Consultant Physiotherapist, Nelson Physio and Fitness Center, New Delhi. So please come up on the stage and chair up the session. We welcome you, sir. Thank you, sir. Now I request our next speaker, Dr. Harpreet Singh, Physiotherapist, Department of Neurology, All India Institute of Medical Science, Delhi, to please come up on the stage. We welcome you, sir. Please give a round of applause for sir.
Okay, a very good morning to all, and I thank the organizers of GAPTCon for the invitation, and I'm thankful to all the seniors, my colleagues, and the chairpersons for this session. My talk would be on functional electrical stimulation, especially focusing on the upper extremity rehabilitation in stroke patients. Now, I'm sure that you all must be knowing what stroke is and what happens when a stroke occurs. So we will discuss that stroke is a very disabling condition, and it was thought that it is a disease of old age, that people after 55, 60 years get the stroke. But stroke is also seen very young now, even in 20s and 30s, because of the lifestyle and stress. Stroke has started appearing early in life. And because it is coming early in life, the disability remains with the patient for a longer part of their life. But still, more than 75% of strokes happen because of after 50 years of age. And because it happens after 50 years of age, the reserve in the brain for recovery is less. And that makes the recovery process slow. And with improved medical care, the survival has increased. The rate of survival has increased even for patients who are severely disabled. Therefore, in the society, what we see is more severely disabled patients of stroke surviving and coming for rehabilitation services, trying to be independent in their lives again. But the thing is that the recovery is not only slower, but the care period is also short. We know that because of privatized medical health care, the length of stay in hospital is quite short, and the patients are discharged soon. And because of that early discharge, they do not get enough time for rehabilitation and care within the hospital. Many patients, because of unavailability or other factors in the environment, are unable to continue with rehabilitation and suffer with lifelong disabilities. So we have to understand that it is a very big problem that occurs at a later part of life when the person is about to retire and plans to enjoy and leisure down his life after the age of 50 or 60, after having worked hard for all his life. And that is when the strokes creates that period of disability. Now, after stroke, there is a window of opportunity where recovery can be impacted the most. And that is the acute and the early subacute period after stroke. That is, this is the time that if rehabilitation is given at the right intensity and with the right mindset, the recovery can happen aggressively in the stroke patients. But because of extensive weakness and immobility or patient being bedridden, this phase is often lost. And we do not, or we are not able to give enough intensity of rehabilitation. We must understand that there are a few physiological mechanisms which also work for recovery after stroke, and they are known as the neuroplastic mechanisms. The first is the interhemispheric connections. We have to understand that even if the stroke happens on the right or the left side of the cortex, but due to connections between the right and left cortex, there can be problems and impairments on both sides of the body, and even one side of the cortex can affect recovery from the other side. The present rehabilitation or the conventional practices in rehabilitation are limited to those with some movement. Most of the times, if patients are severely impaired, severely weak, we prescribe the patients passive treatments or waiting for recovery till some movement comes. Whereas patients who are mild or moderately impaired do get a lot of attention and care in rehabilitation. So what happens to these severely affected patients? Now, this is where our focus should be. The patients who are severely impaired are somehow missed by the normal rehabilitation procedures. These are the patients who are unable to activate voluntarily, that results in a prolonged immobility and inactivity. Many times, patients with weakness try to overexert to move. Suppose one side is weak and due to weakness, there is difficulty in movement. Most of the patients would try and overexert. So in that overexertion, what we see are the abnormal components of movement or the synergistic movements and certain compensations which the patient learns very easily, and it becomes the abnormal movements which stay with the patient, which we do not want. For better quality of improvement and outcomes, it is good that rehabilitation starts early, it is intensive, and it also addresses patients with severe impairments. Now, for recovery, there are certain targets of training, and most of them include, research has mentioned that training should be repetitive, goal-oriented, active, and also should give a sensory feedback. Okay, so whenever you are giving a therapy, look for the characteristics. Is it active? Is it goal-oriented? Is it repetitive? And does it provide a sensory feedback? Now, when we talk of this, just think of one modality of electrical stimulation that we give, the neuromuscular electrical stimulation. When you give electrical stimulation, what are we expecting within the patient? Most of the time, we are expecting the muscle to strengthen. But apart from the muscle that is strengthening by electrical stimulation, there are other physiological effects of electrical currents being placed on the human body, and they are sensory feedback that goes to the central nervous system. The muscle changes that happen with electrical current and electrical stimulation. Most often what we neglect are the central effects of electrical currents. That is, the electrical currents, just like any other sensory input, can affect a change in the central nervous system, including the spinal cord and the brain. So this is the reason why we give electrical stimulation to our patients. Now, giving neuromuscular electrical stimulation, if you look at the characteristics, it is repetitive because stimulation happens as a cycle, on and off cycle. So there is repetition. But is the patient active during stimulation? A lot of times, no. So stimulation is given as a passive modality until it is mediated by biofeedback systems. So electrical stimulation is repetitive, passive, does not give an accurate sensory feedback. Okay, so there are drawbacks of using just the neuromuscular electrical stimulation in patients of stroke such that recovery happens. And stimulating a muscle, producing a movement is never goal oriented. So there is no goal attached to the electrical currents. So we have to see that how we can overcome these drawbacks of the conventional electrical stimulation. And one of the ways is the functional electrical stimulation, also known as FES. Now, as the name suggests, it is the electrical stimulation of the motor neurons while performing a functional task. Now, when the patient is performing a functional task while the muscles are electrically stimulated, it gives repetitive, active, goal-oriented, and a sensory feedback of action being completed. Okay, so it checks all the boxes of what is important characteristic of training. Now, these are a few pictures of examples of patients receiving functional electrical stimulation, and you would not see them happening during a normal electrical stimulation session, like use of tools or gadgets while the stimulation is going on. And the patient can coordinate the stimulation with their own effort. That is, when the patient tries to move, the machine can be on or off, rather than a preset time duration of stimulation and rest period. Now, it is an artificial activation of paretic muscles, generally synchronized with task-oriented practice. Now, this is the difference between a normal electrical stimulation and FES. Now, what is more important is that the voluntary effort that the patient exerts, rather than a passive recipient of electrical current, the voluntary effort that the patient creates with that electrical current is of a lot of therapeutic importance, is an important factor in the therapeutic process and recovery. Now, electrical stimulation doesn't go by protocols. You have to do movement analysis of the patient, identify the components that are missing. So, for example, if you look at this picture, in the first picture, asking the patient to lift the hand, there are certain components that are missing, and the patient tries to compensate with something else. So the electrical stimulation is used during the task on the components that are missing. In this picture, you can see anterior deltoid and triceps, because you see the patient abducts in place of substituting it for shoulder flexion, and in place of extension, there is flexion. So we give it from an external source of electrical current. Now, a lot of times you might have seen that stroke patients, although are able to lift the hand, bend the elbow, but are not able to function with the hand, because any function with the hand or the upper extremity requires differentiated movement from the digits from the fingers. And this is especially challenging because after stroke, the main pathways of the corticospinal tract or the primary motor system are impacted, and most of the signals reach the hand by compensatory or substitutive patterns. Now, these pathways are less selective. If you understand what do I mean by less selective is, if I can move two digits simultaneously and not all, this is a selective action. Okay, now this happens only because of the connections of the corticospinal tract. In case of damage to the corticospinal tracts, any other system that allows us to move the fingers are not that selective. So if you ask the patient, you would have seen either they close the hand together or they open the hand together, but selective movement is lost. So when we are doing this, we have to see that how electrical stimulation can affect. Now, what we do is we provide electrical stimulation while the patient is as functional as they can be. So remember that the therapy is not just a combination of isolated things, but we also tend to combine them in such a way that the ultimate task or the goal is accomplished. And this also assumes the importance of the entire body to the movement. If you see in this task, the patient is not asked to lift the hand or to reach for a cup or an object, but asked to weight bear or support the body on the surface. Now, while the arm is supporting, the body tends to move. Okay, so we have to see that functional stimulation can be used in any way, in any manner that is functional for the patient and goal-oriented. Right. So these are a few examples of how upper extremity stimulation can be used. And this is, we have combined functional electrical stimulation with mirror therapy. So adding the effect of one therapy and getting the benefits of another therapy, that is the mirror therapy. Okay. Sorry, just play this video once. So if you see this picture, so the first picture that you see is the affected hand, and on your right is the unaffected hand. And you can see the switch. There's a switch in the board which can be on and off, such that patient can do bilateral symmetrical movements, and that can be facilitated by the feedback of the mirror system. Thank you.
Wonderful presentation by Dr. Harpreet. Any questions from audience? Any doubt? Thank you so much, Harpreet.
Thank you, sir, for your delightful session. Can I have a round of applause for sir? Okay. So the participants of paper presentation, abstract presentation may go down on the ground floor as we are about to start the program. Now I request Dr. Poonam ma'am to please facilitate Dr. Harpreet sir. I request Dr. Harpreet sir to please come up on the stage. Thank you, sir. Thank you, ma'am. Now I would like to invite our next speaker, Dr. Jyoti Dahiya Kataria ma'am, Assistant Professor, School of Physiotherapy, Delhi Pharmaceutical Sciences and Research University. I welcome you, ma'am.
Good morning, everyone. Yeah, good morning, everyone. Today I'm going to talk about the latest rehabilitation protocols which we use for the scapular rehabilitation. So my topic is that, and yeah. So before starting for the rehabilitation protocols, latest protocols which we are using presently, we have to know that scapula is a major bridge between the cervical spine and plays a major role in shoulder pathologies as well as cervical spine pathologies. So here, scapular dyskinesia has a close relationship with the cervical and shoulder pain. As we know, the latest evidence suggests the patient, those who are having impingement symptoms and glenohumeral instability, they always consistently show altered scapular kinematics. So we have to treat the both. We have to, whenever there is any pathology in shoulder, we have to concentrate for scapular positioning and the muscle balance of the scapular muscle as well, along with the shoulder. So the major cause for scapular pathology involves two major components, that is the lack of flexibility, and major and primary concern and components involves the pectoral muscles and the capsular soft tissues and capsulars present towards the glenohumeral joint which supports the structures. And the second component for the causes and the scapular pathology involves the lack of muscle performance. So majorly here, serratus anterior and trapezius, lower fibers of trapezius plays important role when there is any weakness of lower fibers of trapezius, when there is any altered muscle activity or the muscle strength, or there is any changes in timing of the firing of serratus anterior fibers along with upper trapezius, middle trapezius and lower trapezius portions of muscles. So these are the major reasons behind the altered positioning of scapula. So now we come to the rehabilitation. So rehabilitation, it is a holistic approach. Here we have to concentrate in rehabilitation of all the surrounding structures as well, which are related for the major reasons, which are major reasons behind the shoulder pain, cervical pain, and scapular malpositioning. So these are the basic idea, and these are the 5 components which we work together and which involves presently for the rehabilitation of scapular pathologies. First one is kinetic chain activation. So presently these days we work in this pattern. We have to focus on the facilitation of kinetic chain amongst our patients. Then we have to train in sports specific and activity specific patterns. So yes, as per the requirement of the patients, what is the requirement, whether it's a sports person or it's a normal housewife. So accordingly, we have to manage and devise the rehabilitation protocol. And then third comes the scapular functional training, which is also known as SFT. Here the functional activities, we have to focus more on the functional activities. So the requirement, again, as per the requirement of the patient, but yes, we have a certain few daily basis requirements which we have to incorporate in all our rehabilitation exercises. Fourth one is corrective strengthening program. Here we have to target the positioning of scapula. So we have to correct the positioning if there is any alteration in scapular resting position. And fifth is your supporting devices. So we can use the taping techniques or some kind of corsets which are now present for the correction and for the facilitation of correct positioning. Okay. What's happening? Next. Okay, So here the restoration of scapular muscle force, which I just said that we have to target, we have to initiate with the firing and kinetic chain pattern. So we have to focus accordingly. We have to focus on core muscle strengthening. Here, when we are talking about the scapular rehabilitation, but there we have to focus on core muscle strengthening programs as well. We have to strengthen the core muscle, lower limb muscle, so that the execution of any overhead activities is easier for the person. Rehabilitation of scapular dyskinesis should include the kinetic chain. As I said, this aspect of the rehabilitation may be started early, and the involvement of lower limb, back muscles, trunk flexibility, and strength should be normalized. So we have to initially focus on not only scapular muscles, we have to focus on core muscles as well. We have to train lower limb as well. So whenever there's a patient or a sports person who has work of overhead activities or racket sport, so they need a kinetic chain activation so that the involvement and scapular pathologies will be able to reduce. So these are the exercises which are involved in the kinetic chain activation. The low row trunk extension and scapular retraction exercises. These are the first one which we have to initiate, followed by scapular clock exercises. Then we have humeral head depression and rotation movements, followed by wall washes. These are the certain patterns, certain exercises which we use for the scapular rehabilitation. Also, we advise our patients and sports persons to perform such movements as a home exercise program. Then we have punches. So punch in and punch out motion is also helps in facilitation of scapular retraction, and then closed chain scapular control exercises. So these are the basic kinetic chain pattern which we have to focus. So this one is a low row trunk extension. Here we just have to ask our patient or the sports person just to retract the shoulder or retract the scapula, and then they may sit or stand basically along the couch or a table, and then they are asked to just retract the scapula or squeeze the scapula. This is scapular clock. So here you can see in 12 o'clock pattern, in 9 o'clock pattern, and at 3 o'clock pattern. So these are the three patterns which we use for the facilitation and activation of scapular muscle. Then these are the certain movements which we ask our patient as a wall wash. This is closed chain scapular control exercises. These are the progression, and once the patient is comfortable and there's no pain and patient is fine and able to execute the closed chain exercises, then we can come forward with the closed chain movements. Second is training in sports specific and activity specific. So requirement of a patient is dependent on various factors. There are patients, those who are involved in sports, so they may require a vigorous and rigorous exercise regimes. And there are patients, those with old age and someone who is not working physically much, so their requirement is different. So accordingly, we have to plan our rehabilitation program. So activation is facilitated when the scapula is placed in retracted position. So basically, because of our work posture, most of us are having rounded shoulder and forward head or forward neck posture. So we tend to exercise, or we tend to practice more of retracted exercises, and we ask our patient to do a lot of retraction movements. So here we start with the retraction movements, which involves the facilitation and activation of serratus anterior muscle and lower trapezius activation, which stabilize the retraction movement of scapula. So that we need to do. As per latest evidence also, it is suggested that we need to focus more on lower trapezius and serratus anterior muscles. So these are the 3 phases where we have to focus as per the sport specific pattern. So phase 1, it involves the standing, low load and low activity exercises and low activation movements. So we don't, when the patient comes to us, so we don't force patient to do very vigorous movements or very vigorous or rigorous exercises. It involves only the positioning. So it involves only the positioning of the scapula. Phase 2 involves to further, once the symptoms are subsided, then we can progress towards the prone line and sideline exercises. And third one involves, that is phase 3, we can start with weight training. So the movement, the exercises which we are performing earlier, now we can perform with the weights. So with the help of any resisted exercises like therabands or some weights we can perform, we may ask our patients to do that. Then comes the scapular functional training, which is SFT. So it is a 10-week interventional program. Early in this program, in first few weeks, the exercise intensity is very high. And once the patient is accommodated according to the exercises, then we go for the endurance training. So the intensity is getting lowered, but we have to increase the timing of the exercises. So this is the basic idea of scapular functional training program. As I said, the first 5-week participants perform the aggressive scapular strengthening with the optimal rest time. And then the last week exercise will be alternation in the superset fashion according to the comfort of the patient. And once the patient is accommodated with the exercise regime, then we can further progress to the resisted exercises. Fourth one is the corrective strengthening program. It is devised by Cools et al. And it majorly focus on all the causative factors. What are the causes leading to the pathology? So we are here to correct all the causes. So here we have to focus to regain the normal flexibility of the scapular muscle. Manual therapy, or with the help of stretching exercises, or with the help of normal muscle releases, we can involve this. Then comes the motor control strengthening program, which is further followed by the dynamic control in order to restore the muscle balance. And final emphasis is on scapular muscle strengthening. As I said, it is the major thing. We have to strengthen scapular muscle whenever there is any pathology which is related to a shoulder, because most of the time they both are in combination. So we need to rehabilitate both your scapula as well as your shoulder. So this was the our fourth rehab program. So these are the further divided into 3 phases. So first phase, there is initiation and firing of scapular muscles. Phase 2, it focuses more on the overhead activities. So when patient comes to us, they majorly tell that we are not able to lift their hand. They're having difficulty in, if there's a sports person, they'll tell they're having difficulty in playing racket sports or doing any kind of overhead movements. So in second phase, we have to focus on all those patterns. And third phase, advanced scapular exercises. It further involves the closed chain pattern. So closed chain mostly we use in rehabilitation in the last phases. Okay. So this is the corrective strengthening program, which consists of 3 phases. Okay, so phase 1, these are the 2 exercises, 2 sets of exercises, the basic exercises which we involve, the isometric ones and the isotonic. So isometric, these 3 main movements or 3 patterns we involve in the rehabilitation. And isotonic, these are the 5 patterns and 5 components of exercises we involve for the rehabilitation of scapular muscle pathologies. This is not working actually properly. Okay, so this is phase 1, the isometric exercises, as I said. So these are simple 3 exercises which we ask our patients to perform. We initially, sometimes patient won't be able to get the correct method of performing the exercises. So we have to ask and we have to demonstrate the movements, and we have to show the movements to the patient, and accordingly, these are the basic exercises we have to ask. For 3 seconds, they have to maintain the position, and then they have to come back to the normal position. So scapular pinches, robbery pinch, and low row wall isometrics. So these are the retraction. We are facilitating the retraction movements here. These are the exercises of isotonic exercises. Here we can use therabands, we can use weights, we can use different kind of handcuffs for the movements and for the exercises. So scapular pinches using therabands, low row therabands, and dynamic hugs. So all these exercises helps in positioning and training and rehabilitation of scapular muscles. These are the seated rows, these are the high rows, and the Swiss ball robbery. We can perform the exercises in prone position. Then further we can progress to the different base of support and different kind of bases. So we can further progress to the gym ball or Swiss ball for the activation of the muscles. Plus we can, here in this position, there is activation of core muscle, which I said in the first phase. So we here the core muscles are also getting activated and facilitated. So we can involve such movements and pattern for the scapular retraction pattern as well. Then comes the manually resisted scapular strengthening program. These are the exercises further we can use in the rehab setups. So as we say, rehab should not be a monotonous program. It should be having, it should have different variations. So we can go for strengthening with the help of therabands, with the help of weights, with the help of closed chain exercises, plus the manual therapy where we can give the manual resistance. So these are the basic things which we use for the strengthening of scapular muscle. The phase 3 here, these are the certain patterns, certain exercises which we involve in phase 3. Here we are going to be more aggressive in the rehabilitation. We have to be using various kind of different loads. That is the super 6 pattern, standing cable column punches, bear crawl on Swiss ball, plyo balls, deceleration, seated pike lift, and standing snow angel movements. So these are the basic ideas which we use in the rehab program, in the rehab setup. So you may use any of the rehab program depending on the condition of the patient. These are the different patterns which we use. In plyo ball, the subject is kneeling and they have been thrown a ball from behind. They just have to hold it and grab it. These are the seated pike lift. Using different kind of dumbbells, patient is asked to place the hand and they just have to hold and lift the buttock off the table or the floor and hold it for certain seconds. And this is back. So this is the standing snow angel. So these are the exercises. You just have to hold the position. You just have to hold the position. You have to abduct the upper limb, upper arm, and you have to hold it for a certain seconds. And this movement, you can use therabands. This movement, you can use weight cups. You can use the weights, different weights, depending on the requirement of the patient. This is the last phase. This is the last component of the rehabilitation where we use various kind of supportive devices. So presently we have certain kind of clothing patterns where there is a retraction. These are the corsets which is utilized by the rehabilitation program where this corset, this will maintain the scapula in a retracted manner. So that is one thing which we can use. This is scapular taping. Yes. Scapular taping, we have certain evidence that the taping, if being done in earlier phases of any pathology, it will definitely help the patient for the further progression of the injury or pathology. Now, the recent or latest evidences which we have for the scapular rehab program. So there's a study where they just found whether the scapular taping facilitate or recovery of shoulder impingement symptoms. So the result shows of this pilot study suggests there's a short-term role of scapular taping as an adjunctive treatment in the management of shoulder impingement problem. So yes, if there is any patient who is having shoulder impingement, and then if the patient is being treated earlier with the help of scapular taping, so it will be helpful for the patient to prevent the symptoms plus to further progression of the patient. It is very helpful. Second is there's another study where upper and lower trapezius muscle activity was studied in subject with subacromial impingement symptoms. So they have studied whether this imbalance or this problem can be taping be effective. So this subacromial impingement symptoms are associated with altered upper and lower trapezius muscle activity. So yes, once if we target these muscles, so we'll be able to prevent subacromial impingement or will be able to rehabilitate appropriately subacromial impingement patients. Here they studied the rigid and elastic taping changes in scapular kinematics and pain in subjects with shoulder impingement syndrome. It was an experimental study. So they compared both the techniques and they observed that both the techniques had an effect on scapular kinematics and pain in movements occurring in sagittal plane. So the results were positive, and it was advised to these if taping being done on earlier phases, then we can benefit the patients. Here also upward taping was done on patients of shoulder pain and those who are having pathologies in upward and downward rotation patterns. So here also it was studied that the scapular training and the scapular taping is very beneficial to the patients. Then this was the current concept in the throwing shoulder pain they have studied. So they have studied that kinetic chain pattern is very beneficial for the patient, those who are having shoulder pathologies. So we should focus on kinetic chain activation also in our rehabilitation programs and protocols. And this was a study where the scapular dyskinesia was studied with the help of Botox. So yes, there is another latest thing in scapular rehabilitation, though Botox has been used in various rehabilitation in neurological patients, in children's, but in scapular rehabilitation. So this is also studied that whether the Botox helps in scapular pathologies or not. So it was shown that the results shown that it is very beneficial to the patients. Thank you.
Thank you, ma'am. It was indeed very informative session. Now I request Dr. Nelson to please facilitate Dr. Jyoti, ma'am. I request Dr. Jyoti, ma'am, to please come up on the stage. Thank you, sir. Thank you, ma'am. I request all the participants who are presenting paper, please go downstairs. I request all the participants of this paper presentation to please go on downstairs. Now I invite our next speaker, Dr. Prakash Mishra, sir, Director, Neuron Physiotherapy and Rehabilitation Center, Delhi.
Hello, everyone. Yeah, I'm very thankful for the organizing committee to organize this such a way, like it's a very nice. And today I'm going to present on the soft tissue manipulation because now I had seen, is it good? Like everyone can audible? Yeah. So in this Corona period and all, like most of the people, they are working at home. They're working at home. Even like I had seen from last 2 years, near about 2 years, I'm in India, and I had seen before that I was working for the UNDP. So I had seen like small kids, they are coming with the problem of neck pain, back pain. Small kids, they are playing, but what happened? Why they are coming with these problems? So what was the reason? So I find out mostly they are like they are not doing physical activity. They are simply studying and whatever activity they are doing on the mobile. So they found like I had seen like these things. So I thought like this is a very good techniques. So which you can apply for the soft tissue. So before that, like briefly, I can go for like how this soft tissue manipulation has come. So soft tissue manipulation, it's like before that we was using massage technique. So massage, can anyone say, please, like anyone can say like massage word has come from where? What is the meaning of massage before that? Like anyone can say, please? Did you heard? Did you heard about like Masa, the like Arabic word? Some people they are saying Sanskrit word. Some people they are saying it's come from the Arabic word Masa. So I think some Muslim friends are there. They are using like Masa Allah. Yeah, Masa Allah means what is the meaning of Masa Allah? Yes, MTH, can you tell me? Yes. Yeah, beautiful. Like touch is very comfortable, good. So that is masa. Masa means like, so when you are touching, the patient will feel comfortable, relaxed. That is massage. So we'll go for next slide. Yeah. So before that, what is soft tissue manipulation? It's art of hand. We are rubbing. We are doing activity like rubbing, applying pressure on the body. So that is, so, and it is more or less therapy or treatment purpose. Treatment purpose, and it's involved the stimulus pressure of the soft tissue. So this is the like introduction of soft tissue manipulation. So now we have to go like what are the techniques we are using in this soft tissue manipulation. So here these are the technique we are using. Instead of like nowadays we are using myofascial release, trigger point release, all these techniques we are using for this. So here variations we are using like stroking. You people are knowing about stroking. Stroking means like just touch. So I think I don't have much time, otherwise I can show on the like client also. It's a very good. So stroking is two type. Superficial, when we are touching, when we are initiating, that is superficial, and deep is, we are saying in another medical thing like effleurage. Effleurage, same like effleurage. Effleurage means like we are draining on the lymphatic or wherever like. So these two things here, sorry, they had changed, just previous slide. And then pressure manipulation. In the pressure manipulation, we have to go for kneading. Kneading is also palmar kneading. Then digital kneading, we are using thumb, finger, yeah. Then ironing. Ironing means like where the area is more, we are doing like, if the soft tissue is hard, we are using ironing like this. So see here, pressure by another finger on that. Then another way like we can use in this way also. Nowadays, if the area is very hard, not for the neck, I'm going to deal here with the neck, but on the gluteal back, we can use the elbow also. So different thing like, so here mostly I'm going for head and neck. So this is the things, ironing. Then petrissage is picking up. Picking up is mostly we are using two types. One is C shape and one is V shape. V shape here and C shape is round shape like this. Then picking up, then ringing. Ringing means like we pick up and twist. Means we can release the things. We can pick up, release, then leave it. So ringing, rolling, skin rolling, and tissue rolling. Yeah. So we can start and just do rolling and then leave. Then friction massage, again two type, circular friction and transverse friction. So we are using like, so that depend on the area where we are using. So according to that, we have to give pressure from the thumb, finger, So the percussion. So percussion is, we are using clapping, hacking, taping. Tapping is like finger. Yeah. Then beating, then pounding, then tenting is 3 finger we will use and just do it like. So these are the things. And then vibratory is vibration and shaking. Shaking for the muscle also, not for the only for the lung. No, we can do the shaking here also. Is it? So next slide. Mostly we are going through this area, neck, and so here my topic is on the neck and the headache. So these are the mostly area we are going to deal. So just you can briefly, I cannot deal like all the things because time is not there. So please next slide. So here soft tissue manipulation. Soft tissue manipulation for the neck and headache. So in which condition, like what is this? Neck pain and headache can be caused by trauma, injury, poor sleeping posture, poor posture, prolonged use of computer or anything. So poor ergonomics. So these are the like things in which condition we can use. And pain can range mild to a severe burning feeling if untreated. If it is untreated, mostly you will see the muscle spasm is very common. So next slide, please. Next slide. Indications. In which condition we have to go? First one is torticollis. Second one, torticollis is, you know, like, so I think you people are friendly. In this, you have to take care. It's a functional torticollis, not a structural. We can go for functional torticollis, not a structural. Then neck stiffness. This is a very common conditions. Nowadays, most of the patient, they are coming with this. So neck stiffness, limited range of motion. You will see like most of the patient, they are coming and they're saying, I cannot bend my neck. Neck ko ghumane mein dard ho raha hai. So they are saying, so this technique is very used for that kind of patients. And rhinic, you know this condition, and cervicogenic headache. Next slide. So these in this condition, contraindications. In this condition, we cannot go for that. For example, edema. If there is a swelling, we don't know what is the reason for the swelling. We cannot go edema. So next is severe cervical herniation, grade 3 herniation. So we cannot go for that. So like treatment procedure, how we can go. So treatment procedure. So like in comfortable position, you can make the patient lie down, in which patient can breathe properly. So don't make like patient nose is aise band ho gaya, you are giving. So don't. So most comfortable position you can keep. One is on the diaphragm, another is on the abdomen, and then one side bend the neck. Then you will start this side. When the patient will bend this side, you can do this side. So that is a very good. Otherwise, nowadays couch are very good. So you can keep in that position, and then you can do one by one side. Then in that, so I told you about that, and then first of all, like we have to spread the lotion or lubrication wear on that part of that. So here, what all the muscles we have to start first? So we can start with the trapezius, pectoralis major, shoulder muscles, upper trapezius, and posterior neck region. Posterior neck region. So we have to like put a lubrication and just here this area exposed, and we can start with this and just then effleurage means deep stroking. We can go start from the posterior neck area. Posterior neck area. From the posterior neck area, then superior angle of the scapula. Superior angle of the scapula we can take, and we have to see the scapular up to the occipital ridge. You know about occipital ridge? Huh? occipital ridge where the occipital and the cervical spines are meet, like on that. So that area we have to then gentle place neck onto the overlap hand and perform gentle side to side rowing motion. So we can lift up and just do side to side. So muscle will relax, then we can proceed. So rotate head first we'll do on the left side. So rotate head to the opposite side and then effleurage on the right side of the neck using long stroke. So long stroke here we can take and just drain this area. So Patricia's, I told you, Patricia's, you remember? Picking up. Yeah, picking up, V shape we can do. Here, we can do the wiki like this and just go for that. We can release all the thing and then return on the neutral position. Then we will make on the neutral position. In this, one thing is also important. Where is the trigger point? You will check it out. You know about the trigger point. So we will release by the trigger point release method, TPR. Okay, so we can release the trigger point and then we will do effleurage again. Yeah, then the same thing we can do till C7 and then we can take it up to the occipital ridge. Next slide, please. The repeat the same thing on the opposite side, then perform with the friction. Then we can go for friction. We can just use our both the finger and just release by this, and then we can see all the area where the area is stiff. We can release by the friction. Then we can go for again effleurage. Then work on the active trigger point, what I told you. So trigger point, you know how to give trigger point. So just we have to see the area, we'll press it for a few seconds and then just release it. Trigger point release. So we can go for that and then work. Next slide. Next slide. So this, and before that, you will see the patient like neck muscle. You can check the range of the muscle. Yeah, sorry, range of the motion of the joint and see all the things. If it is needed, we'll give more these things, and you will see the tremendous result. I've seen like now most of the patients they are coming, they're saying again you have to do that. I am suffering from this problem again. So that is the thing, like they are not doing the exercise, they are in poor posture. So these are the things like, so I think these are the very good technique you people can use. And just I got very briefly because time was very less. So I just gone through the briefly of this. And I think before manipulation, what you have to do, how you will make yourself relax. Okay? So you have to stretch all the body part, especially your hand. So what exercise you have to do that is also important. See, so we can go. So there is a, when I was in like Ethiopia, I was teaching. So that time, those people, they don't know, like they are saying namaste, namaste. But namaste, why we are doing namaste? What is the importance of this? So here, when you are doing namaste, you see, everyone can do it. Like just feel, when you are doing the namaste, what are the muscles are getting a stretch? You can feel. When you are doing like this, what happened? So same thing in namaste, you can do this exercise. You can do this exercise. Yeah. Then you can here. So all the muscles, upper limb and hand muscle will get a stretch if you will think like that. So any questions you can ask? Huh?
Very good presentation by Dr. Prakash Kumar Mishra. in this COVID era is very informative for all the physios. They should use these techniques to relax your patients, small kids, young teenagers. They're coming to us for cervical problems. It was very good. Thank you, sir. Thank you so much.
Thank you, sir, for such informative session. Now I would like to request Dr. Poonam ma'am to please facilitate Dr. Prakash, sir. So please come up on the stage. Thank you, sir. Thank you, ma'am. Thank you, sir. Thank you, ma'am. Now I would like to call our next speaker, Dr. Richa Gupta. She is a very renowned clinician and managing director at Align Body Physiotherapy Clinic. And today she is going to talk about role of lumbosacral alignment in low back pain. I welcome you, ma'am.
Thank you so much for this invitation and giving me a platform to just help you all in a small lecture. And this will be an interactive one. Wake up, everyone. Anji. First of all, I would like to give a small introduction about me. I'm Dr. Richa. I'm the owner of Align Body Physiotherapy Clinic. It's in Jagriti Enclave. And I'm having an experience of 12 years. I did my master's in physiotherapy orthopedics and did my modified chiropractic alignment things from USA and Thailand from Dr. Robbie Goodrum. And it has been a wonderful, I should say, that experience which I'm performing on my patients and getting wonderful results. So I just want to deliver it with you, and I want you to apply on your patients and get again a wonderful results. The patients having pains and disc problem, thank you. Mainly these are very much helpful in the patients having disc problems. So in this era, everyone is having a discal problem, and the doctors ask them for surgeries, and with these techniques we can cure the surgeries, and this makes ourselves different from other physios and other doctors. So if you want to stand different from everyone, you should go for alignments of your sacrum, of your ilium, of your lumbar spine, and of course whole spine, obviously. But this platform is just giving me 15 minutes, so I won't be giving everything in one go. Let's have our topic on role of lumbosacral alignment in low back ache. Sab khade ho jao. I just want everyone to stand and touch their toes. Many of you will be able to perform it easily, and many of you must be having problem in bending or getting up, right? And we need to rule out why. See, assessment is the most important thing. Treatment to puri duniya kar deti hai. Main is assessment. If your assessment is right, then your treatment will be right. But if your assessment is wrong, you cannot give a right treatment to them, and the patient cannot get a good result. Right? So assessment plays a very, very big role in the treatment. So आपने कुछ देखा होगा, please be seated. मैंने बस ये इसलिए किया जिससे आप लोग सब उठ जाएं, आंखें खोल लें. Right? So you must have seen अभी अपने आप में, I will be taking Hindi and English both, right? आपने बेंड किया, कुछ लोगों को बेंडिंग में प्रॉब्लम आई और कुछ लोगों को खड़े होने में प्रॉब्लम आई. Am I right? And here everything is different. जब आप बेंड किया, जिनको बेंडिंग में प्रॉब्लम आई, आप क्या सोच सकते हैं, क्या हो सकता है? Maybe hamstring tightness, or there is lumbar restriction, or your pelvis is posteriorly stuck, yeah, or your muscles are tight, your hamstrings are tight, and the patients, I mean, you people, when you are getting up, and those who are having problem in getting up, उनको क्या हो सकता है? कोर मसल वीक हो सकती है, और sacroiliitis is a very big term. No, I mean at this platform, what is sacroiliitis? फिर वो दूसरा उसमें चला जाएगा, उसमें तो inflammation हो गई joint में, right? और क्या हो सकता है? Glutes weakness हो सकती है, और क्या हो सकता है? हमारा pelvis may be anteriorly stuck, yeah? So we need to align that. Or your iliopsoas is tight. Right now, Dr. Prakash has told you how to release the muscles, and muscle releases plays a very, very big role. आपने align तो कर दिया, alignment के बाद you need to maintain that alignment. How these alignment will be maintained? Of course, we will have to go for MFRs. We need to go for rehab, good rehab. Then only that alignment will be maintained, right? Yes. So this is a small anatomy that we do have a 5 lumbar vertebrae, then 2 pelvic bones, sacrum and coccyx. And lumbopelvic rhythm again plays a very important role. Like in shoulder, you have heard about glenohumeral rhythm. 120 डिग्री हमारा glenohumeral joint में work होता है, उसके बाद scapular movement होती है, and there is a clavicle rotations, right? Same way, when we bend, there is a coordination between the lumbar spine and the pelvis. So when we bend, there is 45 degree of flexion movement in lumbar region and 60-degree movement of pelvis. See, the pelvis playing a so important role. हमारा 45 degree केवल lumbar movement हो रही है, and 60 degrees of movement is of pelvis. I'm sorry. And when we come back, there is first of all rotation of the pelvis, and then we have a lumbar movement. We do have a small video. I don't think it will be working. I'm sorry. Never mind. I told you, when we bend, we have 45 degree of lumbar movement and then 60 degrees of pelvic movement. And in patients, जिनको problem आ रही है bending में, there may be straightening of the lumbar region and more of the pelvic movement. So we need to align what? Maybe the sacrum is stuck. Yes, one more thing. Maybe sacrum is stuck posteriorly or anteriorly. क्या होगा? Bending में movement आ रही, restriction आ रही है. There is posterior or counter nutation of the sacrum. We must have studied in our 4th year in our physiotherapy bachelor's. There is a nutation and counter nutation of sacrum. Yes. So nutation, what is nutation? The sacrum is stuck anteriorly. This is nutation. And what is counter nutation? The sacrum is stuck posteriorly. So here we are to align it. And first of all, we need to see, we need to assess that what and how the rotation of pelvis is there. What is the alignment of our sacrum? If it is posteriorly stuck, we need to do it anterior. If it is anteriorly stuck, we have to do posterior. Am I right? Yes. So can I have one volunteer here? कोई भी आ जाओ, एक जिसको कमर में दर्द हो ना हो चलेगा, कुछ भी चलेगा. Just come up fast. We don't have much time. जल्दी आ जाओ यार, कोई भी आ जाओ. शर्मा क्यों रहे हो? Thank you so very much. Your good name?
Okay. Dr. Simple Batra.
Simple.
SIMPLE.
Oh. Her name is simple, but the technique is not simple. Yeah. Can you please remove your coat? Let's see what is her alignment and what we need to do on her. It's all clinical. Again and again, I'm telling you, this is a very, very good technique to apply on patients having low back pain. And you know, these low back pain, these alignments can even reduce the radiating pains, or what we say, sciatica. Sciatica could be because of many reasons. So we need to, when we align the bones and the patient says, at the same moment patient says, मैडम बहुत आराम लग रहा है, बहुत हल्का फील हो रहा है पैर में से, दर्द भी बहुत कम हो गया, झंझनाहट कम हो गई. You know, so please be here and see the technique and the assessment first. She has an anterior sacrum. It's just the skills, because I'm practicing it from past 4 years. Can you please bend? Can you please bend and touch your toes without bending your knees? See, you cannot touch more. Bend more. Any pain, or you need you find some stretch over your hamstring? Okay, you please get up. In getting up, do you feel any pain? No. While bending, you felt pain. Yeah, in hamstring muscle. Hamstring muscle tight है तो क्या हो सकता है? Hamstring muscle जब tight होगी, can you please turn? Stand straight. जब hamstring tight होगी, your pelvis will be moved posteriorly. Yeah, so we need to work on posterior tilting of pelvis into the anterior ones. And of course, when there is posterior pelvis, what will be the sacrum? It will be opposite. So it will be anterior. So what we need to do? We need to make the sacrum posterior, and we need to make the pelvis anterior. Am I right? And again, then we need to release the muscles. We need to strengthen the opposite muscle. Only the alignment will not help until and unless you do the muscle balancing, because here there is a lot of muscle imbalance. Can you please come up here in a prone lying position? Yeah, just be comfortable. I know this is not a good platform. I mean, not a soft mattress or something. I'll be aligning her posterior pelvis into the anterior. See, we need to see which leg is short and long, and which pelvis is posterior, which is anterior. So let me check once. Should I remove my shoes? Yes, please. Thank you. Can you put your hands just beneath your forehead, please? Thank you. Her left pelvis is posterior, so I'm going to align the left posterior pelvis into the anterior. So this is the technique. But if I come up here, you won't be able to see. I'll be aligning over the right side. Yes, definitely later on I'll do the correction of the left side. When we are doing the anterior pelvis, which is posterior, I need to stuck my hand, my forearm, my thenar eminence over the iliac crest and other hand over the ischium and make it anterior with a vector anterior lateral and towards the floor. And this is how I do. Okay. There is a popping of joint as well. I won't be showing you that because this is not the correct. If I show you and you perform on any of the patient and the patient, maybe the patient's pain aggravates. So this is very, very simple and very safe technique you can perform. Yeah. And this is how we can go for the alignment of the pelvis. And I told you when there is a posterior tilting of the pelvis, the sacrum will be anterior. Yeah. So what we need to do? We need to make the sacrum posterior. So my thumb will be over the S2 level. It will drag down. It will drag down and the other hand will be reinforcing it. And I will do, my pressure will be like this because I want to make the anterior sacrum to the posterior ones. Yeah. So this is how we need to correct our sacrum, our pelvis. If the patient complains of pain over the same side, it could be same side or the opposite side. You need to rule out that. Thank you so very much, Simple Ji. And with this, I told you what all treatments we can inculcate with this alignment. We need to go for MFR. We can go for strengthening of the muscle imbalanced, the weak muscle. We need to strengthen it and we need to stretch the tightened muscles. That's it for today. And I hope you love this session. Thank you so very much. Any questions, any queries, I'm ready to help you. Yeah, sure. Sorry. See, when she was bending, I asked, is there any pain while bent? So she said there is a stretch on my hamstring, right? And there is no pain when she was getting up. So the hamstring muscle was tight. When the hamstring is tight, what will happen? The pelvis will be stretched posteriorly because muscle tight हो रही है, वो अपनी तरफ खींचेगी. So what we are going to do? We need to do anterior tilting of the pelvis. And we know that if the pelvis is posterior, sacrum will be anterior, definitely. So what we need to do? We need to align the sacrum into posterior. That's it. You're most welcome. Up slip and down slip. See, in that case, we need to release the QL. When there is an upslip, what does that mean? Your QL is tight. So you need to release the QL muscle and you need to align the sacrum and the pelvis downwards. In that case, the technique is different. We need to push the sacrum and opposite side ischium, we need to shift it up and pull the leg. This is a different technique which we cannot come up here just in 15 minutes. But you need to release the QL and stretch the QL muscle. Yeah. Yeah. Anything? Anyone? Thank you so much.
Thank you, Richa. It was
Pleasure
nice.
is all mine, ma'am.
I think you should take a long workshop for these students.
Anytime, anytime.
Then they will have a lot of doubts and you can clear them.
Yeah, of course.
We have short time here. Thank you. Thank you so much. It was very good.
Thank you so much, Dr. Richa ma'am, for such enthusiastic and informative session. Now I request Dr. Nelson sir to please facilitate Dr. Richa. I request Dr. Richa ma'am to please come up on the stage. Thank you, sir. Thank you, ma'am. To begin the session, may I please request Dr. Sanjay Bhaskar, sir, a very renowned clinician from Ghaziabad, to please come up on the stage and chair the session, sir, please. We welcome you, sir. Please welcome, sir, with big round of applause. Now I would like to call our next speaker, Dr. Poonam Mishra, ma'am. She's a renowned physiotherapist in Trauma Center, All India Institute of Medical Science, Delhi. And today, ma'am is going to talk about women health and physiotherapy. So delegates, are you enjoying the sessions? Great. Please welcome Dr. Poonam Mishra, ma'am.
मैडम भाई आप हाँ
Very good morning to all. First of all, I want to thank all the organizing committee to give me this chance to speak on this topic. I'm going to speak on women health and physiotherapy. A physiotherapist play a key role in women problems which we are facing today, day by day. I'll say nowadays women are likely than men to report their stress levels are on rise. Almost half of all women surveyed said their stress has increased over the past 5 years compared to 4 in 10 men. This is Association of Psychology Association of America. They have did this survey in 2019 and they found the women are over the past 5 years, they are more stressful than the men in the society. Women's role often include family obligations, caregiver for children, and elderly parents. Oftentimes, women spend more time meeting their needs to others rather than nurturing their own. What happens? The hormone is cortisol that this is a stress hormone that affects our body in a different manner. If we are facing stress each and every day, our immune system will decrease, our metabolism will be affected, we can get depressed, hypertension will be there, and chronic fatigue and sleep apnea will be there. We can feel tunnel vision will be there, hostility, and we may go to the arthritis. Now, what physiotherapists can do for a woman? We work in different kind of field. We work in obs and gynae, in antenatal, postnatal. We also deal the problem which occurs during antenatal, musculoskeletal pains, osteoporosis, breast surgeries, lymphedema, education, and we have to educate the antenatal in antenatal era of the female, and we all female across the lifespan, from young athlete, the childbearing women, the menopausal and elderly women receive benefit from physical therapy. Now, what are the field which we can, what are the problems which can deal with pelvic floor dysfunction, diastasis recti, posture-related back pain, sacroiliac and pelvic girdle pain, varicose veins, joint laxity, osteoporosis, nerve compression, lymphedema, and the most latest problem which come occurring in the society with females, young females, that is PCOS. Now I'm going to tell you about some small things about each and every part where we can work, because lack of time, I can only aware you with small what we can do, but I have tried to cover every topic. Antenatal care, purpose of antenatal exercises basically prevent low back pain and enhancing physical and psychological preparation for delivery by means of joint stretching and muscle strengthening. Guideline for antenatal exercises may begin when pregnancy reaches to 16 to 20 weeks. Now we have to work on certain specific muscles. We have to stabilize pelvic, as Richa said, by working on gluteus medius and maximus, and prime spinal stabilizer muscles, that is transverse abdominis and lumbar multifidus and pelvic floor muscles. How we work during this time, breathe, we have to teach women with breathe smoothly, exercise gradually according to your capability, twice or thrice a day, repeat each sets of movements. Low impact aerobics, the emphasis is on maintaining the fitness level. Back care classes, some with precaution, we can use Swiss ball. Gym work, pregnant women can do with precaution. She can use static cycle, treadmill, cross trainer, and all of which increase aerobic activity. She should use light weights with some maximum lifts. Now we can again modify some plates of yoga. We can modify it for a pregnancy. These can relax the women and control the breathing and relaxation. These are the some patterns of exercises we can guide with your antenatal after second semester of pregnancy. Gym Swiss ball and some pelvic clock exercises. Now, how you educate for positioning to a women, you have to tell, you have to explain about the increased uterine cramping may occur with the some activity. It is acceptable if the women after the exercises, this cramping stops when activity is completed. You should not exceed the 5 minutes of supine positioning any one time after the first trimester of pregnancy to avoid vena cava compression by the uterus. So what is the wrong position? Supine position should not be advised to the pregnant women after the second semester. Recommendation for fitness exercises. This is strongly recommended for all women to participate to mild to moderate exercises for both strength and cardiopulmonary benefits, 15 to 30 minute sessions. Most days a week, individualized program based on pregnancy fitness level are preferable. This again will depend on your subject. If the subject can tolerate what exercise regimen, you have to change according to the subject you get in. Suppose some patient can, they don't have good cardiopulmonary fitness, so you have to change your regimen according to them. This has to be very careful. When the women fatigued, a woman should stop exercise and she should never exercise to exhaustion. Exhaust आपको women को करना नहीं है. Now we talk about postnatal care. This is pelvic pelvic floor strengthening. We have to stress on this. Exercise should be resumed as soon as after the birth as possible. These exercises may increase circulation and aid healing of laceration, epistomy, combining pelvic floor contraction with feeding.
Again, we have to work on according to the capacity of the women. When she feels able, cardiopulmonary exercise we should start. Precaution, again, we have to take with postnatal care. If bleeding increases or turns bright red, then exercise should be postponed. Tell her to rest more. And ये इसके साथ नहीं जा रहा है ना? Excuse me. Okay, fine. If bleeding increases, turns bright red, exercise should be postponed. Tell her to rest more and allow a longer recovery time. Now I'll talk about diastasis recti, that a physiotherapist should take care of this. They should know how to assess this. Rectus abdominis diastasis is defined as a gap of about 2.7 centimeter or greater between two sides of rectus abdominal muscles. The distance between the right and left rectus abdominis muscle is created by stitching of linea alba, a connective collagen sheath created by aponeurosis, insertion of the transverse abdomens, and internal oblique and external oblique. You can see in this picture normal abdomen and diastasis recti abdomen. This a physiotherapist should know how to assess this single. Just please come. This is not getting changed over there. It's not functioning. Na? अभी इसमें now just button. I know that, but it's not getting it. I have to get just okay. Abdominal exercise program which includes strengthening of transverse abdominis and rectus abdominis muscle, postural training and strengthening of postural muscles and stretching of tight muscles should not be ignored. Now we work about pelvic floor muscle strengthening. More than 70% of women get not create a pelvic floor contraction in the presence of rectus diastasis. And as a result, one more likely to experience incontinence, prolapse and pelvic pain. Abdominal bracing and taping can be done. Breathing exercises for diaphragm efficiency. If the gap is more than a 4-finger width, then you have to advise a corset or a binder is typically recommended in conjunction with the exercises. Now talk about again pelvic floor dysfunction and urinary incontinence. As you can see, the pelvic floor muscles support the urethra, anus, coccyx, and pubic bones. So you have to work upon that. Involuntary loss of bladder or bowel contents frequently as a result of both neuromuscular and musculoskeletal impairment occurs. These patients often have significant social discomfort and anxiety regarding leakage and hygiene concerns. Strength training of the pelvic floor improves the structural support of the organs, connective tissue, in addition to the facilitate more effective recruitment of motor units and more consistent proficient contractions. You can see these are the weak pelvic muscles and strong pelvic muscles. If the weak pelvis was urine dribbling will be there, urine incontinence will be there. So the pelvic floor exercises that is called Kegel exercises are the simple way to help build strength in your pelvic muscles. Nowadays, we have this biofeedback system. With this, we can multiple types of instruments we can use to provide sensory feedback to the pelvic floor muscle. Patient can see how much contraction he is doing or she doing to see his muscle strength, and we can guide with this machine. We have different probes to use electrodes for the patients. These are the different techniques we use for strengthening the pelvic floor muscles: contract, relax. In continuation Valsalva maneuver, we have to see how much women can count loud to increase the normal breathing pattern. Quick contraction, again we have to teach the women perform quick and repeated contraction to the pelvic floor muscles while maintaining a normal breathing rate and keeping accessory muscles relaxed. Try for 15 to 20 repetition per set. Type 2 fiber responses is important to develop in order to withstand pressure from above, especially with coughing or sneezing. As you can see this, how the pelvic floor muscles, if they are weak, how they can create incontinence, and pelvic floor relaxation also is very important, linked with the breathing and relaxation of the facial muscles. Instruct the women to concentrate on a slow and deep breaths, allow the pelvic floor to completely relax. These are the methods to teach them exercises. Now I am going to come to the hysterectomy. This is also very important to a physio to know actually what are the types of hysterectomy is going in the hospital. Or nowadays, cervical cancer, even though the cervical vaccine has come, the cervical cancer has come down a lot. Still, we have hysterectomy in the hospital, gynae hospital. There are 3 types of hysterectomy: subtotal and total and radical. Hysterectomy, in this, to reduce the effect of general anesthesia, first day of hysterectomy, you should again go for deep breathing exercises, coughing. This you can see subtotal, total, and radical. After the post day 1, to reduce the effect of general anesthesia, practice the following exercises throughout the day: deep breathing, coughing, and circulatory exercises. Day 2, you can go for abdominal exercises with precaution. From day 2 onwards, start all exercises lying with the back of your head on pillow, knee bent and shoulder width apart, feet flat on the bed. Again, you can go for pelvic tilting, knee rolling for day 2 till patient discharges. Useful tips what we have to give to the patient: always try to use pelvic floor muscle before you laugh, before you cough, before you sneeze or lift any object. What precaution you will give? Excessive weight gain, you have to stop the patient, you have to guide the patient for not to gain weight after hysterectomy. That will again creates an extra load for the pelvic floor. Constipation, again, as a staining stretches the pelvic floor muscles. Strenuous heavy lifting, as this places extra pressure on the pelvic floor, so does repeated lift, does by repeated lifting. Sudden movements, try to contract your pelvic floor muscles before coughing or sneezing or jumping or jogging. These are the posture corrections. The patient after the hysterectomy goes home, you have to teach them how to lift this, what they have to do or what they don't have to do. Posture correction, standing, in walking, in lifting. This is the resume which you have to give when patient goes home. Continue with the exercise described above for at least 6 weeks. Take rest in between on your bed about an hour for the first 6 weeks. Walking, this is a very valuable exercise. Try to walk for about 20 minutes at least once a day. Hills and stairs are quite safe, but build up speed and distance gradually. Driving, do not expect to drive for about 4 to 6 weeks, depending on your surgery. These are the precautions, what they have to do at home, but they don't have to do. They don't have to do heavy work, heavy house bedding, lifting, and washing, and small kitchen work they can do. Now I'm going to talk about mastectomy, that is breast conserving surgeries. As a physiotherapist, we are dealing with this impairment and complication. What are the complications occur after the breast surgery? Post-operative pain is one of the most difficult to deal with that. Post-operative pulmonary and vascular complication, lymphedema, chest wall adhesions also is very difficult to deal. That really creates a lot of problem to the patient. Decreased shoulder mobility, weakness of involved upper extremity, postural malalignment, decreased endurance and fatigue. Obviously, when one goes under this, once a woman goes under this breast conserving surgery or mastectomy, psychologically she's very depressed, so that has to be taken care. Now, these are the complications which I've already talked about. The way we can deal with it, we have to taken care of the restrictive scarring and underlying tissue on the wall can develop as a result of surgery. Decreased shoulder mobility that occurs because they just take out all axillary lymph nodes, and that thought to be caused by the interruption of lymphatics in the axilla. Weakness of involved upper extremity, that very common shoulder weakness. If the long thoracic nerve is traumatized during axillary dissection and removal of lymph nodes, that result in weakness of serratus anterior and compromised stability of the scapula. So we have to work upon it. Postural malalignment, the patient may sit or stand with the rounded shoulder and kyphosis because of pain, skin tightness, and psychological reasons. Fatigue and decreased endurance because of chemotherapy. Now, this is very important for all of us to deal with psychological consideration. A patient undergoing treatment for breast cancer experiences a wide range of emotional and social issues. The needs and concern both the patient and the family must be considered. As a therapist, we have to we play a psychologist role also with them, because we are dealing for hours to them, 1 hour, 2 hours we are with them. So we can act as a very good psychologist for them. Now, this is also one of the important part which we have to take in care. Yeah, this is a big problem. Compression therapy. After the operation of the patient feel lot of swelling in his upper limb. The type of compression bandage which we should use, that is low stretch bandages. We should not directly go for high stretches bandages. That can create a lot of problem to the patient. Now, these are some exercises for upper extremities, which we have to give for the edema clearance. These are the different other exercises for everybody knows about wrist and finger rest. And she has to take rest also in between, because already she's undergone such a major surgery and undertaken chemotherapy sessions. Now I'm talking about polycystic ovarian syndrome. Most of our girls are facing this problem nowadays. This is what? This is formally known as Sten-Leventhal syndrome. Is a disorder affecting the hormones of women of childbearing age. Ovaries are enlarged secondary to multiple cyst formation within the ovaries. The most annoying complication of PCOS are infertility and obesity. What exercise as a physio you will recommend them? You have to plan a exercise resume for them. Steady state cardiovascular workout. I'm not going to in detail in this because time is short. HIIT workouts, high intensity interval training. Interval training for, it is a way to exercise at a different intensity level. Mind body exercise are very useful in PCOS, because PCOS is more related to the stress. Study shows that women with PCOS have an enlarged bodily response to stress and distress. Mind-body exercise like yoga, pilates, and Tai Chi exercises can help not only for burn calories but also reduce stress level that worsen your PCOS symptom. अगर stress आपका relieve नहीं होता PCOS में, तो आपकी obesity भी कम नहीं होगी. तो strength training we have to do. Please. चेंज नहीं हो रहा है अब हो रहा है ठीक है थैंक यू लाइफस्टाइल चेंजेस अगेन एवरीबडी नोज अबाउट इट बट वी हैव टू रियली emphasis on them, on the patients with PCOS, they have to go for weight loss. Regular exercises, dietary modification. Nowadays, even Indian women are also starting smoking. So they have to quit smoking. Who smokes have higher level of androgen. Now again, osteoporosis, again we have to, physiotherapist has to deal with this. What is osteoporosis? Disease characterized by low bone mass and deterioration of bone tissue leading to increased risk of fracture. This is a silent thief. Bone deterioration can occur over a number of years without presenting any symptoms. Unfortunately, mostly detected at time of break. जब हड्डी टूट जाती है, तब एक women को पता चलता है after 45 or 50 years कि मेरे को osteoporosis है. This is very common in trauma center. We are dealing lot of fractures because of osteoporosis. 1 year में एक fracture लेके आती है, next year she will get another fracture. So we are dealing with fragility fracture in, we have fragility clinic in trauma center. The most common fractures which occurs in hip, spine and wrist and shoulder. What are the risk factors for osteoporosis? Again, alcohol use. A lot of corticosteroid have used, calcium, low calcium, estrogen अगर आपका low है, smoking and sedentary lifestyle. Now, what is the management as a physiotherapist you can do? You can go for muscle strengthening. Again, weight bearing combined with small weight bearing exercises with the elderly, posture control, balance and coordination, training in daily living activity. This is a very good exercises, Tai Chi exercises for elderly people who have osteoporosis. They enjoy this and stress level also decrease with this. Thank you so much.
Thank you, Dr. Poonam. Any question, please? Well, it's a wonderful, informative presentation by Dr. Poonam about the women's. Any question, please? No. Dr. Poonam, एक मेरा क्वेश्चन है.
Please.
मोस्टली क्या होता है कि आजकल ना पेशेंट्स योगा की तरफ ज्यादा भाग रहे हैं और फिजियो की तरफ भी. Or according to your opinion, would you like to do the some physical exercises as well as yoga both at a time, or either in a simultaneously, or either in a one of them for women's health?
In my opinion, sir, yoga is actually advanced stage में अगर if patient comes to you, so we should not advise a typical yogic posture to them. If they do, they will break something, they will break the ligament, they will come with a lot of facet discomfort. For daily, we are having 1 or 2 patients of that type also, because Ramdev is fully doing all yoga. But I'm not denying that yoga is bad. Yoga is very good. But if the individual didn't do yoga for 40 years and they're doing after 40 years, so we have to teach them, guide them. You have to be very careful under the supervision of some educated or yoga therapist they should do, and with the modified yogic postures, not typical yoga posture they should do as they're showing in the TV. It should not be.
Thank you, ma'am. Thank you so much.
Any question, please?
Thank you so much, ma'am. It was really very informative session. Now I request Dr. Sanjay Bhaskar sir to please facilitate Dr. Poonam ma'am. I request Dr. Poonam ma'am to please come up on the stage. Please give a round of applause. Thank you, sir. Thank you, ma'am. Now I would like to request Dr. Uma Shankar Mohanty, sir, to please come up on the stage and facilitate our chairpersons. I request Dr. Nelson, sir, to please come up on the stage. Thank you, sir. Thank you, ma'am. Now I request Dr. Prakash, sir, to please come up on the stage and facilitate Dr. Sanjay, sir. Thank you, sir. Now I would like to request Dr. B.K. Lamba sir to please come up on the stage. I would like to request Dr. Poonam ma'am to please come up on the stage. Ma'am. I request Dr. B.K. Lamba sir to please come up on the stage and facilitate Dr. Poonam ma'am as the chairperson. Thank you, sir. Thank you, ma'am. I thank all the research, all the chairpersons and all the speakers for the wonderful session. Now it's a time for having a presentation by Petrimed CA. I like to call Dr. Sachin from River Engineering Private Limited, Greater Noida.
Good afternoon all. Myself Dr. Sachin, and I'll talk about the sustainable solution to the indoor air pollution designed and developed by Petrimed CA. So whenever we talk about the air pollution or indoor air pollution, there are sources of air pollution, and the commonly sources of air pollution which are available in the day-to-day life is landfills, household products, stubble burning, construction activities, industrial activities, and agriculture fumigation. All these sources will lead to the PM 2.5, PM1, and PM10 sources of pollutions. Apart from that, whenever we talk about the pollution, there are airborne microbes. Whenever we breathe the air, we breathe the different microbes. If we generally categorize the microbes which are available in the environment, they are tuberculosis, pertussis, measles, chickenpox, rhinovirus, mobile virus, influenza. They all are categorized by their size also. Like for tuberculosis, the size of this virus or bacteria is ranging from 1 to 5 micron. Similarly, for the measles virus, the size is ranging from 0.15 to 0.22 micrometer. Similarly, the chickenpox, rhinovirus, all these are having their physical diameter or the physical size by which we can categorize them. So whenever we are breathing the air, we are breathing the different microbes. We are breathing the PM2.5, PM1, PM10. So all this will lead to different diseases. They are having certain harmful effects on the human body. Some of them are like with the there are regulatory bodies. They have identified the cause of these diseases and they have given certain figures by which we can visualize the severity of these pollutants. For example, World Health Organization, they said around 99% of the global population live in places where pollution exceeds the defined guideline. Similarly, US Environmental Protection Agency, they said indoor air quality can be up to 5 times worse than the outdoor air quality. Similarly, UN Environmental Program, they said 7 million deaths per year due to bad air quality, and 9 out of 10 people worldwide they breathe polluted air. Similarly, the study conducted by Global Burden of Disease, they said 2 million premature deaths in India are due to poor air quality. So in a hidden way, if you see, the indoor air pollutants or indoor air pollution is a leading risk factor for death globally. So all these diseases, all these pollutants, whether it's a microbial pollutants or they are PM particulate matters or the VOCs, volatile organic compounds, they lead to certain diseases. Some of the diseases which are caused by these pollutants are asthma and allergies, COPD, chronic obstructive pulmonary disease, Alzheimer's disease, irritation of airways, dizziness and fatigue, cardiovascular disease, cancer, infertility, even the sleep disorders. These are all the diseases which are directly or indirectly related with the different pollutants. Not only the disease, there are certain pollutants which are having their correlation with the disease related to the muscles. Some of the findings, some of the studies from the international reputed journals are, the first article is association between exposure to ambient air pollution and rheumatoid arthritis in the adults. This is the study which is published in the International Journal of Environmental Research and Public Health in 2019. Another article is effect of PM 2.5 on skeletal muscle mass and body fat mass of elderly. This was conducted in the Taiwan. The next article is association of ambient and household air pollution with the bone mineral content among adults. This was carried out in the South India in 2020. So all these pollutants will lead to, directly or indirectly, will lead to the diseases. And somehow, if we can restrict the such pollutants by inhaling while breathing, we can definitely reduce the risk of the diseases. So one of the solution for such kind of diseases are designed and developed by Petrimed CA as a technical solution in the form of air purification system. We called it as air purification system. It's not the simple air purifier. There are certain reasons for that, why we are calling it as an air purification system. Whenever we talk about the air purification system, the major heart or major contribution is the filtration system. Whenever we talk about the filtration system, there are certain regulatory bodies. They have given certain guidelines for the use of such filters in the filtration system. Like actually, American Society of Heating, Refrigeration and Air Conditioning Engineers, they have given the guidelines of using the HEPA filter with the efficiency of 99.97% for the application of orthopedic, bone marrow transplant and organ transplant operating rooms. Especially in the OTs, they have given the guidelines of using 99.97% filter efficiency for the air purification system, whether it's a conventional air purification system or the advanced air purification system. Similarly, FDA talks about the efficiency of 99.99% for the indoor application. WHO has given the guideline of using 99.97% efficiency for the critical medical applications. Similarly, NABH has also said the guidelines of using 99.97% for hospital and healthcare facilities. In the ICUs, the requirement of filter efficiency is 99% down to 5 micron as per the article published in the Journal of Critical Care elsewhere. Similarly, for the burn patient wards, the efficiency should be 99.99% as per the Journal of Burns. So, as a technical solution by the Petrimed CA has come up with the solution of using air filtration system or the air purification system with the HEPA filter having grade H14 as per ISO 50U, which is having an efficiency of 99.999%, 99.999%. Which is surpassing all the regulatory standards of worldwide accepted bodies, just to ensure the maximum utmost protection of these diseases or of these pollutants. This is the basically technique which we are using in our devices. It's an air shield air quality defense technique where we are filtering the different pollutants. It may be microbes, it may be a TOCs, it may be a PM using 8 different stages. The first stage is it has a washable pre-filter where we block dust, particles, pet hairs. Next stage is we have permanent nanosilver antibacterial layer where we eliminate molds and bacteria. The next stage, we have high quality activated carbon where we absorb odors and smokes out of the indoor air. Then next we have nanomolecular sieves where we absorb harmful industrial pollutants. After that, we have exclusive ionic catalytic coating where we decomposes TVOCs, formaldehydes, ammonia. In the next stage, we have filter, which is a H14 as per ISO 50U, where we filters out around 99.999% of particles out of the air. Next, we have UVC technology where we are using germicidal wavelength for the ultraviolet 251 nanometer, which is sensitive to the microbial organisms, where we kill the microbes using this wavelength. Then next, we have the ionizer where we purifies the air in a room by electrically charging it. We have a device inside the purification system which will produce the negative ions, which will basically attract the pollutants and it will settle down the pollutants in the nearby surface, as well as neutralizes the charges. Basically, this is the filtration process through HEPA. This is somewhat a scientific slide where we have shown there are 4 different methods by which any particles or any microbes or virus or bacteria can be trapped using HEPA filters. The first is direct impaction. Second is sieving, interception, and diffusion. Each stage is having their own advantage. Like direct diffusion, if there is a particle of bigger size, it will directly collide with the fibers of the HEPA filter and it will get stuck. In the next stage, sieving, if the particle is of a little bit smaller size and it is crossing the first stage and going to the second stage, then it will be trapped in between the 2 fibers. Similarly, in the third stage, interception, it will collide with the fibers and it will stick to the fibers. In the last stage, if the particles are too small, like in the microns, 0.1 micron or 0.2 micron, they are going to the diffusion state. They will collide with the particles which is ahead of their path. So if you can see in the bottom side, we can see here the particles that they are moving in a random pattern. Basically, if the small particles are there, they will follow the Brownian motion. They will collide with each other. They will change their path and they will travel in a zigzag pattern. So while traveling in a zigzag pattern, they will come in contact with the HEPA filter fibers and get stuck in out of the 4 stages, any of the 4 stages. So if we are passing 1 lakh of particles from this side, input side, then on the other hand, if the filter efficiency is 99.999%, then only we can expect 1 particle out of 1 lakh particles. So that much accuracy this device is giving. These are some more scientific explanation for how it is trapping the 0.1 micron size. HEPA filter generally they are designed for a size of 0.3 micron. It's called as MPPS, most precision particle size. They are designed for that. Efficiency is calculated for that particular particle size. But whenever we are using HEPA filter, because of this last 4 stages which I explained, there are particles of having size 0.1 micron. So they will get trapped in that. Out of these 4 stages, they will get trapped in any of the stages. Most probably in the diffusion stage. The graph which is given over here, this is experimental study conducted by NASA. They did this experiment on HEPA filters, a similar kind of HEPA filters, and they found the observations. Though the HEPA filters are designed for 0.3 micron size particles, but whenever the size of any microbes is greater than or less than 0.3 micron, the efficiency get increased. This is the experimental findings of their HEPA filter. Even for the different viruses, I have listed the different viruses over here: influenza virus, rhinovirus, coronavirus, measles virus, chickenpox. All they are having different sizes, and the sizes is ranging from 0.06 to 0.14 micron. So if I talk about the average size, it will be around 0.1 micron. So this virus and bacteria, they are having a physical diameter of 0.1 micron, which will be trapped by the HEPA filter, which is used in our system, air purification system. So one very common question generally people ask, like, can a normal air purification system protect you from indoor air pollution? So like the explanation for this is, it may not be that much helpful to protect you from the different pollutants. The reason is we did one comparison between our system designed and developed by Petrimed and which is available in the market. We generally categorize this system into 3 different stories. The first story is a medical grade plus filter where we are using 99.999% filtration. Whereas in case of other devices, they are having 99.90 to 99.997%. So this is the first stage of defense where we are trapping most of the particles. Next story is the UVC, where we are using the ultraviolet radiations to kill the microbes. This is in general not found in the other devices in combination with the filtration process. So there we are giving the advantage of using this UVC technology. After that, in third story, we are having inbuilt ionization, where we are producing the negative ions, which will attract the positive particles out of the environment, and they will settle down that one. So within these three different stories, we can give you the maximum possible protection against these viruses and bacteria and different pollutants, which is generally in general not found in the any of the devices. Either they will use filtration with the UVC, filtration with the ionization, but not all together. So using this technique, we have come up with the solution. We have come up with the solution, air purification system, design efficiency of filter as high as 99.999%. Some of the key features of this device or key features of this air purification system is it has inbuilt ionizer, it has inbuilt UVC disinfector, it has wide voltage level so that it will sustain the fluctuations which is generally causing in our day-to-day life. It will work between 140 watt to 270 volt. It has a real-time display. We can see over here, it has a real-time display so that we can monitor the air quality, we can monitor the PM level, we can monitor the TVOCs, even we can monitor the temperature and humidity. So application of these devices, we can use this air purification system in different various applications, such are like operation theaters we can use for severe acute respiratory disorder. We can use this system in ICUs, hospital rooms. We can use this in dental clinic. For home isolation also it is very beneficial. In automobiles also we can use. In office workplace also we can use. In automobile generally people think like, okay, in automobiles whenever we are sitting in the closed cabin in the automobile, the environment is very safe. But this is not actually the fact. The inside the car, the air pollution is up to 12 times higher than the outside. So it is a much more dangerous inside the car. So whenever you're going for a long trip or in the vehicle, then definitely it is a very helpful device to minimize the pollution level and keep ourselves safe. Now the benefits of using air purification system, very basic benefits are like it reduces the odor, dust and allergies. It will kill the airborne molds and germs. Sorry, it's not working. It will filter out the 99.999% of particles. It will help to minimize the chances of disease caused by air pollution. So using this technique, we have developed different products for the different variety of applications. Some of them are, we are having air purification system 400, 250. Basically, these are the two devices which is basically designed for different applications based on the air space, the air volume which we need to purify. We have air quality monitor AQM10 that will give you the indication, the real-time indication of different pollutant levels. We have air purification system APS20 for the car application. We have designed and developed bipolar ionizer, a UVC disinfectant box, mist-based sanitizer dispenser, and the oxygen concentrators. So like if you talk about the bipolar ionizer is basically, it is different from APS, air purification system. It will produce negative and positive both the ions. Whenever we are talking about the ions, see in the open environment space, there are free radicals. Free radicals are having charges of positive or negative, both are there. Most probably positive particles are harmful for the human body, but there are certain cases where negative charge particles or negative pollutants are also harmful to the body. So this bipolar ionizer AI100 is basically designed for such applications where we are having both the radicals in the environment. So it will basically neutralize these radicals and it will settle down the pollutants. UVC disinfectant box is very useful for the office workplaces or even in the homes whenever we are having such environment where there are so many viruses or bacteria are there. We are sanitizing our hands, but what about the different devices like mobile phones or purse or wallets or such kind of things? They also need to be properly sanitized. So UVC disinfectant box is using UVC wavelength, ultraviolet radiations of 254 nanometer, that is germicidal wavelength. So whenever there are any microbes on the surface, that will kill that microbes within a minutes. So generally the cycle time is around, if you keep any object inside this device for 1 or 2 minutes, it will completely free of microbes. oxygen sanitizer and mist-based dispenser all know that we have also developed. So these are the devices from Petrimed CA, designed and developed. Thank you. If you have any of the questions for any of the devices or their applications, you can get your doubts clear. Cost of which one? Air purification system. In general, it is around 60,000. We're claiming there are certain offers by the company. Marketing department will get back to you on that one particular thing. But yeah, it's rough cost is around 60. Parameters are basically the first one is the PM 2.5. The indication is PM 2.5. It will give you the exact values of PM 2.5 particles in this environment in the vicinity of these devices. Second one is your CO2 level, and the last one is the TVOC, total volatile organic compounds. Whenever we are using perfumes or smell or any sanitizer, we smell something. So that smell is basically harmful for the human body. It's not that good. So the level of that pollution or level of that TVOC is, will be shown by this device, the indicator, the third indicator. Even we have the temperature devices or the temperature sensing element as well as the humidity. We can control the humidity as per our requirement. Not with these devices, but we can monitor the humidity and then we can use other devices to control the humidity. Okay, thank you.
Thank you, sir, for a very informative session. I have an announcement to make. We'll be holding a quiz based on physiotherapy. So those of you who want to participate can form a team of 4 members and get it registered with me and Dr. Dimple. I am Dr. Parul, she's Dr. Dimple. So you form a team of 4 members and get it registered with us. So then we'll be holding the quiz and the winners will be getting appropriate prizes. Okay.
Thank you, ma'am. Thank you, ma'am. Now we'll have another presentation from SPRY. I would like to call Mr. Brij Mohan, founder and CEO. Mr. Brij. Sorry, I would like to call Mr. Brijraj sir, founder and chief executive officer SPRY, to please take over.
Good afternoon, everyone. I hope everyone can hear me. First of all, I'd like to thank GAPTCON for giving us an opportunity. This is the first time we are making a public appearance, so thanks for that. Bharat. So before I start, I'll just give you some context. I'm not a physiotherapist, nor do I come from a medical background. In fact, we are from the software world. Until March, I was the CTO at Ola Cabs, the cabs that you take, right? I was the CTO of that, and now we've started SPRY. The motivation behind starting SPRY is simple. Until 10 years back, any of you try to book a cab or order food from any restaurant, it was a nightmare, right? It was very painful. And obviously with Ola, with Swiggy, we have changed all of that. So the idea with SPRY is that more than 2 billion people in the world suffer from pain. Not many of them access to treatments. People who take treatments, start taking treatment, drop out of the treatment halfway. More than 70% of the people drop out halfway. So what can we do to make the treatment more accessible, affordable, right? The work that you guys do, and it's evident from all the presentations that are happening so far, is advancing the medical science well. But who is working on the delivery of this medical science? So that's what SPRY does. We want to improve the delivery so that anyone sitting in any corner of the world wants to access the physical therapy service, they should be able to do it well. And when they start accessing the service, they should be able to continue with the treatment as well, right? And now I'll take you to what we do with. So just to give SPRY is a platform which is one of the first in India and also one of the few globally, which is only developed for physical therapy, right? We don't work with any other specialty right now. So it's the only developed for physical therapy, physical physiotherapists and rehabilitation centers. We are already working with around 100 clinics in India, clinics in the USA and clinics in UK as well. So what are some of the things that I saw when I started looking at this industry deeply, when I wanted to change from Ola to here? Right. First of all, with COVID, everyone is obviously talking about preventive care, and physiotherapy, strength and conditioning plays an important role there, right? All of us are working towards increasing lifestyle. We want people to live longer, but no one is working to making sure that the quality of life also improves when we live longer, right? And physiotherapy, strength and conditioning can actually do that. patient expectations are increasing. Patients are at the front end set. Patients are becoming, especially the younger people, are becoming more vociferous. They want control over the data. They want control over. They want to make choices. We select our own cabs. We select our own partners. We select our own life partners. Right. The patient want to choose doctors. Patient want to have better control over the medical delivery, and so patients have more power. That's why the customer relationship management and patient expectations change. Another thing which is working in favor of physical therapists is direct access, right? Until few years back, everyone was dependent on orthopedics, neurologists for their referrals. But now if you go to google.com and say physiotherapist near me, there are close to 1 million searches happening every month, which is more than cardiac surgeon near me or eye surgeon near me, right? So that means people are looking for physiotherapists directly, and you guys have to make yourself available for that. So those are some of the changes that we are seeing. And some of the trends that we are seeing, right? Data-driven decision making. So data-driven decision making is essentially used for insurance, value-based care. Gamified rehab. A lot of companies doing VR, AR, so that you can actually treat patients in nursing, skilled nursing, away from home, without having them physically come to the clinic. AI and ML. This is what we use effectively. I see that all our assessment forms are very bulky. All our subjective information forms, objective information forms are very bulky, and they're not really linked to the outcome. Can we actually understand the outcome? Make these forms shorter so that the amount of time that you spend with your patients and the amount of time the patient spends on all of this reduces. Yeah, that's what we do as well. Wearable technology. We don't use wearable technology, we use cameras. Wearable technology is, I think, slightly old. But when a patient is exercising in front of the camera, even a camera as powerful as your phone, we can understand the form and shape very accurately. We can understand if they're doing the exercise right, if they're adhering to the protocol correctly. And all these protocols which we develop, which we monitor, are being verified by Manipal Institute, which is one of the best institutes of physical therapy in India, right? Corporate wellness. I've been talking to a lot of HRs in the US and in India. All of them want their employees to be actually fitter and better so that they avoid insurance costs. In US, you wouldn't believe that employers are spending close to $100 billion on MSK related issues. And that's why everyone wants to get to preventive care, right? And physiotherapy, strength and conditioning play an important role there. And obviously telehealth. In the pandemic, people have realized that you can deliver care over telephone, right? So you don't need to be physically present. So I live in Bombay, but I come from a town called Bhavnagar where there's no physical therapist. If anyone there wants to work to physical therapist, they have to travel all the way to Ahmedabad, right? But telehealth actually helps us overcome all those boundaries. So what is PRI then, right? And what is our vision? So basically, what we think is movement health is not monitored regularly. Many of you would know your blood sugar, many of you would know your blood pressure, right? But if anyone were to ask me what is my mobility index, am I fit enough to play badminton today evening? Am I fit enough to go for a run? I wouldn't know, right? And the only thing I know whether it's my pain only when I have pain. So how can I figure out a mobility index? And that's what software can tell you. Your range of motion is 20 today, it can improve 30. So you can objectify treatment. And then when you start giving easy numbers to people, people can act on it, right? The patients will act on it. Right, that's what I'm saying. The other is it's all reactive. Today, I only go to a physiotherapist or an orthopedic when I have pain. There's nothing preventive about it, but that's not the way the other industries are working, right? Be it skin, be it health, be it dental. There is a lot of preventive care happening, and we need to move towards that as well. And through Spry, we want to make it democratized. That means like how we democratize cabs, right? At Ola Cabs, when I was a CTO, everyone is able to now book a cab. My mom is able to book a cab. Your parents are able to book a cab. And imagine the power it has brought. Someone who was stuck at home can now have the freedom to actually go out and move. We want to do the same thing with movement as well, right? If anyone who's old, should have access to this physical therapy, be it on telehealth, be it in person, or be it remote. And then they can pursue the things that they want to do. So I'll come to the software after giving all this yarn that basically what are we doing, right? We are developing a software which is only for physical therapists. Right from the time the patient experiences pain, he looks for a physiotherapy. So we create your entire website, your entire Google My Business page, your appointment module. Then once the appointment is created, sending out the subjective information forms, all of the automation of the entire forms. Then the patient comes to the clinic. You either do a telehealth meeting or an in-person meeting. You do the assessments. Assessments are structured. The workflow of the assessments is such that it's very catered to what you want to do, not something what a clinic says or what a digest says or what a paper says, right? You tell me that, Bridge, I want to ask for abduction first, I want to ask for reflection second, I want to ask for palpation third. We'll actually create a custom workflow for you. And all you have to do is go and tick marks there. So what you know is that. And after that, you decide a home exercise program. So we've developed content as well, around 4,000 exercises, which are typically used for physiotherapy. You can assign content for your patient from that portal as well. So when a patient today, when you either would give a YouTube link or a PDF file, right, which is very difficult for a patient to remember. In the content, you can also specify how many reps, how many counts at one day, etc. So then very easy for the patient to see. What it does on the patient side, I have an app, which when I put my information and I put a doctor code, it tells me, okay, what is my prescription? I have a very easy way to understand my prescription. I see a playlist that, okay, exercise number 1, exercise number 2, exercise number 3, as opposed to remembering this, which is impossible for me to do. And then when I'm exercising, I keep my phone in front of me and exercise. I'm also being monitored whether I'm doing the exercise right or not. So if my form, for example, if I'm doing if I'm extending my back hand and if I'm bending forward, it will say that you're compensating, right? If my alignment is not fit, it will say you're not aligned. And all the metrics that are being measured, for example, how far can I extruct, how can I go like this, are being recorded and being sent to a physiotherapist. So imagine a physiotherapist, like they're sitting in somewhere in Goa, they don't care. They have a dashboard in front of them. There are 1,000 patients, and on the dashboard they say, okay, my patient is at this place in the recovery cycle. This patient is having a problem with extension, so they can call up and give them the necessary counseling. So you can monitor close to 1,000 patients without having to personally meet them. Now imagine the scope, the amount of reach that you guys can have when you start using a software like this, right? And more importantly for the patients as well, right? I cannot come to you because I have office, I have other commitments. I cannot come at a time of my convenience all the time. I cannot come at a time of your convenience for that matter. So my ability to pursue with the program without having to interrupt it, without having to disrupt my lifestyle, is a power that I would love to have. Okay, sorry. Yeah. So this is what motivator, this is how the software looks like. But any of you practicing, any of you having running a clinic, you would associate with the first figure, right? You're using 4 or 5 different software without realizing it. It's subconscious, it's gotten as part of your system, it becomes part of your daily routine that you don't realize it. But you might be using something for appointment booking, which might be a Practo or a Google Calendar. Then you use Excel for data collection, which is subjective information, objective information. Then history taking is typically done either on paper or on Excel sheets again. Assessments are also done the same thing. Home exercise programs are either done on PDF files or on YouTube. And then after the patient leaves, you remain in touch with the patient either through WhatsApp or some kind of a telephone, right? Which is very suboptimal. So imagine the amount of overhead that you're incurring in your life. And what we have realized, the analysis that we've done is all of you guys spend around 50-60% of your time managing this overhead rather than treating the patient, specifically the clinic owners, right? Because they have to manage overhead. So what we're doing is bringing all of this together on one platform, and it's seamlessly integrated with each other. So you don't have to worry about it. It's just one software manager. If you to have an analogy, understand the difference between an iPhone and an Android, right? iPhone is something only the Apple guys make. The chip is made by them, the software is made by them. That's why you have an experience which is as seamless. Whereas an Android phone, anyone makes. And that's why the experience is suboptimal. So when there are multiple parts of a system working together, it's always going to be disparate. Even at Ola, when we built out the driver and the customer, the driver app was built out by us, the customer app was built out by us. And that's when it works seamlessly. Otherwise, it's very difficult to get the experience right. Right. So these are the important modules that we already have live, and the clinics in India, US, and UK using managing of appointment and scheduling, the unified patient view. So you have an entire view, you have a timeline of the chronology of events, what the patients are doing. You have access to a very deep content library, so you don't have to go to YouTube or PDFs or any of that, and the patients have access to the same. And then analytics to drive performance, right? How many people, what kind of people are dropping off? What is the analytic? Do I need to onboard a new physio? Right? Am I able to train people enough? Right? All of those analytics which are important to run a business is something we give as part of this platform. And we're coming up with we are a 7-month-old company. So we're coming with a lot of new things around marketing, around customer relationship management, accounting, invoicing, and all of that. But the idea is that you guys have to only use one software, nothing else after this. And then the other side is patient side, right? Physical therapy is one of those things where 90% of the rehabilitation is happening outside the clinic. So what the patient does for 90% of the time is more important than, as equally important is what happens in the clinic as well. And this app helps you monitor that. So imagine as a patient, I get the prescription, you must make a prescription. I as a patient go home, open map, I see, okay, these are the 10 exercises I have to do. It's like a playlist, like how you create a playlist on Ghana or a YouTube, as simple as that. I start playing the playlist. It's customized. So if I have a repetition of 10, the guy on that will only go up in 10 times. If it's 15, then go up 15 times. Right? If you know it's an older patient, the repetition rate will be slower. So it's very customized. You as a patient follow that. We use computer vision here. That's where the AI comes in, and that's where I've done a lot of that work in Ola, where you used to take a selfie of the driver, count the number of passengers going in and out of the buses. So using camera, you can actually understand what the form and shape is. As you can see, we can reconstruct completely, or we can do key body part detection. I have all the parameters which are important to monitor that, and then you get all of that on a dashboard, and the patient gets feedback. So although the patient is not in the clinic, if there's a continuous communication with the doctor and the patient, at least virtually the patient thinks so. Yeah, that's about it. So as I mentioned that we are doing this with around 100 clinics in India already, and 10 clinics in the US. And yesterday we signed up 3 clinics in UK. We are growing globally. We're in the early days, so we are open to actually onboarding more patients. And as part of GAPTCON, I agree with Dr. Krishna that we have a stall there. Anyone who wants to take the platform, we are giving a 6-month trial right now, right? No charges for the next 6 months. Our team is there. We'll be happy to talk to you and discuss more about it. Right. Thank you, everyone. Thank you.
I request all the delegates to please take seats. To begin with our next session, may I call Dr. Jasmine, Dean and Principal, Subharati College of Physiotherapy, Swami Vivekananda University. Ma'am, please come on the dais and chair up the session. We welcome you, ma'am. I would like to call Dr. Meenakshi Rajput, Director, A-Park Healthcare Private Limited and Head of Department, Jaipur Golden Hospital. Ma'am, please come up on the stage. I request you to chair the session, ma'am. Thank you, ma'am. So now our next speaker will be connected with us from online mode. Please welcome Dr. Jason Raymond Falvey. He's Assistant Professor, Department of Physical Therapy and Rehabilitation Sciences, University of Maryland, USA. Today, sir is going to talk about public health roles of home and community-based physical therapists.
Strong relationship and disability level among older adults, particularly, but from many other age groups as well. Disability prior to hospitalization can be mitigated and is a risk factor for potentially more complicated hospitalization. So when we think about the kinds of hospitalizations physical therapists could help save on, all related trauma is, of course, near the top. Making sure that we have good continuity of care for our patients in the community that need us. Despite the pandemic, many patients still have non-COVID related needs. They might be at risk of falls. They might have a new orthopedic trauma. They might have been in a car accident or had a fall that resulted in dizziness and balance issues. So we could actually treat any of these things as physical therapists. Musculoskeletal pain in the United States, at least, is a major reason for people to seek emergency department care, low back pain in particular. And interrupted treatment of even what we would consider simple or straightforward low back pain could result in emergency department stays, which have major implications for COVID-19 times when initiatives are trying to reduce emergency department hospitalization burden. And things like DVT or pneumonia, sedentary behavior, are especially high risk factors for older adults who might be sheltering in place or staying at home and not getting out to the community as much, participating a lot less in physical activity might make them more vulnerable. So patients have a role in helping shave off all of these types of population. And indeed, higher disability rates before hospitalization has been previously associated with elevated readmission risk. So patients that have untreated disability prior to a hospitalization are more likely to require second or third hospital stays. And this is particularly evident in patients with 3 or more ADL disabilities, when there's a 70% increase in the risk of hospital readmissions for patients with 3 or more ADL disability prior to their admission. Similarly, patients who are in the highest proportion of pre-admission physical function as measured by the SF-12, they have a nearly threefold reduction in their readmission risk. So improving health-related physical function could reduce the risk of hospital readmission for vulnerable patients. Physical therapists play a large role in that. Other research has shown that things like slow walking speed for patients that have to participate in surgery is associated with preoperative morbidity, so complication rates as well as readmission and mortality rates. So for patients that have a timed up and go test of more than 15 seconds, standing up, walking 3 meters, and coming back and sitting in a chair, that takes more than 15 seconds. 77% of those patients have a risk or are likely to experience post-operative complication, cervical or post-hospital discharge. And that rate is substantially lower, only 13% for patients who timed up and go in less than 10 seconds. Very important work that has significant implications for physical therapy. Frailty, another important marker of urological health, is also a marker of outcomes after hospitalization. So patients who are frail, as indicated in this red line at the top, are much more likely to have prolonged courses of disability after an ICU stay. And this is particularly concerning because these patients often don't receive needed rehabilitation before. So increasing, even transitioning somebody from frail to pre-frail prior to a hospital admission could be beneficial. Once patients are hospitalized, there's also a substantial amount of value that physical therapists bring. But despite the value, there's been a lot of reductions in hospital-based physical therapy reported, especially in hospitals with high prevalence of COVID-19. This is very striking and very concerning because we know that physical therapy has a lot of effects on improving mobility and reducing cognitive and other deficits related to patients that are in the hospital for extended periods of time. Reductions in hospital-based PT have also been, shown for patients with COVID-19 because there's been a lack of personal protective equipment. The shortages, therapists have often not been high priorities. This might have major impact on patients with the greatest illness burden, ventilated or in care unit. So hospital-based rehab use is an important contributor to better functional outcomes. Patients that participated in multi-component exercise, more targeted, higher intensity exercise during the stay, were much more likely to change their activities and daily living status, their ability to bathe, dress, or walk in their home as compared to people receiving control group interventions. And in the short physical performance battery, this is even more, even a greater effect. So physical performance might be affected even more than EDL function alone, which helps provide protection against future downstream events like bulk. So when we think about rehab specifically in the ICU, early rehabilitation and early mobilization in ICU is associated with reduced risk of ICU-acquired weakness, increased number of ventilator-free days, and a higher likelihood of discharge from home. So reducing rehab could be very bad for patients. So we need to really advocate for action. When we think about work done by my colleague Amit Kumar, who's at Northern Arizona University, he's shown that higher use of physical therapy for hospitalized patients is associated with reduced readmission rates for older adults following stroke. But nearly 1 in 6 of those patients do not receive any rehabilitation, and many others receive low doses of rehab. This might be even worse during COVID. When we're not meeting patients' functional needs during the hospitalization and not bridging the gaps between what they need and what resources they're receiving, they're more likely to bounce back to the hospital. 7% increase in admission rates if patients are sent home with unmet needs for APL assistance. And this might be things like assisted devices, canes, walkers, wheelchairs, that physical therapists often participate in providing. Caregiver training and home modifications, other places where physical therapists are extensively involved, may also have substantial concerns. We might not be providing these services to the extent we need to during the COVID-19 pandemic. Once patients leave the hospital, physical therapists have a large role in promoting optimal health. Trajectories of hospital recovery and readmissions. The research on these trajectories suggests that what happened in the first 30 days when people return home from a hospital stay is critical to their long-term recovery. When we think about patients with medical deconditioning, so general conditions like pneumonia or heart failure, and we look at their in-hospital short physical performance battery, their physical performance, their muscle strength, and walking speed, some of these important outcomes, we find that patients who really are not able to do these things well, static balance, gait speed, to stand testing, the patients with low scores on items don't do as well, and any patient who declines after they leave the hospital. So something that we've observed in our clinical practice, and the data backs up, that anybody who declines the physical function between the hospital discharge and 30 days later is 250% more likely to be readmitted or die in the next 30 days. So not doing physical therapy to these patients early after hospital discharge could be very harmful to the health. Similar research done by Steve Fisher through the University of Texas Medical Branch in Galveston, Texas, has found that patients who have low levels of physical activity, who aren't walking a lot after hospital discharge, he found that those patients are much more likely to be readmitted to the hospital. So patients with the lowest levels of physical activity were readmitted to the hospital at the highest rates. And this we could observe over the first 5 days, that early period, get those patients home, should be getting therapy to them very quickly. And often that's not happening, and even more delayed in COVID. So PTs also have a role in making sure that populations who are vulnerable, such as those living in lower income neighborhoods or rural areas, they might be even higher risk. Prior work from EEI at the University of Wisconsin has shown that neighborhood disadvantage is associated with 30-day hospital readmission rates. And our work in research that we just published has also shown that neighborhood disadvantage is associated with poor outcomes. Indeed, patients that have living in high-poverty neighborhoods after hospital discharge have 10% higher disability rates over a year than those who live in low-poverty neighborhoods. So what we take from all of this research is that PT is essential across the continuum of care. We need to make sure we're providing those services before, during, and after hospitalizations. Innovations in PT are needed, so we need to find new ways to deliver care to patients that may have COVID-19 or other underlying vulnerabilities that might be not able to access their normal means during the pandemic. Physical therapists might have a role in staffing novel post-acute care settings. So places where patients can go after hospitalization to recover more fully, PT might have a role in designing some of those settings. What that looks like in India, I'm not sure. But in the United States, we've certainly talked about having COVID-specific rehab hospitals where the care is led by PTs for patients who have physical deficits as their major complication. And things like telehealth, working with patients over the internet or over the phone is helpful, but it's not a sufficient tool to meet a lot of patient needs during pandemics, especially older people who might not have the technology or might not be comfortable with using it. We have to be very conscious that we might have to find ways to get to these patients, either visit them at their home or get them into these clinical settings to ensure that we can provide them the services they need before, during, and after hospitalization throughout their lives. Feel free to reach out to me based on my personal information. You can reach out to my personal email account or my Twitter handle, which is included on the title of the slide. I'd be happy to answer any of your questions. Here are some references for the talk, and I'm happy to provide you others if you have questions. Thank you very much.
Thank you so much, Dr. Jason, to present it online very beautifully. Now I would like to request Dr. B.K. Lamba sir to please come up on the stage and facilitate our chairpersons. I request Dr. Jasmine ma'am to please come forward. Thank you, sir. Thank you, ma'am. Now I'd like to request Dr. Meenakshi ma'am to please come forward. I request Dr. B.K. Lamba sir to please facilitate, ma'am. Thank you, sir. Thank you, ma'am. Start the inauguration. Inauguration. Now we'll start with our inauguration ceremony. Hello. I request everyone to please be seated for the inauguration ceremony. And even if someone is outside, please call them as we are proceeding for our inauguration ceremony. Hello.
हम फिर इनको खड़े होने के लिए कब बोलेंगे, मतलब सबसे पहले सरस्वती का नाम किसको खड़ा होना है? गेस्ट का जैसे वेलकम करता है नॉर्मल, इसके बाद लैंप लाइटिंग के टाइम पर लैंप तो मैम
Hello. Hello. Excellence is not a destination, it is a continuous journey that never ends. A very good afternoon, everyone. On behalf of Organizing Committee of Global Association Physiotherapy Conference 2021, I, Dr. Shruti Jha, feel extremely privileged and honored to welcome all the dignitaries, delegates, and our special guests. Ladies and gentlemen, for inauguration ceremony, we have esteemed panel of guests. So I would like to welcome them. First of all, I would like to welcome हम गेस्ट का नाम भी नहीं करो। हाँ बोल दो, वेलकम बोल दो। I would like to welcome our chief guest, Shri Satyendra Kumar Jain, sir, Honorable Minister for Health, Government of Delhi. I extend my heartily welcome to Shri Ankush Dahiya, international boxer. I welcome our guest of honor, Dr. Arun Gupta, President, Delhi Medical Council. I welcome Mr. Brijesh Goyal, Chairman, Chamber of Trade and Industry. I welcome Deepak Kumar Sharma, Chief Executive Officer, River Engineering Private Limited. I also welcome Ankur Narayan Agrawal, Director, Business Development, River Engineering Private Limited. I welcome our special invitee, Dr. Naresh Kumar, General Secretary, Indian Stroke and Paralysis Foundation. Now we'll start with Saraswati Vandana. I may call Miss Anuradha Prakhar to perform Saraswati Vandana. Anuradha likha naam. Thank you, Anuradha, for such wonderful performance. Now I would like to welcome our special guests on dais. First and foremost, I would like to invite Shri Ankush Dahiya, international boxer. So please come up on the stage.
So please.
Now I would like to invite our guest of honor, Dr. Arun Gupta, President Delhi Medical Council. So please come up on the stage. Welcome, sir. Now I would like to call Mr. Brajesh Goyal, Chairman, Chamber of Trade and Industry, to please come up on the stage. Now I would like to call Mr. Deepak Kumar Sharma, Chief Executive Officer, River Engineering Private Limited. So please come up on the stage. Now I would like to request our special invitee, Dr. Naresh Kumar, General Secretary, Indian Stroke and Paralysis Foundation. So please come up on the stage. Thank you. Now I would like to call Dr. Uma Shankar Mohanty, sir, International President, Global Association for Physiotherapy, to please come up on the stage. Now I would like to call Dr. Prabhat Ranjan, sir, National President, Global Association for Physiotherapy. Sir, please come up on the stage. Now I would like to call Dr. Navneet Krishna, sir, General Secretary, Global Association for Physiotherapy, to please come up on the stage. I would like to call Dr. Mayank Pushkar, sir, to please come up on the stage. I would like to call Dr. Navneet Krishna, sir, Honorable General Secretary, to please come up on the stage. I would like to call our guest of honor, Ankur Narayan Agrawal, sir, Director, Business Development, River Engineering Private Limited, to please come up on the stage. Thank you, dignitaries. Light is a symbol of brightness and prosperity. As sunlight expels the darkness of night, similarly, blessings bring in our life prosperity and happiness. To make this event a blessed one, let's invoke Goddess Saraswati by kindling the lamp of knowledge and wisdom. I request all our honorable dignitaries to please light up the lamp. I request all our honorable dignitaries to please proceed for the lamp lighting ceremony.
इनको वेलकम करेंगे, फिर जीपीटी का मैं स्पीच दूंगी, उसके बाद सबको बुलाएंगे। किसको बुलाने पता है? सबको सबको। डॉक्टर नवनीत तो शायद नहीं बोलेंगे, नहीं बुला लेंगे, फिर भी नाम ले लेना, अगर मना करते हैं तो रहने देना।
I request all of you to please stand.
धीरे धीरे अब आप ठीक हो रहा फेलिसिटेट भी तो करवाना था।
Thank you. Thank you, dignitaries. Now, I would like to request Dr. Umashankar Mohanty sir to please welcome and facilitate our chief guest, Shri Ankush Jahia. Thank you, sir. I request Dr. Prabhat Ranjan sir to please welcome and facilitate our guest of honor, Dr. Arun Gupta sir, President, Delhi Medical Council. I request Dr. Prabhat sir to please facilitate and welcome Deepak Kumar Sharma, Chief Executive Officer, River Engineering Private Limited. Thank you, sir. I request Dr. Mayank Pushkar sir to please welcome and facilitate our guest of honor, Mr. Brijesh Goyal, Chairman, Chamber of Trade and Industry. I request Dr. Navneet Krishna sir to please welcome and felicitate Shri Ankur Narayan Agrawal, Director, Business Development, River Engineering Private Limited. Thank you, sir. Now, again, I request Dr. Umashankar Mohanty sir to please welcome and felicitate our special invitee, Dr. Naresh Kumar, General Secretary, Indian Stroke and Paralysis Foundation. Thank you. Thank you, dignitaries. We heartily welcome you. Now, before we start the proceedings, I would like to give a brief overview about Global Association for Physiotherapy. Global Association for Physiotherapy is an association for the physiotherapist, by the physiotherapist. Global Association for Physiotherapy is an association for the physiotherapist, to the physiotherapist, and by the physiotherapist. It is continuously working across the globe for propagating and promoting the physiotherapy profession along with the Sustainable Development Goals and agendas of United Nations. The aim of Global Association for Physiotherapy is to promote the development and reciprocity of physiotherapy qualification and also to improve the quality education across the globe. The component of Global Association for Physiotherapy include International Executive Board, National Executive Board, State Executive Board, District Executive Board, Women's Wing, and Students Wing. And I'm glad to introduce here our esteemed board members. First and foremost, I would like to start with Dr. Umashankar Mohanty, sir, President, International Executive Board. Dr. Mohanty sir hardly needs any introduction. Legendaries like Dr. Mohanty sir don't set out to be a leader. They set out to make a difference. It is never about the role. It's always about the goal. Dr. Umashankar Mohanty sir is our President of International Executive Board. I welcome you, sir. The more you take responsibility of our past and present, the more you are able to create the future you seek. A man behind this, our President of National Executive Board, Dr. Prabhat Ranjan, sir. I welcome you, sir. From fighting for the establishment of Central Council or to educating the student like us or even to treating numerous of patients, Dr. Umashankar Mohanty sir and Dr. Prabhat sir are truly always are someone who has truly a phenomenal contribution in always uplifting our profession. A true leader is someone who takes no credit but all of the responsibilities. So is our Honorable General Secretary, Dr. David Krishna, sir. Welcome, sir. A building cannot stand without the foundation of strong pillars, and so is Global Association for Physiotherapy cannot stand without its chief advisor, Dr. Mayank Pushkar sir and Dr. Kumar Preetham sir. A leader is someone who knows the way, shows the way, and goes the way. And so is our Dr. Pooja Tiwari, ma'am, Vice President, National Executive Board. A woman is one who walks on her own footsteps rather than following the directions shown by crowd. So is our President of Women's Wing, Dr. Sita Singh, ma'am, who is working tremendously to promote women empowerment in physiotherapy. Welcome you, ma'am. In the history, it is the first time that any association had charted students' wing, that too at global level. It was all Dr. Navneet Krishna's sir's vision to launch student wing. His vision was to basically develop the leadership qualities amongst the student and to build a foundation even before becoming them a professional. Dr. Navneet Krishna sir truly believes that the kids of today are the future of tomorrow, and being the General Secretary National of Students Wing, I, Dr. Shruti Jha, hardly express my gratitude to Dr. Navneet Krishna sir for launching the student wing and also to giving such noble opportunity. Thank you, sir. I would like to welcome Dr. Prachi Tyagi, President of Global Association for Physiotherapy Student Wing, national level. So that was a brief introduction about Global Association for Physiotherapy. Now, I request Dr. Umashankar Mohanty sir to please come up on the dais and address the welcome note. Please, sir.
Very good afternoon to all of you. I'd like to thank from the organizing team of GAPT conference of 2021, Sri Satyendra Jain ji, Honorable Health Minister of Delhi, who gave his consent and who has given his valuable message for our conference. And
Dr. Prabhat, I think we should play that message which, that message is there by the Honorable Health Minister for wishing our conference, and we'll be playing that. He had some urgent commitment. He could not come in person, but he has sent his message for our conference. And see, Ankush Dayaji, thank you for coming all the way from Sonipat. And physiotherapists play a very important role for the sports people. And you are representing the sports fraternity. And we all, our physiotherapists are extremely always committed, our best to serve the sports people, not only in India, but across the world. Dr. Arun Gupta ji, President of Delhi Medical Council. So thanks for coming and taking out your time. We need always a synergetic combination in the healthcare as a team. And you are aware that, sir, right now, the NCHP bill has come, and then I would like to congratulate all the physiotherapists of the country for putting that efforts for last nearly almost, I mean, when my involvement is concerned, I can recall that at least 11 years, you all have stood with that. And Poonam Madam is there, Rahul is there, and Jasmine Madam. You see, we have put so many efforts, and that entire credit of independent rights of physiotherapists, I think we should clap for all the efforts of all the physiotherapists of the country. Let it be various movements at Delhi, let it be various movements at Varanasi, let it be various movements at Dandi, or the 10 days long path of struggle. I think that every step, people have written emails, people have participated by postcard campaign. So at last we have got our independent practice right as a healthcare professional. That is actually our right. It was deprived from us, and I think we should thank people like Dr. Arun Gupta ji, medical fraternity, for standing and supporting with us. And we seek your support, sir, always in future. We are one of the most important, component of rehabilitation. Thank you, Brijesh Goyalji, Chairman of Chamber and Trade and Industry. Thank you for your presence, sir. Deepak Kumar Sarmaji, CEO of River Engineer. Thank you, sir, for supporting our conference in a very, a very supportive manner with a lot of enthusiasm. Special invitee, Dr. Naresh Kumar. Dr. Naresh, thank you for your always your support to stand always with the cause of physiotherapy fraternity. That is what I think it's a great thing. And Dr. Prabhat Ranjan, our National President of GAPT, one of the very enthusiastic and dynamic person I have seen in the field. We have everything. He constantly monitors, let it be government policies, negotiations, this thing. So, and he has put a lot of his efforts for this conference. And Dr. Prabhat, I cannot really, I can only appreciate you for, and keep doing the best of work, what you are doing for the profession. That always motivates each of us. Dr. Navneet has been he has been my student from Mangalore, and I have seen him constantly working for various conferences. He was the student leader during that time, and I really appreciate your that nirantar efforts, constant efforts for the organization of profession. I mean, he has been fully concentrated with focus and very dynamic and very meticulously works. My hearty appreciations for him. Dr. Mayank is one of the main person for a lot of activities. He's doing teaching, academic activities and all. So keep doing your good work. So I think our entire team of professionals are here. I am really very extremely delighted to see all of you. Physiotherapy today, as I mentioned, not only the government of India, earlier we heard the Delhi Council, Maharashtra Council, even World Health Organization defines physiotherapy as one of the key healthcare profession. And responsibility of that lies with each of us. We should not just look for somebody to come and lead. the profession has given you all the assignments. When you are treating one patient, you are representing all 8 lakh physiotherapists of the world. I mean, that much is your responsibility, right? And there is one saying, मंजिलें उन्हीं को मिलती है जिनके इरादों में जान होती है, पंखों से कुछ नहीं होता, हौसलों से उड़ान होती है. Right is there, definition is there, everything is there, but every single patient should get the best from us. That should be our goal and motto. We may make huge organizations, we may make huge clinics, but if the service is not reaching to the common man, then there is no use for the organization, for that individual. And for us, every single individual is important and every single individual matters. That is something very, very important. And Global Association, I'd like to tell that once we have achieved the independent practice right for Indian physios, practice right, and then council is also, separate council is also coming, in that provision is there for physiotherapists. There is similar difficulties across the world. And organizations might be there, but then I think that the extent, because we have remembered that when we were struggling in India, we didn't find any international organization coming and standing with us in our fights and in our rights. So that is why we have decided that whichever country needs the support of physiotherapy patent. Many countries have their individual issues, individual rights issues are there. So there we should stand as a team. And I'm happy that our vice president is from France, a very senior physiotherapist, Dr. Luan. And he was one of the key person in the Barcelona Olympics. And soon so many other international people from across the world are going to join. We had great celebration of World Physiotherapy Day. We had celebration at USA, at some places in Michigan. We were planning to celebrate during that time, but lockdown were there in some of the countries. So next year, GAPT is planning to celebrate World Physiotherapy Day in at least 25 countries. That is our motto. That's what we are expecting. And one more thing, what is our work? We can work everything in the domain of SDGs, Sustainable Development Goals. I will request all of you, to being one healthcare profession, please read the Sustainable Development Goals and Millennium Development Goals of the United Nations. Right? The goal 3 is something very, very important. We are working strongly on that. Health for every human on earth. So our agenda is physiotherapy, as physiotherapists, physiotherapy for every single human on the globe. So wherever you can, whichever place you can, irrespective of religion, caste, creed, country, we are healers and we have to heal the entire humanity. So extremely delighted to see some of the senior faculties, Dr. Jasmine Madam, Dr. Saurabh, Dr. Bhaskar, Dr. Poonam, Lamba Sir, Dr. Piyush, Dr. Yaspal, Dr. Kanaya, Dr. Mehul Contractor, Dr. Jyoti, Dr. Sita, all our dynamic team of professionals, Dr. Shruti, Dr. Prachi, Dr. Divya, Dr. Deepika, Dr. Ria, Dr. Saraswati, and to all the, kindly forgive me if I am not taking your name, but you live in the deep core of our heart, and let us together make some big difference to the society at large and make our profession extremely proud. At last I can just tell you, जिंदगी की असली उड़ान अभी बाकी है, हमारे इरादों का इम्तिहान अभी बाकी है, अभी तो नापी है मुट्ठी भर जमीन हमने, आगे अभी सारा आसमान बाकी है. Thank you.
Thank you, sir, for such inspirational words. Now I would like to request Dr. Prabhat Ranjan, sir, to please come up on the stage and say a few words.
So dignitaries, very good afternoon to all of you. Dignitaries sitting on the dais, international boxer, Mr. Ankush ji, Delhi Medical Council President, Dr. Arun Gupta sir, Trade and Chambers Chairman, Dr. Mr. Brijesh Goyal, my very near and dear friend and support, Dr. Naresh Gupta, my guidance as a mentor, Dr. Umashankar Mohanty sir, my friend, Dr. Mayank, Dr. Navneet, who is also the General Secretary, and a key eminent person sitting in the front row, like Dr. B.K. Lamba sir, who is like a father figure, Dr. Bhaskar, and continuous support and guide from Dr. Jasmine madam, and Dr. Poonam ma'am, my colleague, Dr. Parul, Rahul, my friend Sujit is here, Dr. Bhaskar Munjal is here, Dr. Sohrab, and other faculty members from Rajasthan also, Kanaya Pramar and Dr. Raj Purohit, Yashpal Raj Purohit is there. So I welcome all of you. And above all, I am standing on this podium because of the lady sitting at the back. She is Amurai, my wife, and continuous support from her. Because of that only I'm standing here and I am able to do whatever Dr. Mohanty sir told that about the profession and all that. It is because of her support only. So a lot has been said about the Global Association for Physiotherapy. Dr. Shruti also explained about it. And Mohanty sir also explained about the aim and objective and the ideas behind the Global Association for Physiotherapy. This association was started with an idea to unite the physiotherapists across the world and exchange the scientific ideas, whatever administrative ideas are there, that how the functioning is there, how the administration works there for the upliftment of the profession. And it was established in the month of April of 2021. And in this very short span of time, we are getting good support and good amount of support for that. And I really thank all the people who are supporting the idea behind this, because this is one of the key factor regarding the growth of the association also. And we are committed for our professional growth. That is the main idea behind that. We have to catch up with the international standards, what is there, and accordingly in India also we have to establish the international standards so that our physiotherapists should be empowered to get their due, which is due from last 60 years. But now slowly and gradually the government is also taking interest, people are also pushing, and in that form, at least a minimum standard regulation is there is formed in the form of a National Council for Allied and Healthcare Professional Bill or Act. You can say now it is an act. So that act give us a right to practice at least independently, because earlier it was very ambiguous state whether physiotherapists can work independently or not. But now at least the minimum standards has been set, and accordingly our practice will also develop. And since Dr. Arun Gupta sir is here, and he is one of the key member in planning or executing the healthcare system, especially in Delhi, so I will request him that on the pattern of a National Commission for Allied and Healthcare Professional Act, here also the council should be formed, or we are having a council here, Delhi Council for Physiotherapy. That is also an independent council. But what is there is some flaw in that council, that the colleges, the physiotherapists passing from that college are also not getting permanent membership in that, due to that schedule act, whatever the act schedule says, and that is the hindrance in getting the permanent membership to the physiotherapists who are from this Delhi itself, Delhi state itself. So I will request that at least try to amend that schedule, that each and every person should at least from Delhi should get the registration, and they should get the license to practice effectively in Delhi, and that will also curb the malpractice happening around our system. So that's why I request sir to either get that schedule change, and I think that schedule change will be much better because we are having an independent council. Or you can implement the provisions made under the National Commission for Allied and Healthcare Professional Will Act that also will serve the purpose of Delhi physiotherapist. So this I will request, sir, this is my humble request to you. So to kindly look into the matter as you are in planning and policy of Delhi healthcare system. So this is my humble request, sir. So try, sir, that it should be implemented as early as possible because the date has passed. Earlier, what happened that when the NCHP Act was implemented, then there was a clause that within 6 months of the formation of the council in every state should come. But that has passed. Now there has been removal of difficulties through an ordinance, and the central government of India has provided another 6 months for the formation of the state council as per the provisions made in the National Commission for Allied and Healthcare Professional Act. So accordingly, sir, you are the better person to do that, and I will request to at least heed to our request. So before this is the key just which we need at least at present, and this is an important thing at least for the practice and development of the physiotherapy. So before ending to my words, I will thank to Petrimed CA, the Deepak Sharma ji and Ankur Agarwal ji, they have supported us immensely, and I think that because of their support only we are here as a group, and we are exchanging our ideas, whatever scientific deliberation is happening here. This Petrimed CA company is working on air purification. It is a complete air purification system which is based on the ionization and all that. Nowadays pollution is at very high level. That's why these things are now coming up, and as a physiotherapist also it is very important that we should recommend these things to the subject, because to the person, because due to pollution, lungs diseases, a lot of pulmonary diseases are coming up. So these will at least help in reducing the impact of the pollution. So that is very important. So I also congratulate them for bringing this product in the market for the benefit of the society. Then SPRY, they are also our good supporter. They are into the planning of execution of the treatment of the physiotherapist, and they are making some software, and accordingly I think that you should go into these all the stalls with exhibitions. This will give you a better idea that how they are working for the benefit of the physiotherapist. Then I will also thank to the Physio Times, especially Dr. Anuva Singh and Anant Singh, and I think Sonia Srivastav is also here. So they have also been continuously supporting us. They are also our media partner, and that souvenir which you are seeing, they have designed it, and very beautifully designed souvenir is that, and so I thank them, and they have done a great job for the souvenir, and we are looking forward ahead for more other the association with the Physio Times for the exchange of the scientific ideas. So thank you very much. Thank you all of you. Thank you for coming here, and I think that 2 days we are here. We will have a good exchange of ideas, and we will have a good bonding, social bonding also, because apart from social bonding, professional bonding, social bonding is also very important. Thank you. Thank you very much.
Thank you, sir, for your inspirational words. Now I would like to call Shri Ankush Dahiya ji, international renowned boxer. Ankush Dahiya has won a silver medal in Asian Championship, bronze medal in World Championship, and gold medal in National Boxing Championship. I request sir to please come upon the stage and say a few words.
नमस्कार सभी को। मुझे सुनकर बहुत अच्छा लगा कि जो मेरी फिजियो है मोन्टू लांबा, उन्होंने मुझे बताया कि फिजियोथेरेपिस्ट कॉन्फ्रेंस होने वाली है, तो उन्होंने मुझे बताया कि ऐसे यहाँ पे आना है। तो
इसलिए मुझे बहुत अच्छा लगा। एक खिलाड़ी की जिंदगी में एक फिजियोथेरेपिस्ट का बहुत बड़ा अहम रोल होता है, क्योंकि अगर खिलाड़ी को इंजरी हो जाती है तो फिजियोथेरेपिस्ट ही है जो उसको उस इंजरी से उबार सकता है। एक खिलाड़ी की जिंदगी में पता नहीं जब इसको इंजरी हो जाती है तो कितने कितने उतार चढ़ाव देखने पड़ते हैं, लेकिन जो एक फिजियोथेरेपिस्ट होता है उसको वो उस चीज से उबारता है और उसको मोटिवेशन करता है और उसको ऊपर लेके आता है। तो आपका हम ये दुआ करेंगे कि आप सभी ऐसे काम करते रहे और हम अपने देश के लिए ओलंपिक्स में और मेडल लेके आए। जय हिंद, जय भारत।
Thank you so much, sir. Now I would like to invite Shri Ankur Narayan Agrawal, sir, Director, Business Development, Trevor Engineering Private Limited, to come forward and say a few words.
Thank you. Respected chief guest, Shri international boxer Ankush Dahiya, and other distinguished doctors on the dais. It is my privilege to be with you, that amongst the galaxy of the doctors of eminence in the physiotherapy and the sectors of medical sciences. I believe that physiotherapists play a very important role. You provide basically mobility to the joints, and you play an important role not only in the sports, the sports person, maybe in some medical field. Air pollution and the mobility of the joints has got a direct relationship. The bad quality of air becomes stumbling block in physiotherapeutic mechanism of the organs. The various research studies also reveals that the air quality of the desired level improves upon the mobility of the joints. We at Petrimed had designed and state of the art the technology, this air purification system. It is basically a 3-story, what we call a 3-story, that this comprises of a first process is the filtration, second is the disinfection, and the third process is ionization. So we say that we don't provide an ordinary air purifier, we provide an air purification system, and it's a complete package. Everyone is asking me why it is so expensive, because it costs around 60,000. But I believe that we cannot compare this cost to cost of lungs. So obviously, like if we are going, the cost of lungs is more. So I think we can, and we have also like different some marketing schemes and all. We can talk there. Thank you.
Thank you, sir. Now I request Shri Deepak Kumar Sharma, sir, to please come up on the stage and say a few words.
Good afternoon, everyone here. The guests on the dais, delegates, speakers, and ladies and gentlemen. My name is Deepak Sharma. I represent River Engineering Private Limited. We are here in this event. Thank you. So we are supporting this event, but I'm really surprised when one of the guests here on the dais said that the physiotherapist got the license to practice independently very recently. It's a. Pardon me? Law was made first time. Okay, the law came into being for the first time. What I remember from my experience, being in the hospitals, attending my family or friends or relatives, the most human touch which came in the system in the hospitals was from the physiotherapist. I still remember my mother lying in the hospital, and the only time when her face will brighten up when she will see a physiotherapist coming to the room with a smile on the face and asking about the pain. The rest of the time, everybody was just talking about the pills and the injections or the other drugs. Nobody was giving that human touch. So I'm really delighted standing on this dais right now and being in the company of the physiotherapist. And I wish you all a very success in your career and taking this practice to the highest level of professionalism. Talking about my company and the solutions we offer, we are primarily a engineering company. We have a lot of products and solutions which are highly technical in nature. Because we understand the technology and the quality aspect of any manufacturing, though we decided to come up with a solution which can be used in the healthcare system. That's how the PatriMed CA came into being. And this product, as my product expert mentioned, and my colleague Mr. Ankur also mentioned about the different kind of technology which is going into it, which makes it different from many other similar products. So as he rightly said, that we cannot really compare the costs here. What matters most is the output and the result. So I will not be taking much of your time on the dais. I will request, once the events gets over or whenever you have time, you please just turn around, you on your back. There is a site, there is the exhibition. We have put up all the products we are offering, and this system, the purification system, is also one of them. And try to find out more details about it. And if you, we will really be very happy if you can give us more and more questions so that we can further improvise if there is something which is missing here, though we are sure that there's nothing missing. With these words, thank you very much.
Thank you so much, sir. Now it's the time to release our souvenir. I request all our dignitaries to please release the souvenir of our first GAPT conference 2021. Thank you so much, sir. Now I would request Dr. Arun Gupta, sir, President, Delhi Medical Council, to please come forward and say a few words.
Good afternoon, everyone. First of all, I must compliment and congratulate all the office parents of Physiotherapy Association for making such a robust organization, and I wish you all the best. On the dais, my elder brother Brijesh ji, thanks for coming, and Naresh, Dr. Naresh Gupta is known to me for so many years. Such an enthusiastic person and such a great worker, such a person, such a vision. He always organizes such kind of meetings. Thank you, Naresh ji. When I entered this hall, I noticed three things very distinctly. Number one, the kind of enthusiasm you all have here. पूरा hall packed है, लोग side में खड़े हुए हैं. So that shows that your enthusiasm physiotherapist for your cause. Clap for yourself. Second thing that I noticed, almost 80% of people sitting are very young. So that means our youngsters have a lot of faith in this branch. So this branch has a great future, I would say. And third thing I noticed, right, almost 50% are girls, more than 50% maybe. That is again a very good thing, because once the girls decide to take a profession, it changes not only society, it changes family as well. So I must compliment you all for three things which I really noticed here. And as a president of Delhi Medical Council and as a maybe think tank of Delhi government, even it came to surprise to me as that first time you got a license to practice independently. Because I think physiotherapists have been practicing independently, but what is the law? What is the law? I don't know. But it's really surprising that for this thing, even you have to struggle. That says the state of the country. And as far as the provision of a council in Delhi is concerned, that will do nothing big about that. So for that आप बाद में नरेश जी आप लोगों का कोई 4-5 लोग बैठ जाइएगा बात कर लीजिएगा मेरे को डिटेल्स नहीं पता इसका क्या कहानी so whatever details you have and then we can talk to our health minister and himself is a professional, he is a very understanding person. I think that can be done very easily. पर मुझे क्योंकि इसकी कहानी नहीं पता बैकग्राउंड क्या तो एक बार मुझसे बैठ जाएगा that will do. इसकी बात जाते हैं फिजियोथेरेपी की बात है. I think when we got independence like 1947 our average life was 37 years. Now average life in India is 69 years. So longevity is increasing. Now medical services are increasing. So now the 40s are now 60s or 80s. I'll find so many people in 80s and 90s. It's very common. New young is 60, 70. So the moment your longevity increases, the need of physiotherapists will also increase. It's not about orthopedics only. Now practically every aspect of human spectrum, they will need some physiotherapy because you need to like live longer and your body has to respond to greater or ever emerging challenge of later age also. So I think that this branch has very good future and I think we will all be very busy in the coming days. One aspect I would like to highlight here, it's not about curative physiotherapy. I think that you must have a preventive physiotherapy as well. So because we all have a very sedentary lifestyle, most of us, and especially of the advent of the social media and something, the kind of physical activity we used to get is getting low, even for the children. I'm a pediatrician as well. So obesity is a big problem in children also. So here comes the role of the physiotherapist for the preventive physiotherapy. So that's so as to make these children happy and healthy. So I think this thing should be in the mind, and whenever you practice, you maybe you're doing something to mother or grandmother or grandfather, but at the same time you must teach them to take care of children at home so that they can spend some time in parks and doing some physical activity. And any other issue you can talk to me, and it's no issue. Naresh is a very old friend of ours. So any help from Delhi. One thing I noticed here also, I just came to my mind. We have opened almost 500 Mohalla clinics, and we have 40 Delhi government hospital beside 100 more than 100 polyclinics. Brijesh ji, do you think we should have a independent units for physiotherapy as well? होने चाहिए ना, क्योंकि फिजियोथेरेपी की जरूरत सबको है. आप पार्क्स में लोग बैठे होते हैं कर रहे थे, पर उनको कोई अगर हम इस तरह की लाइन पे हम मोहल्ला क्लिनिक लाइन पे फिजियोथेरेपी क्लिनिक्स खोल दें, दिल्ली में 200, 400, 500 भी कम पड़ेंगे मुझे लगता है. तो इससे बड़ी इन्वेस्टमेंट सरकार के लिए कुछ नहीं है. बीमारी में इन्वेस्ट करके क्या फायदा अगर आप पहले ही उनको हर कॉलोनी में एक फिजियोथेरेपी यूनिट खोल दें. बच्चे यंगस्टर्स बहुत है हमारे पास, आपको वहां हम जॉब दे देंगे, आप जाएं उनको सिखाएं. तो आई थिंक दैट विल गेट सर्विस. तो ये प्रपोजल भी मेरे दिमाग में अपनी तरफ से आया, तो दैट विल पुट टू द हेल्थ मिनिस्टर और आई थिंक दे विल डू. और बाकी स्पोर्ट्स की बात हुई तो मुझे ऐसा लगता है कि जो लोग स्पोर्ट्स को फॉलो करते हैं उनके लिए फिजियोथेरेपिस्ट भी हीरो होते हैं. आप लोग हमारे हीरो, ऐसी बात नहीं है. अगर आपने देखा कि बड़े स्पोर्ट्स मैच के कैरियर खराब हो जाते हैं बिकॉज छोटी सी इंजरी की वजह से, और ज्यादातर ये मालूम पड़ता है कि उसको इंजरी इसलिए हुई थी कि उसने अपने आप को पहले से ठीक नहीं रखा था. तो कुछ क्रिकेट प्लेयर बड़े नोटोरियस थे कि पूरी सीरीज कभी पूरी नहीं करते थे, आधे में इंजरियों को निकल जाते थे, तो उनका कैरियर खराब हो जाता है. तो आई थिंक स्टार्स एंड हीरोज फिजियोथेरेपी में भी निकलेंगे, तो मुझे लगता है बिग चांस फॉर ऑल ऑफ यू. थैंक यू वेरी मच.
Thank you, sir. Now I would like to request Shri Brajesh Goyal, sir, to please come forward and say a few words.
सभी को नमस्कार. सबसे पहले तो डॉक्टर प्रभात रंजन जी, उमा शंकर मोहंती जी और ग्लोबल एसोसिएशन ऑफ फिजियोथेरेपी की पूरी टीम को बहुत बहुत शुभकामनाएं, बहुत बहुत बधाई आज के कार्यक्रम के शानदार आयोजन के लिए. और हमारे बीच में दिल्ली मेडिकल काउंसिल, दिल्ली सरकार के प्रेसिडेंट डॉक्टर अरुण गुप्ता जी हैं. हमारा सौभाग्य कि
उन्होंने अपना कीमती समय निकाल के यहाँ पे पधारे हैं, क्योंकि देखिए दिल्ली सरकार हेल्थ केयर को लेके, हेल्थ इंडस्ट्री को लेके क्या क्या कदम उठा रही है, क्या क्या नई नई पॉलिसीज बनती हैं, उसको डॉक्टर अरुण गुप्ता रिप्रेजेंट करते हैं। और जैसा कि उन्होंने बताया कि हम चाहते हैं कि दिल्ली में एक फिजियोथेरेपी के लिए भी अलग से कुछ बने, क्योंकि अभी 2 दिन पहले ही दिल्ली गवर्नमेंट ने योगा के ऊपर एक योगशाला, आपने देखा होगा, अभी कल परसों आया था कि एक योगशाला माननीय मुख्यमंत्री जी ने शुरू किया है कि योगा टीचर जाएंगे और योग सिखाएंगे। तो डॉक्टर साहब, मुझे लगता है ये एक अच्छा कॉन्सेप्ट निकल के आया है कि हम फिजियोथेरेपी के लिए भी, क्योंकि देखिए आज का जो जमाना है, मुझे लगता है फिजियोथेरेपी का जमाना है और आने वाला भी है, क्योंकि भागदौड़ की जिंदगी आज की ऐसी हो गई है, लोगों के पास ना वॉक करने का टाइम है, ना एक्सरसाइज का टाइम है, ना योगा करने का समय, बैठना कैसे ये नहीं पता, सोना कैसे, उठना कैसे, पोस्चर्स इतने खराब हो गए हैं, तो कहीं किसी के जोड़ों में दर्द है, कभी शोल्डर में पेन है, मतलब हर तीसरा आदमी परेशान है किसी ना किसी पेन को लेके। मतलब इंजरीज, स्पोर्ट्स इंजरीज तो बहुत अलग चीज है, आम लोगों के जीवन में भी इतनी तरह की कॉम्प्लिकेशंस पैदा हो गई हैं, क्योंकि एक्सरसाइज, योगा, वॉक सब खत्म हो गया है, खान पान ऐसा हो गया है। तो फिजियोथेरेपी मुझे लगता है आज के जमाने में, और बिना किसी साइड इफेक्ट के, कहते हैं ना मेडिसिन लेस, बिना किसी दवाई की एक ऐसी ट्रीटमेंट है, एक ऐसा उपचार है जो दवाई की जरूरत नहीं है। और ऐसे ऐसे लोगों को मैंने देखा है, ऐसे ऐसे पेशेंट देखे हैं जिनका पेन किलर खा रहे हैं, दवाइयां खाई, उससे ठीक नहीं हुआ, और फिजियोथेरेपी कराई, उससे उनका दर्द ठीक हो गया। तो फिजियोथेरेपी एक आज के जमाने की बहुत ही एसेंशियल चीज हो गई है लोगों के लिए, मतलब एक तरह से योगा एक्सरसाइज की तरह ही ले। और मुझे याद है, मैं खुद एक्सपीरियंस होल्डर हूं इसको लेके, क्योंकि आज से लगभग 2-3 साल पहले मेरी मदर को स्पाइन टीबी हुआ, रीढ़ की हड्डी में टीबी हो गई मेरी माताजी को, और टीबी का ट्रीटमेंट तो हमने एलोपैथिक दवाइयों के द्वारा करवाया उनका। उसके बाद में उन्होंने बेड पूरी तरह से, वो कहते हैं ना, बिस्तर पकड़ लिया उन्होंने। शी इज 70 years old, तो भी 2 साल पहले की बात है, तो वो बिस्तर से उठ नहीं पाई, मतलब सब कुछ, लेटरिंग, पेशाब, खाना पीना सब बिस्तर पे ही 5-6 महीने तक ऐसा रहा। हम लोग इतना परेशान, मैंने कहा यार मम्मी की इतना कैसे करेंगी, मम्मी कैसे आगे चलेंगी। तो डॉक्टर साहब से बात हुई, डॉक्टर नरेश गुप्ता मेरे बड़े भाई भी हैं, मेरे अच्छे मित्र हैं, बहुत पुराने मेरे साथी हैं। तो डॉक्टर नरेश गुप्ता से हमने बात की कि डॉक्टर साहब ऐसे ऐसे माताजी की तबीयत ऐसे है, अब टीबी तो ठीक हो गई है, लेकिन अब माताजी चल नहीं पाती हैं, उठ नहीं पाती हैं, और हड्डियां पूरी जाम हो गई है उनकी। तो कह रहा है कि आप मेरे सेंटर में लेके आओ, फिजियोथेरेपी सेंटर, और जो सरस्वती विहार पीतमपुरा, इन्होंने जो फिजियोथेरेपी सेंटर है
Gupta at right time, right place and right, कहते हैं ना सही समय पे हथौड़ा मार देना, तो मार दिया. So waiting for the new formulation of Delhi Council of Physiotherapy. बहुत परेशान करते हैं ना हर साल रजिस्ट्रेशन करा के. मतलब totally we faced, मतलब I don't have a word what to say for our council. Sir हर साल बुला लेते हैं, रजिस्ट्रेशन कराओ, रिन्यू.
पैसे खाने के लिए बुलाते हैं,
ठीक है. So I don't take your much time and I finally समय आ गया फिजियोथेरेपी के लिए कुछ हमें करना है और I always spend my whole time for physiotherapy fraternity. Thank you very much.
I've been a president of Delhi Medical Council for last 6 years. अब हमने क्या कर दिया है, एक तो उसको 5 years का कर दिया है पूरा का पूरा, ठीक है. Secondly, everything is online. आपको जाने की जरूरत ही नहीं. पैसे कैसे खा लेगा कोई? फिक्स पॉइंट से आप डालो, उसमें घर से ही रजिस्ट्रेशन आपको डाउनलोड कर लो, प्रिंट आउट लेने की जाने की जरूरत भी नहीं. कर देंगे आपके, अभी क्या दिक्कत है?
सर्वे में क्या कराते हैं वो ऑनलाइन, हमें अपॉइंटमेंट देते हैं 1 महीने बाद. 1 महीने बाद उसके बाद क्या कहते हैं सर्टिफिकेट मंगाते हैं सारे पुराने भी.
ये देखो सिस्टम ये खराब क्यों कहते हैं, इसलिए क्या जाता है कि ताकि आपसे पैसे लिए जाए. तो करप्ट सिस्टम है ना, और क्या रीजन है. मेरे आने के बाद दिल्ली मेडिकल काउंसिल में किसी को जाने की जरूरत नहीं, डॉक्टर को घर बैठे बैठे वो लोग फॉर्म भरते हैं और वहीं डाउनलोड कर लेते हैं सर्टिफिकेट. हम किसी को बुलाते ही नहीं है. आपका भी करा देंगे, करा देंगे.
ये तो बताओ आपसे क्या हो रही है?
पूरी बातें
कौन से जानू में कौन से हुई है वो?
ये तो ऐसा ना, ठीक है. देखो दिल्ली मेडिकल काउंसिल का पहले हमारा ऑफिस था मौलाना मेडिकल कॉलेज के ऊपर. अब हमने एक नई बिल्डिंग ले ली, काफी बना दी. पर मैं कहता हूँ जान के करना क्या क्या खुला हुआ है, होनी नहीं चाहिए बिल्डिंग, तो सब कुछ ऑनलाइन काम होना चाहिए. जान के करना क्या है. अब हमारे दिल्ली के अंदर आरटीओ जानते हैं, आरटीओ रोड ट्रांसपोर्ट होता है, जहाँ लाइसेंस वगैरह बनते हैं. पहले अगर किसी ने लाइसेंस बनाया पता होगा, कई चक्कर लगाने पड़ते हैं, कई हजार रुपए घूस देनी पड़ती, तो भी नहीं बनता. अब सब अरविंद केजरीवाल जी ने सारे बंद करवा दिए हैं. सारा काम ऑनलाइन होता है. 1076 नंबर मिलाइए, घर में आकर लाइसेंस मिलता है. तो आपको जानने की जरूरत क्या है कहाँ खुला है काउंसिल. ताला लगा दो काउंसिल के अंदर, कोई दिक्कत नहीं.
Thank you, sir. Now I request to play the video message of Shri Satyendra Kumar Jain, sir, Honorable Minister for Health, Government of Delhi.
राष्ट्रीय सम्मेलन के आयोजन पर देश से सम्मिलित हो रहे सभी फिजिकल थेरेपिस्ट को शुभकामनाएं देता हूँ. इस सम्मेलन का जो विषय है ग्लोबल डेवलपमेंट एंड ट्रेंड्स इन फिजियोथेरेपी, वो आज के संदर्भ में बहुत शामिल है. आशा करता हूँ कि इस पर होने वाले अनुसंधान के ऊपर विचार करने के बाद समाज के सभी लोगों का इसका लाभ प्राप्त होगा. मैं आयोजन समिति के अध्यक्ष डॉक्टर प्रभात सिंह को इस सम्मेलन के सफल आयोजन के लिए शुभकामनाएं देता हूँ. मेरी ओर से सभी पार्टिसिपेंट्स को और सभी डॉक्टर्स को बहुत बहुत बधाई.
Thank you so much. I request all the dignitaries to please take seats. Now I request Dr. Prabhat Ranjan, sir, to please felicitate Dr. Arun Gupta, sir, President, Delhi Medical Council.
Very good, sir. Very जल्दी.
Thank you, sir. I also request Dr. Prabhat sir to please felicitate Dr. Brijesh Goyal sir, Chairman, Chamber of Trade and Industry. Okay. Thank you, sir. Now I would. Okay. I would like to request Dr. Prabhat sir to please facilitate Dr. Naresh sir. अंकुर और दीपक ठीक है ठीक है I would like to request Dr. Umashankar Mohanty sir to please felicitate Deepak Kumar Sharma, Chief Executive Officer, River Engineering Private Limited. I would like to request Dr. Umashankar Mohanty sir to please felicitate Ankur Narayan Agrawal, Director of Business Development. Thank you so much, sir. Now I would like to request Dr. Sita Singh ma'am, President, Women's Wing GAPT, to please propose vote of thanks and conclude the inaugural ceremony.
A hearty vote of thanks to our chief guest, Sri Satyendra Kumar Jain, Honorable Ministers for Health, Government of Delhi. Special thanks to all our speakers for delivering their valuable knowledge among physiotherapy students and physiotherapy professions and to take out their valuable time for us. Thanks to the sponsorship provided by the company Petrimed CA Physio Biomed Export. Petrimed CA is a care for lung air purification system designed with efficency of filter 99.99% with the ionizer and UVC disinfectors. The second sponsor is Physio Biomed Expert Company, which is a supplying physiotherapy equipment. Last but not the least, I would like to thanks to all the students and physio who are participating in the conferences, and thanks to all for gathering and making this conference successful. Thank you.
I would like to request Dr. Umashankar Mohanty sir to please felicitate Deepak Kumar Sharma, sir. Okay.
Facilitation of Dr. Umashankar Mohanty sir on behalf of River Engineering by Dr. Deepak Sharma and Ankur Agarwal.
Thank you, sir. Now I would like to request to all of you to please stand for the national anthem. I would request all the delegates and dignitaries to please proceed for lunch and join back after half an hour. Thank you.
હલો આ બધા કેમ કશું ચાલુ કેમ નહીં થતું બે ના ના એવું ના થયું તમે તો બેસી કેમ રહ્યા છો
Hello. Can anyone hear me?
Yes, sir.
Great, thank you. Is there an organizer I can talk to here? I'm the next presenter, so I just want to make sure that everything is okay. Did the presentation before me is completed? Mrs. Dr. Since it's 3:40 p.m. in India, let me get started, okay? So I'm going to share my screen. Since Ms. Patel, you just let me know that you can all hear me. So I'm assuming you can all hear me. So let me just share my screen. And if one of you can let me know once you see my presentation. Okay, can you all see my presentation? Can someone let me know? Kushali, can you let me know?
Yes, sir.
Okay, great, fantastic. So let me get started then. My name is Dr. Kunal Banod. I am a program director. I am a program director and an associate professor at in a Doctor of Physical Therapy program at Carlow University in Pittsburgh, Pennsylvania, in United States. I'm originally from India. I have completed my bachelor's in physical therapy or physiotherapy, as we say in India, a master's in kinesiology. I majored in biomechanics, and my PhD was in orthopedics and sports science. And I have a manual therapy certification, dry needling certification, and I'm a fellow of the American Academy of Orthopedic Manual Physical Therapist. I've been a physical therapist for over 15 years now. I've been a professor at a Doctor of Physical Therapy school in about 8-9 years, and I've been a program director for about 2-3 years now. So that's about me, and my clinical practice have always revolved around seeing musculoskeletal patients and mostly neck pain and back pain. So let's talk about low back pain. We all know it's a global problem. Low back pain is one of the most common diagnoses seen by physical therapists in their daily practice, specifically in outpatient physical therapy, who specializes in musculoskeletal physical therapy. It's considered a leading cause of disability worldwide, actually, including India and United States. The cost of managing the low back pain is increasing exponentially, as we know, putting a lot of additional burden on already stressed, economically stressed healthcare systems everywhere in the world. People go to emergency rooms and make doctor appointments for low back pain very, very commonly. And we all know that they're most of the time prescribed with medications, anti-inflammatory or codeine medications, and it provides them limited benefit out of that. Cases of chronic low back pain are significantly increasing and without any improvements in overall clinical outcomes. So we're giving them more medication, we're giving them treatments all these years, but the problem is just getting bigger and bigger, and more low back pain is turning into chronic cases. And those are becoming even difficult to manage. So Today, what I'm going to talk about is the clinical advances in low back pain happened in the past, I would say 10, 12 years. And I think that the recommendations provided by clinical practice guidelines are something that can help you improve your patient's clinical outcomes. So what are clinical practice guidelines? So clinical practice guidelines are recommendations. Those are provided by, give me 1 second. I think something happened. Sorry, it says it said someone just stopped my sharing of my presentation. So I'm sorry about that. So clinical practice guidelines are recommendation on how to diagnose and treat medical conditions. Guidelines summarize the current medical knowledge, weigh the benefits and harms of diagnostic procedures and treatment, and give specific recommendations based on this information. They should also this information is provided based on scientific evidence supported by research. Now, how these guidelines are developed. First, a guideline committee is formed, including a specialist to cover all the important aspects of medical condition about a specific question. The committee is usually led by a member of specific association responsible for managing that condition. It collects as much information as possible from different sources and different research papers on a predetermined criteria. Various assessments and opinions of committee members are discussed and taken into consideration when writing these guidelines. And in other words, these recommendations are very consensus-based, developed by the experts in the field. So the purpose of the orthopedic clinical practice guidelines, which I will go over today, are to describe the evidence-based physical therapy practice, classify and define common musculoskeletal conditions, specifically low back pain, we will go over today, identify interventions supported by the current best evidence, identify appropriate outcome measures that would be used to assess changes resulting from physical therapy interventions, and create a reference of publication, physical therapy clinicians, academic instructions, clinical instructors, students, everybody can use in their clinical orthopedic practice. So who developed these clinical practice guidelines specifically? The Academy of Orthopedic Physical Therapy of the American Physical Therapy Association, they has an ongoing effort to create clinical practice guidelines for orthopedic physical therapy management with musculoskeletal impairment, and they're as described in WHO's International Classification of Functioning, Disability, and Health model, which we also call the ICF model. Evidence-based clinical practice guidelines, as I said, are developed by the experts in the field of orthopedic physical therapy, who critically evaluate all the published research, provide their recommendations, and these guidelines really can become an important resource for clinicians in their clinical decision making when evaluating, examining, and developing a plan of care for patients with low back pain. The clinical practice guidelines for low back pain, which we will go over today, were initially developed in 2012, about 10 years ago. It was included information regarding subgrouping the low back pain into different categories. They provided characteristics of each subgroup and recommended intervention specific to each subgroup based on the available research evidence. And they also ranked the evidence as strong, moderate, and weak. The updated recommendations for intervention strategies actually just came last month in 2021. So they just updated the intervention. So these guidelines are an excellent resource for all of us to follow in our clinical practice when treating patients with low back pain. So the purpose of today's presentation, as I said, is to go over these two clinical practice guidelines. The original one is on the top, the low back pain in 2012. And then, as I said, the 2021 updated one just came a month ago. And they're specifically focused around intervention strategies or management strategies for low back pain, acute as well as chronic. So the general recommendation of these low back pain guidelines are that the tissue is causing a patient's low back pain is mostly often unknown, thus, or at least physical therapists or even any clinician, even physicians are unsure exactly which tissue is causing the low back pain. So thus clinicians should assess for impaired function of muscle, connective and nerve tissues associated with the identified pathological tissue, which we might have some idea about when a patient presents with low back pain, which means that we should spend less emphasis on finding which exact tissue is causing the pain and more on addressing the sign and symptoms of the patient. The association between clinical complaints and concurrent pathological examination with radiological findings must be considered cautiously. And that is where I can highly emphasize that radiological findings must be considered very cautiously, because we overly emphasize on radiological findings such as X-ray findings and MRI findings, where we see a disc which is protruded, we see degenerative changes, and then we automatically assume these changes are causing low back pains. And several studies have showed inconsistencies between patients' symptoms, cause of symptoms, and even radiological findings. And further, even when abnormalities are presented, establishing a direct cause and effect, as I said, between the pathological finding and patient's condition has proven to be very elusive and most often does not assist greatly in patient management. So be very careful in assuming what you see on MRI and X-ray to be the cause of low back pain. We as a physical therapist should rely on our physical examination of the patient. So the clinical practice guidelines have recommended in the following categories: the examination and clinical findings, the diagnosis, and intervention. So before we actually delve into recommended examination, test, and measures, I would like to point to the importance of using functional and objective outcome measures. These outcome measures provide an assessment of patients' functional disability during low back pain episode. As a physiotherapist, I think we care about not only reducing patients' pain, but also improving their functional independence. And I've personally used modified Swiss-Tree Disability Index. I asked the patient to fill it during initial evaluation, reassessment, and a discharge. And besides assessing improvement in my objective test and measures and pain scale, the index provide me a good measure of improvement in patients' functional activities, which are most important to them. So I would highly recommend all of you to use one of these outcome measures to measure their functional disability during your initial assessment. And I would also emphasize in using one of these outcome measure, they are a measure of patient's psychological disability due to low back pain. There is plethora of literature on how pain perception versus actual injury does not correlate in many patients. I'm sure you have worked with those patients whose pain number might be too high when you compare it to their injury itself or their mechanism of injury when you take their history. And these outcome measures gives you an objective data of their pain perception, and you can tailor your intervention accordingly. I will go over the details later in this presentation on how to tailor your presentation accordingly if the patient scores high on one of these outcome measures. So they kind of sort of gives you a yellow flag, so to speak. Fear avoidance belief questionnaire tells you about kinesiophobia, that patient is afraid of moving due to their pain. And pain catastrophizing scale is that they catastrophize their pain. They perceive their pain to be too much when the injury might not be that much. And they're not making it up, just so be clear, that's how they feel. And it's not that they're lying to you, but that's how they feel. They catastrophize it a lot. So again, these are some of the objective examination test and measure we all use, and I'm sure you use as well, recommended in these guidelines to assess a patient's with low back pain. Usually I start my examination after taking a thorough history with structural examination and look at structural abnormalities. But after that, I usually follow with the lumbar active range of motion in all different directions. I look for if the range of motion is limited due to deficit or due to pain. Is it full? Is it smooth? Is it aberrant or jerky? Followed by segmental mobility testing, performing the unilateral posterior anterior motion or a central posterolateral motion. You must have learned some Maitland techniques. And also looking at segmental mobility using manual therapy techniques. I then try to perform a pain provocation test, try to push it a little bit more harder to see if it reproduces their pain during that mobility segmental testing. I also perform a prone instability test, which also gives you an idea of the clinical instability. Straight leg raise test or a crossed straight leg raise test, they both are good objective measure for any kind of radiculopathy, radiculitis. Slump test is also another good one to use for any kind of nerve impingement and nerve inflammation. And then I also ask them to perform specific movement which causes pain. Sometimes it's spinal extension, and then I would ask them to repeat to repetitive spinal extension. Does it lead to some kind of a directional preference, which means does that pain goes down or does that pain goes up? And it tells me a lot about that if what treatment strategy I need to use to reduce their pain. And then finally, I look into measuring their trunk muscle power and endurance testing, along with hip range of motion testing and hip strength testing. I think they all are good measures which can be used in these patients to help with improving their low back, in assessing their low back pain. And then a special mention to adding sacroiliac joint testing as well, as for differential diagnosis to make sure the patient pain is coming from low back pain and not from sacroiliac joint pain, and especially when they have buttock pain. So these are the 6 criteria or categories which are recommended in the clinical practice guidelines. Before I go over them, I wanted to say that most patients would fit in more than one category at the same time. So however, there are times when they fit into one category exclusively, but mostly my experience is that they fit in more than one category. Low back pain with mobility deficit, low back pain with radiating pain and or referred pain. And it's pretty much referred or leg pain, radiating pain is in the leg, movement coordination impairment, and then related cognitive and affective tendencies and generalized low back pain. These are the 6 which are categorized in the clinical practice guidelines, and I would specifically go over each of them now in detail. So let's go over low back pain with mobility deficit. Usually in clinical findings during your examination, you would find it's mostly an acute or subacute condition. Sometimes can happen in chronic conditions with patients with spinal osteoarthritis. Patient will have a limited range of motion, most likely due to pain, but sometimes due to degeneration of the facet joints. Symptoms mostly isolated to low back pain with no neurological sign and symptoms. That is an important one. There are no neurological sign and symptoms in the leg or even in the buttocks. And you sometimes see presence of muscle guarding and tenderness on palpation in acute and subacute stages. So what does the clinical practice guidelines say? If you have this kind of presentation in a patient, what kind of intervention would work the best. And it's a manual therapy, both thrust and non-thrust techniques, from Maitland grade 1 to grade 5, gentle repetitive motion in pain-free range to improve spinal mobility. Soft tissue mobilization works as well to some extent. Therapeutic exercises, specifically spinal stabilization, gentle spinal stabilization exercises works as well. And then encouraging patient for active lifestyle. So not take bed rest, but instead perform gentle pain-free range motion and stay active as much as they can, respecting their pain. So these are the recommendation for the first category. Now, what are the clinical findings when you have a radiating pain in the leg? Mostly again, acute and subacute conditions, sometimes chronic. But the hallmark is the paresthesia, the numbness, the tingling in the leg. And if it becomes chronic, you will find weakness started to occur in that leg, in their hip extensors, in their knee extensors and knee flexors, depending upon which nerve root is being compressed or inflamed. The straight leg raise test or the crossed straight leg raise test or the slump test, they're usually positive in these cases. And you'll find the dermatomal, myotomal findings in the reflex testing to be present and positive as well in these cases. So what can you do? What are the recommendations for intervention? Mechanical traction works really well in these patients. And positional traction, you can do that as well, where you can put the patient in side lying with that side up, the affected side up, and try to open that, put a roller on their downside, and then try to create a convexity. And when you create a convexity, it opens the foramen and it helps with reducing any kind of compression and then helps with relieving the patient's leg pain. Neural mobilization works really well, specifically for the sciatic nerve. Going back and forth and flossing the nerve really helps with improving nerves blood flow and reducing that radiating pain. Again, try that directional preference, but then follow by, once the patient's pain starts to centralize, you can start with spinal stabilization exercises, trunk exercises, and then manual therapy definitely helps to improve that lumbar mobility and reduce the compression on the nerve. Referred pain is again very similar. Its presentation again is buttock pain, thigh pain, and leg pain. Now, what's the difference between referred and radiating pain? Mostly, my experience has been that radiating pain in the leg accompanies with, as I said, dermatomal and myotomal findings. But in referred pain, it's not in a specific dermatomal and myotomal pattern. And there is no paresthesia, no numbness and tingling. And referred pain could be referred by any tissue in the back. It can come from the disc. It can come from the facet joint or any ligament as well, which is injured. So in these cases, you'll see there is a little bit of a differentiation between radiating pain and leg pain. Radiating pain when there's actual damage happening to the nerve or compression to the nerve, whereas in referred pain, nerve most likely may not be involved, but sometimes can be involved. Again, you'll find some kind of trunk shift, lateral trunk shift on reduced lumbar lordosis. And it usually occurs with someone with have a movement coordination impairment. Directional preference is the best one. Try to see if repetitive extension or repetitive flexion improves that pain. Traction sometimes helps, but manual therapy and stabilization exercises are the hallmark, again, besides directional preference. So I would say if you have to differentiate between the two in your treatment, traction doesn't seem to work in these patients, but directional preference does because the actual nerve is not being compressed. Movement coordination. This is usually happen in younger patients I have seen, mostly like a 15-year-old to like a 35-year-old, and mostly because of muscle weakness in their back, and it creates spinal instability, not to a certain point, not to a point where they get spondylolisthesis, but still an instability where they starts to have that aching back pain when they sit too long, more than 15-20 minutes on a chair, or they stand too long and they starts to feel like that they need to change their posture, and they like to pop their back a lot. And when you perform the spinal motions, active spinal motion, you see some shaking and juddering. We call them aberrant motion. And on passive range of motion testing, you find it hypermobility with hypomobility in thorax and pelvic region. These are the hallmark of their clinical findings. And all I can emphasize is a lot of spinal stabilization. Manual therapy doesn't seem to work as much, only in maybe improving mobility in the thoracic region or below in the pelvic region, but lumbar region really doesn't need mobility improvement because it's already hypermobile. Lot of stabilization, not just in therapy, but outside of therapy as well. Patient have to do a lot of therapeutic exercises of trunk and hip, and also patient education and activity modification, understanding ergonomics, understanding not being in one posture for too long, using a standing desk at home or at work, and not be in a posture in more than 15-20 minutes. And often patients have asked me, what's the best posture? We are physical therapists, we are supposed to tell them what the best posture is. And I usually tell them that your next posture is the best posture. There is no good posture, because any posture you stay for too long will going to start causing pain. And so you need to change your posture every 15-20 minutes. If you're sitting, you need to stand. If you stand, you go back to sitting, and make sure that you maintain that lumbar lordosis during sitting, and keep changing it, and then keep getting stronger. And the more stronger you are, you're able to assume that position for a little bit longer. But sitting in a perfect position for even for 30 minutes, 45 minutes, no matter how strong you are, it will cause back pain of some sort. So there is no perfect posture. The next posture is the best posture. So I combined the cognitive affective tendencies and the generalized pain because they overlap a lot. And this is where I would say that the two categories, you'll find a lot of psychological outcome measures we talked about earlier would come handy. If the patient scores high on these two, on those outcome measures, you can employ these intervention strategies with the patients, which is basically patient education. So what do you find in them? Chronic patient pain is longer than 3 months. It's not consistent with any of the other categories we just went over. Patient's positive response to some kind of mental disorder. You might see some kind of an anxiety because of pain, depressive symptoms because of pain, and they score very, very high on those outcome measures related to psychological disability. So what's the hallmark? What can you do? These are one of the most toughest patients. And if you find them in combination with those other treatment strategies would work, but the patient's pain would not completely go away. And the scientific research says that pain's neuroscience education, or talking about the biopsychosocial pain model, the pain is not just about the injury to the tissue. Pain is perceived in the brain, and don't be afraid of the pain, but try to respect it and work through it as per your tolerability. And that's where this graded exposure to movement and exercise is the hallmark treatment. Encourage them to move, but up to where they feel the pain, and then respect that, do stabilization exercises, but continue to expose yourself to movement and try to stay as active as possible. And then if possible, try to get the counsel of other health professionals that can help with depression and anxiety, because they all contribute to their pain. So the hallmarks become understanding pain and how pain is perceived and pain is processed in the brain. And the brain usually is not just about how much tissue injury has occurred. It's a combination of what you think of pain and how you perceive it to be. And it plays a major role. And as I said, these categories comes in conjunction with sometime other categories which we just discussed. So here, what I tried to do with my best estimation, I took common pathoanatomic based diagnosis of low back pain, and I tried to fit them into clinical practice guidelines diagnostic categories. Like for example, I think the osteoarthritis of the vertebral joints, or we call them spondylosis, mobility deficit category is something I would fit in. Any kind of synovitis or capsulitis, inflammation of the facet capsule, also mobility deficit. Usually they do not have any leg pain. Foraminal stenosis or radiculopathy, we call them, can come under radiating pain or referred pain. Degenerative disc disease, often referred pain into the buttock and the posterior thigh. So it could be into the referred pain. Similarly, disc prolapse. Herniation could be both, depending upon if it's actually compressing the nerve and causing the radiculopathy, then I would say radiating pain if they have those myotomal, dermatomal symptoms and paresthesia. And if not, then would probably fit into referred pain, and a lot of different directional preference would work. And then you have the spinal instability I just told you, and then SI joint pain due to ligamentous insufficiency can fit into those movement coordination impairment. Please note that low back pain with relative cognitive tendencies and generalized pain can occur in combination. I would also like to mention here the spinal stenosis patients. Now, those patients you can fit in mobility deficit, radiating pain based on their symptoms. If they do not have any leg pain, only they have degenerative spine and vertebral column, most likely they can fit into mobility deficit. But if they have that bilateral leg pain due to walking and sitting improves it, then you fit them into that radiating pain category. And we all know that it occurs due to degeneration of the facet and the disc, which eventually leads to foraminal stenosis bilaterally, and that causes that radiating pain. So as I stated in the beginning that these presentations are all evidence-based, all the recommendations are given some kind of letter grade, and each letter grade is assigned by the strength of evidence. So A means strongest evidence in the literature. They're level 1, high quality randomized control trials, or level 2, a little lesser quality. Similarly, B is moderate evidence, C is weak evidence, and so on and so forth. D is conflicting evidence, like some research showed it works, some shows it did not work. And as clinicians, you can make the final judgment call on what level of evidence is valid and reliable for you to include into your clinical practice. It's a very individual decision. Some people will perform intervention which only have strong evidence, and some people would say, yeah, I would like to try moderate evidence as well. So it's a very individual decision. So these are the updated recommendations of 2021. They categorize the recommendations based on the type of intervention and severity of the condition. These are the recommendations.
Dr. Kunal, we are running out of time. Kindly finish fast.
Yes, I have one more slide and almost done. And so these are 2021, and if you see there, these are all categories which are provided the strong recommendations. And what you would want to note is the language used by them. A means physical therapist should use, B means they may use, and C means that they can use. So these are for managing low back pain using exercises and manual therapy. And if you look at the acute low back pain, exercises actually is a C, whereas manual therapy is an A. So if somebody comes with you with acute low back pain, manual therapy is the best treatment. But if you look at the chronic low back pain, A is the exercises and not as much manual therapy. Manual therapy can be C, but mobilization is an A here. At post-operative low back pain, they still think exercises are doesn't have a very strong evidence. And this is my final slide for patient education. If you look at patient education, acute and chronic, it's somewhat moderate. But in chronic low back pain, that's where patient education works, that I just talked about, that psychological disability and pain neuroscience education. So giving them a lot of that and a lot of active treatment, asking them to stay active. So these are the recommendation. I hope that you enjoyed listening to my presentation, and I hope that you would incorporate these clinical practice guidelines in your clinical practice. These are all evidence-based, and these are the references. These are the 2 clinical practice guidelines I have used. So this concludes my presentation. If there is some more time left, I would be happy to answer the questions, or you can always reach out to me in the later time if you have any questions. Thank you.
Thank you, Dr. Kunal. Anybody, any queries there? So Dr. Kunal Bhanot is the program director and associate professor of the Doctor of Physical Therapy program in Carlow University, Pittsburgh. And he holds a PhD degree in orthopedics and sports science from Rocky Mountain University for health profession in Provo, UT, and Master of Science in Kinesiology. And he is a specialized musculoskeletal physical therapist, and his clinical practice focuses on treating patients with chronic pain and back pain. His research is focused on investigating the muscle recruitment pattern of the community and used therapeutic exercises for the musculoskeletal rehabilitation. He has co-authored several publications and peer-reviewed presentation at various conferences. Thank you, Dr. Kunal. It was a great pleasure to have you here in this platform. And thanks for accepting the invitation.
Absolutely, it was my pleasure, Dr. Ranjan. And let me know if you have any questions, just reach out to me and I will be happy to answer them. Thank you so much again, everyone.
Thank you. So now we have another speaker. She's Navpreet Kaur. And
good evening, everyone. Dr. Ranjan, can you hear me?
Yes. Just let me introduce you.
Sure.
Dr. Navpreet Kaur is a manual therapy certified associate professor in
University of St.
Doctor of
Augustine.
Physical Therapy program, University of St. Augustine for Health Sciences, Austin, Texas. So welcome, Dr. Navpreet, and she will be talking on the topic are special tests really special? A critical look at their usefulness in an orthopedic examination. Welcome, Dr. Navpreet.
Thank you, Dr. Ranjan. Good evening, everyone. My name is Dr. Navpreet Kaur. I'm an associate professor, as Dr. Ranjan introduced me, for about 8 years, last 8 years, at University of St. Augustine. Before that, I've worked as an outpatient orthopedic physical therapist in the United States as well. So topic is, are special tests really special? Critical look at their usefulness in an orthopedic examination. So during initial examination, we as physiotherapists collect data through history, systems review, and selected tests and measures, and then use that information to come up with a PT diagnosis to formulate a treatment plan. A good clinical or diagnostic test is one that can really differentiate between a person having and not having a condition. So it's really critical to ask yourself what kind of tests and measures and tools do you have in your toolbox. And to answer that question, we as physiotherapists should be able to assess and appraise the diagnostic research that pertains to these diagnostic tests. Hence, the purpose is to define and explain the commonly used indices in appraising a diagnostic research study and how clinicians can integrate the information in their clinical decision-making. Now, when we're looking at any research article pertaining to diagnostic research, we can divide that into 3 main areas to consider. The study design, which means are the results valid? the data analysis, what are the results, and can we apply that evidence to our practice. Due to time constraints, I'll be focusing mainly on the what are the results section. A quick look at study design. So when we're looking at a research article related to diagnostic tests, main things to consider are, is the reference or gold standard valid and reliable? Has that been applied to all participants? Is it independent of diagnostic test? And was there proper blinding of the examiner who did that test? When looking at the diagnostic test itself, it should be clearly described and interpreted in the research article, and there should be proper blinding of the examiners again. The population studied should be representative of the population on whom the test will be used in the clinic. So if your patient population is not represented in that research article, then it will not be a good research study to be applied to your practice. Now, focusing on what are the results section for my presentation. These are the main statistical indices that are usually reported in a diagnostic research: the specificity, sensitivity, likelihood ratio, pre and post-test probabilities. Again, due to the limited time constraints, I'll be focusing on the ones that are highlighted on this slide. Any diagnostic study reports the results in terms of true and false, positive and negatives, based on a comparison of a diagnostic test results with a reference or gold standard test. So it's represented in this 2x2 matrix, and then this matrix can be used to calculate the various clinical indices, as I mentioned on the previous slide. So the first one is the sensitivity that I would like to define. So sensitivity is the ability of a test to correctly identify the condition when it's present. So it's proportion of the patients with the condition who have a positive test result. A highly sensitive test have very few false negatives. Therefore, a highly sensitive test can be used to rule out a condition when it comes negative. So you can see on the screen the formula, how to calculate that. Defining the specificity is the ability of a test to correctly recognize when the condition is absent. It's proportion of the patients without the condition who have a negative test result. A highly specific test rarely have false positives. Therefore, a positive result for a highly specific test can be used to rule in a condition. So how can we clinically use this information? When you're looking at a special test and you know the specificity and sensitivity of those tests, if it's a highly specific test, we should be focusing on a positive result. So SPIN, which means a highly specific test, when comes positive, can be used to rule in a condition or diagnosis. A highly sensitive test, when it comes negative, can be used to rule out or screen the conditions. And usually 80% or above is considered good in terms of specificity and sensitivity numbers. The best statistics for summarizing the usefulness of a diagnostic test is your likelihood ratios. Likelihood ratios is the extent to which a clinician will change their estimate regarding the presence or absence of a condition. So by definition, a positive likelihood ratio means a likelihood that a positive test result was obtained in a person with a condition as compared to a person without a condition. Negative likelihood ratio is the likelihood that a negative test result is observed in a person with a condition as compared to a person without a condition. So if the likelihood ratios are not reported in a research article, but you only have specificity and sensitivity numbers, you can use the formula to calculate these likelihood ratios. A test with a large positive likelihood ratio is usually highly specific, and a test with a negative likelihood ratio, a smaller negative likelihood ratio, usually have a high sensitivity. And I'll show you on the next slides how we can use these numbers to calculate our post-test probabilities. When the diagnostic test comes positive in our patient, we will be focusing on the positive likelihood ratio. When the test comes negative in our patient, we'll be focusing on the negative likelihood ratio. So the guidelines to interpret the likelihood ratios. Since the likelihood ratios are the most important indices to pay attention to when we're looking at the credibility of diagnostic test, a likelihood ratio, a positive likelihood ratio of 5 and above, and a negative likelihood ratio of 0.2 and below usually gives you a significant shift in your post-test probability. A likelihood ratio of 1 for a special test or diagnostic test really does not do anything to change your post-test probability, which means there's no point in using that diagnostic test if likelihood ratio is 1. A likelihood ratio greater than 1 increases the odds of condition, and less than 1 diminishes the odds of having that condition. So now, how do we put all this information together in our clinical practice? We use these numbers to calculate the post-test probability. Post-test probability means how likely or what's the probability of having a condition in our patient, and we want it to be really high. So for example, if a post-test probability of having an ACL tear in my patient is only 70% after my diagnostic test, then I'm still not comfortable starting the treatment. Whereas if the post-test probability of having the ACL tear in my patient after applying my test measures is about 95%, I'm that much confident. That means I would like to start the treatment. So it's really important to calculate the post-test probability. And if that's higher, that means we can start the treatment. If it's low, then that means we need to keep looking. Now, how do we calculate this post-test probability? For that, we need to have a pre-test probability. Pre-test probability can be calculated different ways. And as you can see on the slide, it can come from the research articles, also known as the prevalence rates. It can be based on a clinical experience, depending on how many patients you see for a certain condition and what's the probability of someone having that condition. And the last one, which is the most important and most commonly used one, is the data you've already collected. So before applying a diagnostic test, how much do you think your person have that condition will give you that pre-test probability. So when in doubt, when you can't really come up with a number, using a number of 50% is always a good approach to start as well. So I'm 50% sure that my patient have an ACL tear or does not have an ACL tear. So you can start with the 50% of a pre-test probability. Now, once you have the pre-test probability, you can use different ways to calculate the post-test probability. I'm sharing two ways. One is nomogram, as you can see on the screen on the right side, the blue picture. You can find this nomogram on the internet very easily. It shows 3 lines. The first line on the left side is your pre-test probability. The middle one is the likelihood ratios we talked about. And then based on these 2 numbers, you will come up with a post-test probability. On the left-hand side, I've shared a website where you can just plug in the numbers, the likelihood ratios, and it will provide you the post-test probability based on the likelihood ratios. So let's put this together in an example. Let's take a hypothetical diagnostic test for an ACL tear, and you came across these numbers in a research article: specificity of 88%, sensitivity 96%, positive likelihood ratio of 6, negative likelihood ratio of 0.3, and let's say if, our pre-test probability is 50%. So based on examination so far, we are still not sure either way if this person have an ACL tear or not. So we're gonna go with 50-50 chance, and let's see how these numbers help us to calculate the post-test probability. So looking at these numbers, when we put that in a nomogram, if we are using a pre-test probability on the left-hand side, 50%, and the test comes positive, and our patient will use a positive likelihood ratio, and then the post-test probability is around 86%. If our test comes negative, based on a 0.3 negative likelihood ratio, our post-test probability of someone having that condition is 23%. If you use the website, you can just plug in the numbers, and again, you will see you're getting the similar results: 86% post-test probability if the test was positive, or 23% chances of having an ACL tear if the test came negative. So based on these results, I will be more confident in using this special test in ruling in an ACL tear when the test comes positive. Because if the test comes negative and I use a negative ratio, I still only have a 23% chance of my patient having the ACL tear. So in this scenario, I'll be using the test when it comes positive because it will give me a higher post-test probability of having the condition. So even though my sensitivity was higher, I'm actually looking at the post-test, the likelihood ratios to decide my post-test probability. Now, as I mentioned earlier, due to the time constraints, I will only focusing on the main things. What I discussed so far are the mean values, the mean value of the likelihood ratios or specificity and sensitivities. But there's always a variability in the data because the data is collected on a small sample and it may not be applicable to a patient if we only look at the mean values. So there's always a lower boundary and upper boundary, which is the variability, and those are known as the confidence intervals. And that gives you the worst and best case scenarios of the post-test probabilities in your patient. Because we don't have enough time left, so I won't focus on that, but I just want to highlight that the mean values only give you one number, but there's always a variability around that mean, known as the confidence intervals. Finally, how can we apply this to our patients? Other than looking at the reliability and validity, there are other questions that a clinician should ask before applying a special test or diagnostic test to the patient. Is it cost effective? Does the therapist have a good understanding of the test? Can they apply the test in terms of the expertise, patient values and preferences, and then previous experiences with this test? And then putting it all together will help us make a decision. Do we even need to apply the special test or not? Big picture, we need to make sure that if that special test is going to give us a higher post-test probability of having a condition, then yes, it's good to apply the test. If it's going to give us a lower post-test probability, then actually it's wasting our time because it's not going to push us towards starting the treatment. On this slide, I've given you some examples of special tests that are commonly used in an outpatient orthopedic setting, and what are the clinical indices for those special tests. And then focusing on the specific sensitivities, any special test with 80% or above specificity and sensitivity is usually considered a good test. And then when you calculate your post-test probabilities, mainly focusing on the likelihood ratios to come up with that probability of deciding if you will be doing a treatment or not. These are my references, and that concludes my presentation. Thank you so much, and let me know if anyone have any questions.
Any query? No question. Thank you, Dr. Navjeet.
Thank you so much, Dr. Ranjan.
So we will be, I think we'll be continuing with the other speaker. Thank you for joining us.
Now I would like to request Dr. B.K. Lamba sir to please come up on the stage and chair the session. I request Dr. Kirti Agarwal, Assistant Professor, Galgotia University, to please come up on the stage and chair up the session. I request Dr. Tanya Gujral, Assistant Professor, Department of Physiotherapy, Galgotia University, to please come up on the stage and chair the session. Thank you, ma'am. Start.
So now He is a chief clinical officer and he's a MD, senior vice president and clinical officer focusing on clinical quality and safety value based initiative to improve quality while reducing cost of care. Dr. Vasisht is one of the 219 and 218 Baker Hospital Review 105 physician leader to be known in America. He is a dual board certified internist and psychiatrist and an avid proponent of initiative aimed at promoting quality and improving safety, reducing cost and minimizing the variation in the delivery of the patient care across diverse setting. He has been recognized as regional healthcare hero and under 40 honorary, a senior fellow of the Society of Hospital of Medicine and fellow of the American College of Healthcare Executives. Dr. Vasisht most recently served as the chair of the Ballard Health Clinical Council and the system chair for the Ballard Health Hospital Division. And in this COVID-19 also, he was one of the key member getting the policy implementation and all that in US. So welcome, Dr. Amit Vasisht. And it is a great pleasure to have you on this platform. Okay, okay. So his topic of presentation is COVID-19 management and transition of care from acute to post-acute care. And then onwards, this will be taken by Dr. Amit Kumar after the Dr. Amit Vasisht. Yeah, welcome, Dr. Amit. You
Hey,
can
can you
start with
guys
your
hear me
topic.
okay?
Yeah, it's fine.
Good. Give me 1 second, guys. Thank you so much.
Share your slides, Dr.
Okay.
Vasist. Is it fine? Can you see your slide?
Yes, sir, I can. Can you put it on the slideshow, Dr. Kumar?
Yes. There you go.
All righty. Can we get started?
Yes, you can.
All right. Hey, thank you so much, everyone. Good afternoon, good evening, and a very good morning from the United States. This is Eastern Standard Time. So we are just past 6, as Dr. Ranjan would have introduced me. My name is Amit Vishist. So I would first of all like to start off by thanking the Global Association for Physiotherapy for inviting me. It's truly an honor. It's a privilege to be here with all of you this afternoon. And I did my MBBS from Government Medical College, Nagpur in India. That's where I met Dr. Ranjan, and our journey together started. Subsequently, went to the United States, where I did my residency, and I practice over as the Chief Clinical Officer, Senior Vice President for a very large health system, Ballad Health. Today, we will be talking mostly about COVID-19, what impact COVID-19 has had in the management and transition of patients who get admitted to the hospital from the emergency room, and then they get treated inside the 4 walls of our hospital. And when they're ready for discharge, they either go home or in many scenarios to a post-acute care facility like a skilled nursing facility or a rehab facility. Next slide, please. So 1 second, let me minimize my window. So the key objectives for this talk, of course, we'll be talking about the impact of COVID-19 pandemic on our health system, which is a fairly large and representative of a health system in the United States. As can you go back to this slide, the last slide, please? And we will also be looking, if time permits, at a few case studies and examples. Next slide, please. So as I was talking about Ballad Health, we are a not-for-profit integrated health system. We serve the southeastern part of the United States, our catchment area. This is a little snapshot of the map. I wish I could show you the map of the United States where we exist, but we are primarily located in 4 states, which is the Northeast Tennessee, Southwest Virginia, Eastern Kentucky, and Northwest North Carolina. We have 22 hospitals across 4 states, and these hospitals range all the way from tertiary centers, community hospitals. We have a children's hospital. We have a few critical access hospitals that are small rural hospitals, as well as a behavioral health hospital. Along with that, we have long-term care facilities, which are our rehab facilities. We have 140 ambulatory care outpatient facilities, clinics, those kind of things, retail pharmacies, as well as a large employed physician group comprising of about 800 to 900 physicians. Next slide, please. As far as COVID-19 is concerned, I wouldn't go through these slides. All of us know that COVID-19, when it started early last year from Wuhan, China, and of course the modalities of spread were primarily droplet as well as aerosol dissemination. A little bit of this was the number 3, which is through the touching of the mucous membrane that have been solved. But so far, the evidence is very, very little for that third modality. If at all there are cases, there are very few and far between. One of the more important points of understanding is that in COVID-19, it's not necessarily that somebody who is coughing, who is sneezing, only those are the one transmitting the disease. Asymptomatic spread of COVID-19 is very, very common. Next slide, please. As far as the epidemiology of COVID-19, of course, staggering statistics, we have had about 5.3 million deaths across the world. We reached a very, very tragic milestone earlier in the week in the United States of America, 800,000 deaths and 50 million cases just in the United States of America. So I think the United States has been impacted out of proportion, clearly the most impacted country with COVID-19 illness. Next slide, please. Can you go to the next slide? Of course, as I said, we have reached almost 50 million cases in the United States of America. In India, I'm sure the number will be considerably more than that, but so far it seems like we have about 35 million or so confirmed cases of COVID-19. These are the ones that were tested and detected to be positive for COVID-19. Next slide, please. This is a slide that shows the vaccination, how many folks have been vaccinated, fully boosted or one dose. Of course, as you can see, let's go to the United States of America. We authorized the booster dose a few weeks ago. So we have a fully vaccinated population in the United States at about 62%. Just started boosters, we are at 14%. If you look, of course, some European countries like France have a much higher rate of fully vaccinated as well as boosted doses. India, unfortunately, only has 39% fully vaccinated patients. Clearly, boosters have not been authorized there. So that's why you see there are no folks have been boosted as yet. I will also add over here that as far as the booster dose, we are pushing in the United States that to change the definition of fully vaccinated folks to include folks who have gotten a booster dose just because of the Omicron variant that is upon us. Of course, low-income countries were relying on an arrangement called COVAX, which basically was going to give them the access to the vaccines through, this was a vaccine sharing agreement, and it aimed to provide 2 billion doses by the end of the year. We, of course, know what happened. India got in the midst of a severe COVID-19 around April, May of this year, and that clearly has suffered because a lot of these vaccines were going to be exported from India. And as much as we are privileged in the developed countries of the world where 80% of the shots have gone, that also means, unfortunately, developing countries in Asia, as well as in parts of Africa, have not been given enough vaccines yet. Next slide, please. So COVID-19 has had a disproportionately adverse impact. It has disrupted healthcare. When we have had adverse impact on healthcare, some exciting innovations have happened. And of course, the United States healthcare system clearly has been in the midst of both those tragic cycles where healthcare suffered, as well as some innovations coming from that. You know, one or two of the biggest things that have happened is our hospital systems, our health systems have clearly been overwhelmed. Supply chain has been disrupted because we live in a very, very interconnected society. A lot of our supply chain items like personal protective equipment, gowns, masks, even therapeutics come from places like China. India is a huge maker of generic medications, and everything has suffered because we have taken primarily care of the patients with COVID-19. What that has also meant is that we have had to postpone procedures, elective surgery procedures. I really don't like the word elective because elective also includes Elective procedures, services, or surgeries mean folks who just don't need surgery at 4 o'clock in the morning, but people who are in advanced stages of cancer, their tumor needs to be taken out. That's included in, unfortunately, the postponement of those procedures. As a result of that, we are seeing a whole lot more increase in advanced stages of cancer, delayed detection of heart disease, all those kind of things. So we have been at the receiving end in the United States because of the constraints imposed by COVID-19. Next slide, please. So I think our general population, as far as disruption is of COVID is concerned, we have been impacted through the restrictions. You know, as I was alluding to earlier, you know, advanced stages of heart disease, hypertension, diabetes, because access to primary care has been impacted. I would also like to say that, you know, because of the disproportionate impact to the nursing facilities, to the post-acute care facilities like rehab, skilled nursing facility, home health, that has clearly suffered in the United States as well. Next slide, please. So this is, of course, this is a graph that tells a huge story. What happened during COVID, our inpatient or in-person visits in the United States, in the outpatient clinics. You see what happens in early March. COVID hits, COVID strikes, everybody's scared. We get locked down. In-person visits almost drop by 70–80%, almost coming to a standstill. And gradually, as things started to improve, so did in-person visits started to improve. So we are in a phase where clearly we don't have as many televisits as we used to back at the peak, but we still have a considerable. So you can see as that graph went down of in-person visits, the telehealth services across the United States and many other parts of the world clearly exploded in a way that we had never seen before. And that was one of the exciting things to come out of the pandemic, really exciting innovation. So as I said, the number of telehealth visits has declined, but clearly it is substantially more than what we were before the pandemic. United States health system, as exciting as we are in terms of designing cares for cutting edge research for all these diseases, all the fancy stuff that we do, is unfortunately very segmented. It's very siloed, it's very fragmented. And that's how you see, you know, patient get to the emergency department, admitted to hospitals, post-acute care facilities. There is not an optimal exchange of electronic records. And as a result, because of this fragmentation, the patient care suffers. Let's go to the next slide, please. So I was alluding to earlier, because of the impact of COVID-19 hugely on older parts of our population, nursing homes, post-acute care facilities, rehab were disproportionately and adversely impacted by the pandemic. There were several countries, they had done a few things, but not much to protect our most vulnerable population as and before COVID arrived. In the United States, we were clearly caught napping and we lost a whole lot of our nursing home residents because of the pandemic. The testing was abysmal, the treatment, their admission to hospitals, all those kind of things was just unfortunate. And a whole lot of staff working in this nursing home was bringing COVID-19 inside the four walls of our nursing homes. Next slide, please. And this chart tells a very tragic story. In the Western world, you see a huge percentage of total COVID-19 deaths came from the post-acute care, the nursing facilities, everything. In the United States, 38% of our deaths were came from the long-term care facilities, post-acute care facilities, places like Belgium, Netherlands, Sweden, all those places. So unfortunately, that was the case in the Western world. Next slide, please. So I think the areas of focus where we try to make efforts in terms of fighting pandemic and maintain the safety of our patient in post-acute care, as well as during acute care, was how do you make sure that you maintain adequate staffing, because a lot of folks were getting sick, a lot of folks were getting burned out, and they were worried. There were childcare issues. Kids were being educated from home. There was the teleschooling going on. Remote instruction was going on, and our nursing staff is, of course, younger female. So staffing was a very, very big challenge. As I said, burnout, stress, unprecedented amount of misinformation. So our focus was, how many financial incentives do we provide for our staff to come show up to work and try to take care of those patients? Next slide, please. So, as much as possible, clearly this work suffered a lot. We tried to maintain ongoing access to non-COVID-19 care as much as possible. But during different waves, like the recent Delta wave that we had during the months of August and September, that clearly suffered. We were not able to take care of as much of our non-COVID-19 patients as we usually do. Visitations, access to patients, our policies around triage, all those kind of things were designed so that we limited danger to our patients as well as to our caregivers during the times of these waves of COVID-19. Of course, we robustly try to use telehealth to try to take care of those patients, reduce in-person visits, all those kind of things. So next slide, please. So we have relied robustly on the use of epidemiological data, data that comes to us in the United States from CDC, our state health departments, our local county health departments, to basically share information, manage COVID-19 resources. So there is a very tight collaboration, which at times is not tight, unfortunately, but for the most part, it has worked for us. And as I said, it works locally as well. Next slide, please. So let's talk a little bit about post-acute care rehabilitation. Basically, you have patients who get admitted to an acute care, the regular kind of hospital, and then a whole lot of our patients, for example, in Ballad Health, the last point, which is more than a third of our patients get discharged. Once they are ready to be discharged from the hospital, they are medically stable enough to get out of the hospital, but they usually need more physical therapy, other modalities of therapy. So they have to be discharged to either a skilled nursing facility or an inpatient rehab facility. So next slide, please. So I think communication has been a challenge, but it has been an area of opportunity as well, so that we can continue to deliver consistent, uniform messages to avoid confusion and conflict. We have embarked on a robust education program about the risks of COVID-19. How do you manage to stay yourself healthy? We have been, unfortunately, no match for the amount of misinformation that circulates around social media, no amount of appearances on TV from officials, all the way from Dr. Fauci to CDC director or anybody, is not enough. The amount of misinformation that exists on Facebook, the WhatsApp, the Twitters of the world has clearly overwhelmed us. But at the very same time, communication has been very, very key for us in terms of reducing the impact of COVID-19. Next slide, please. So I think our response can be basically summed up into three different categories. Number one is, we prepare as much as you can. Right now, we are preparing for an imminent surge of the Omicron variant. And you prepare your staff, you train your staff, you do robust data modeling, how many patients you expect to be admitted. Once those things come, you are confronted with that unfortunate situation. You respond by getting your staff ready, your resources ready, your supply chain, all pieces in place. You learn a few lessons along the way. There are things that you learn that you should not have done. You drop those lessons, But there are clearly some best practices that emerge, and we try to sustain those. So I think these are the things, I call it the PRS model, prepare, respond, and sustain model. And that is very, very necessary during this pandemic and any other pandemic that will come to different parts of the world. So next slide, please. So just wanted to, we are at the very, very end of our presentation. Of course, we live here in the United States. My friend, Dr. Amit Kumar, who I've been associated with since our days at Government Medical College, Nagpur, we saw what was happening in India back in April and May. And of course, what happened was very, very tragic. We were here in the United States. We were fighting the pandemic over here, but we also realized that India is a developing country. We are not blessed with as many resources as some of us in the United States and in the Western world. So at that point of time, we decided, Dr. Kumar and myself, that we will start this not-for-profit fund drive, GoFundMe drive. And we were successful during that time. We raised about $40,000 or so to go to different parts of India to help with the COVID-19 relief. When this was happening back in April and May, I went on television channels requesting our local communities, regional communities, to donate for people stricken with COVID-19 in India. And I will tell you, as far as we live, the community was very, very generous. People who work in housekeeping, who sweep the floors and everything, they pitched in with donations as small as $5, $10, $20. But I think their gesture went a long, long way. They didn't know. They've never been outside the United States. They don't know where India is, but they clearly knew that our community, our population in India was suffering. I also had warned during that time, back in April and May, that no part of the world is safe unless every part of the world is safe. So that's why we need to be generous in providing, sharing resources, information, therapeutic modalities. Unfortunately, my voice and so many others who have been advocating for science has fallen on deaf ears. And in August, onwards till October, we were in the midst of the Delta wave in the United States, and we have lost about 100,000 more lives since then, because our response was just lagging in terms of getting our own population vaccinated, as well as getting population in parts of Africa, India, and other parts of the world vaccinated. So the role of immigrant worker is clearly very, very important in the United States. More than 1/3 of us serving the communities here are immigrants, and clearly that was recognized by various forums in the United States. So I was honored to receive this, but that was an award for all the immigrant frontline caregivers who served on the front lines of COVID-19 pandemic. I myself, I'm a practicing physician. In the next few minutes, I'll be starting to drive to the hospital to take care of patients with COVID-19. Some things to keep in mind as we move forward the next few weeks, even if we are in India or in the United States. I said Omicron. It's not if Omicron is going to hit us, it is when Omicron is going to hit us. So it is very transmissible, it's very contagious. Maybe it is less severe, but the amount of people it is going to impact, especially the unvaccinated ones, we see a lot of breakthrough infections in vaccinated, but because they're vaccinated, the severity is a little less. So please, 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 wherever you are in any part of India, beware, educate your communities. Omicron is coming. I'm not trying to scare anybody, but Omicron is not going to be very pleasant. So read as much as you can and educate as much as you can. Medical misinformation. This has really killed us in the United States. Vaccine resistance, reliance on modalities of treatment like ivermectin, all those kind of things, and not taking the therapeutic modalities that are based on evidence and have been approved has been really extending this disease and will continue to do so, unfortunately. Please be aware of the mental and emotional impact that the pandemic is generating on all the frontline caregivers, be it in India or in the United States. In the US, we just approved the Lorna Green Healthcare Provider Protection Act. I was involved in crafting of this legislation providing resources for our frontline caregivers. And the last thing is, no matter if you're in India or in Europe or in the United States or in Australia, a lot of people don't want to be in healthcare. They have just been burned out. They've seen way too many deaths, way too much stress, and they feel there are other areas to work in that do not involve healthcare, where they may have a better work-life balance, all those kind of things. So we will see a whole lot of people leaving healthcare, as they're calling it, the age of great resignation. So just be aware of that as well. With that, I would like to thank you again. It's been a privilege. It's been an honor to be here. This is just a great picture. I live 10 minutes from here. This is one of our bigger hospitals located in Johnson City, Tennessee, Johnson City Medical Center. And you can see all those colors and everything. We get that every single year during the fall. So a great area to live. I'm just blessed to work here, and I appreciate your time. Thank you. I'll take any questions if there is some time.
Thank you, Dr. Amit. And it was really a very interesting talk. And I would say that you have been largely associated with the COVID-19 managing and treatment at Tennessee University from the Ballard Health doctors. So if any query is there, then we will have any queries. No queries there, sir. We will proceed to Amit, I think. And thank you for coming on this platform.
Yeah, there is no such thing called too many Amit. Amit Vashisht and now Amit Kumar. So I appreciate it, guys. Thank you so much. Have a great day.
Thank you.
Thank you,
Dr.
Vashisht. Amit Kumar is a graduate from GMC Nagpur, and he has done his PhD from University of Pittsburgh, US, and now is serving as an assistant professor in University of Arizona. So kindly continue, Amit. Before that, just Amit, wait for 1 minute. We will be facilitating our chairperson, Dr. B.K. Lamba, who is about to leave, as his train is there by 5:40, 5:50. So I will request Dr. Vandana to facilitate Dr. Lamba. And I will at the same time request Dr. Rahul to continue as a chairperson for this session. Dr. B.K. Lamba, sir, is a very senior physiotherapist, and he has been working in Karnal. Now he's retired from his service, and he's doing his, I think he's inspiring, and he's motivating the physiotherapists, budding physiotherapists, by his all social work in the field of physiotherapy. Thank you, sir. Thanks for coming. Dr. Rahul, kindly continue as a chairperson. So over to you, Amit.
Okay. Can you hear me, Rohat?
Yes. Yes.
All right. Good morning, everyone. Good evening to India, and good morning from Wild West, Arizona. So I live in northern Arizona. So the title of my topic is Role of Rehabilitation Care in the Era of COVID-19 Pandemic. And thank you, Dr. Vashisht, for setting up the stage and giving a brief orientation about the US healthcare system and post-acute care system. Today, I'll be discussing how rehabilitation can improve long-term outcome in patients with COVID-19. If time permits, I can give one case study example, and how WHO has recommended, to do more physical activities during the pandemic. As Dr. Vashisht said, the US healthcare system is fragmented in silos based on the payment, based on settings. So as I said, it's primarily it goes from high intensity to low intensity, and starts from emergency room, acute hospital, then long-term acute hospital. Then we call it inpatient rehab facilities, where they receive at least 3 hours of rehab, physical therapy, occupational therapy, speech therapy per day. And if patient can't tolerate that much of rehab, then they goes to skilled nursing facilities. We call it SNF. And some of the SNF also include long-term care hospitals, where largely patients with Alzheimer and dementia receive care. Then we have outpatient care and home health care, so primarily almost after the following hospitalization, 2% patient goes to long-term acute hospital, those who are primarily on ventilators. 10% patient goes to inpatient rehab facilities. 41 to 42% patient goes to skilled nursing facilities, SNF, and 9% patient goes to home and receive outpatient care, and almost 37 to 38% patient goes to home and receive home health care. And again, that includes nursing care, physical therapy, speech, occupational therapy. So of course, disruption, as Dr. Vasist has highlighted, the disruption happened in the during the COVID period, and it's almost large number of patients end up going to hospital, and then they need ICU care, they need oxygen therapy, all this thing, and primarily large number of older populations with multiple chronic conditions were getting admitted into the hospital. And many of these patients end up on getting intubated and ultimately impacting speech, swallowing function, respiratory function, and overall affecting physical function, impairment, and frailty. So, it's really important, from the PT point of view, what we can do during this pandemic. And the role of physical therapy, again, start from workforce planning and prepare recommendation, ensure the safety of the staff, and with appropriate PPE. And during the early phase, there was a paucity of lack of evidence on rehabilitation recommendation during COVID-19. Some research was coming from Italy and UK, but in the US, we were not having so much evidence on PT, the role of PT. And of course, with the time passed, we saw some evidence that patients with COVID-19 will be benefited from timely and comprehensive rehabilitation care from acute to post-acute care. And again, and as I said, I do research here primarily in epidemiology area. So we have seen some PT interventions, so not only be provided when there are clinical indicators, so that the staff exposure to the patient with COVID-19 should be minimized. And also during acute setting, if needed, you can monitor the patient through tele-rehabilitation or through video call also. But along with that line, early mobilization should be encouraged to improve the functional strength of the patient, reduce the risk of frailty, and along with that line, we should be mindful for the safety of the staff and using appropriate PPE. So here's one of the case study done by my colleague from the Cleveland Clinic, Joshua Johnson, and he looked about for patient diagnosed with COVID-19, and he examined the relationships of physical therapy visits frequency with the patient mobility status at discharge and probability of discharge to home. So he used the retrospective study and using the electronic chart review from one healthcare system, which includes 11 hospitals in Cleveland area. And the primary outcome, as I said, was a patient functional status. They use John Hopkins scale and AMPEC 6-clicks mobility scale. And again, you can see in the results section, it's definitely there is a monotonous relationship between amount of physical therapy visits and higher odds of improvement in patient functional status and more likelihood of discharge to home. So again, here's one case example, so for example, in acute care setting, a 60-year-old male was hospitalized due to COVID-19 with the symptom of fever, dry cough, and dyspnea, all the common symptoms of COVID. Patient was having a difficulty in maintaining sufficient oxygen saturation during physical activity. They started physical therapy on day first and to avoid rapid deterioration and respiratory failure. And they started with the prone lying and step-by-step from 135 degree. And then followed by breathing exercises to avoid prolonged coughing and oxygen desaturation. And as exercise progression goes on from first to fifth day, patient was finally discharged on day 10th. So this is the one successful story of the patient from that clinic. Again, as Dr. Basis had mentioned, disruption happened here in the US at various levels. But again, the post-acute care in the US was largely affected. And as I have shown the graph in the prior slides, the US healthcare system is fragmented in the silos, and especially in the post-acute care setting, we have inpatient rehab, we have skilled nursing facility care, and home health care. So the disruption in the US post-acute care happened at the 3 different levels and through 3 different mechanisms. The first one was a skilled nursing facilities, which quickly became an outbreak hotspot with almost 38 to 48%, 40% of death happened in those skilled nursing facilities during the first 2-3 months. And the second one was, and again, that affected because almost as I showed in the previous graph, 40% patient goes to skilled nursing facility to receive rehabilitation in those skilled nursing facilities. The second happened at inpatient rehab facilities. So during the initial stage of pandemic, inpatient rehab facilities were converted to acute care units in the early stage of the pandemic, because they were not in a bed in acute hospitals. And that resulted in large number of patients discharged to home following hospitals, not receiving any kind of rehabilitation. And then third happened for the patient who are discharged to home. Usually they receive some kind of home health rehabilitation or outpatient care. But again, at that time, home health providers were kind of restricted and hesitant to provide home visits because of limited personal protective equipment. And also there was a lot of staffs also got infected during that period of time. And so there was a shortage of staff, and that also delayed the initiation of home health care or number of home health visits to all these patients who need some level of rehabilitation. Again, with this pandemic also kind of opened the Pandora box of disparities in COVID-related mortality and number of confirmed cases in the US. And of course, in India, it might be a more, but we don't know because we don't have any data. So here we have done some research showing the disparities in COVID mortality by racial and ethnic proportion of patients in different nursing homes. And of course, in the early period of the pandemic, we saw there was a racial disparity in those nursing homes which have a higher concentration of Hispanic and Blacks. Then in the latest part of the pandemic, we saw that it went in a different way. The nursing home with higher proportion of white population, they died more often than the nursing home with high proportion of Blacks and Hispanic. Of course, COVID don't discriminate based on the race and ethnicity. It's a system, it's a structural racism here in the US or either in India, which kind of led this kind of findings. So again, talking about the skilled nursing facilities, my another colleague from Brown University in Orestes did some research. Again, it's all this data has been done in the large population, you can see. So he identified, examined the risk factors for 30 days, all-cause mortality among US nursing home residents with COVID-19. And again, this was a retrospective cohort study in 351 US nursing homes among 5,256 nursing home residents from March 16 to September 15, 2020. And the outcome was death due to any cause within the 30 days of the first positive COVID test results. And the finding was, again, it was not surprising. Those two comorbidities were significantly associated with mortalities, diabetes and kidney disease. But another thing interesting came from the PT point of view, and rehab point of view is very important. Compared with the resident with no physical impairment, those patients who have a higher level of physical impairments have significantly higher risk of death by 49% and 69% compared to the patient with no physical impairment. And again, likewise, also patients with cognitive impairment also have almost 100% higher risk of dying compared to no cognitive impairment. So that shows again, like, the role of physical therapy during the nursing home care or during the acute following discharge from the hospital, like, because physical therapists, occupational therapists play a significant role in improving your physical function. So again, I also, as I mentioned, inpatient rehab facilities was also part of the post-acute care system, got disrupted, and also I mentioned all these factors, like, what was happening in inpatient rehab facilities. It became acute care hospitals, and large number of PT working in the inpatient rehab got infected. So then again, I also mention all these things. Disruption happened in home health care, as I said, because of lack of PPEs and protective staff, and home health agencies were hesitant to send their staff back to the patient's home. So again, there was another study done by another Catherine Ball from UPenn, University of Pennsylvania, and Cornell University, and they described how home health recovery of patients with COVID-19 and associated risk factors with rehospitalization or mortality. The study was done using all the patients who are discharged to home following hospitalization in New York City, and it's 1,409 patients with COVID-19 admitted to home health care between April 1st and June 15th. Following hospitalization were included in this study, and the finding was of course, risk of rehospitalization and death was higher for patients with heart failure, diabetes with complication, consistent with other studies too. And the same thing we found a patient with cognitive impairment and physical dependent, we have higher risk of rehospitalization and mortality. Again, it's restating that role of physical therapy and rehab in patients with COVID-19. Again, coming back to outpatient care here, so this is a data published by American Physical Therapy Association. We can see the disruption in outpatient care as well as by different settings. So there was a reduction of percentage of physical therapy utilization by 29% in acute care hospital, 33% in outpatient care, 45% in private outpatient clinics, 40% in SNF, skilled nursing facilities, 46% in home healthcare settings, 35% in the school system, and 12% in academic institutions, and 20% in inpatient rehab facilities. So overall, there was a 36% reduction in physical therapy utilization in the month of July, almost last year. And here in this slides, you can see percent of physical therapy caseload has been declined again during that pandemic. Again, you can see how much decline. The blue one is the before pandemic, and then in the blue one is during the July, and the gray one was in month of April and May. So it went for example, the access to physical therapy went from 33% to 19%. Same thing for the hospital-based outpatient facility clinic, went from 67 to 38%. So you see across all the settings, number has went down significantly. And again, we don't know right now the outcome because we don't have follow-up data, so we don't know right now. Once we will have those data, then we can see how COVID in pandemic has impacted the patient outcome. Right now, we are seeing only how it has impacted the utilization and disruption in care. Again, now, as Dr. Vasis mentioned, we will have almost 1 billion population with COVID survivor, and all these patients will have some level of physical impairment, frailty, and they need some kind of rehabilitation after that. Of course, in the US, we have a robust post-acute care system, including inpatient rehab, SNF, home health, and so does other Western countries. They have already robust post-acute care system to handle those patients. But it's challenging for the places like in India and other developing countries where we don't have a post-acute care system. There is a missing post-acute care system. Patients just have a hospital and then they discharge to home and they receive physical therapy either in outpatient clinic or through home visits. So that will be a big challenge in developing countries. And I can see, like, in India, we don't have inpatient rehab or skilled nursing facilities. When I was in India, in Mumbai, working for All India Institute of Physical Medicine and Rehabilitation, Hazi Ali, and that was the only inpatient rehab unit I saw at that time in the year 2001 and 2. But I think things might have changed in the last 10, 12 years. I don't have exactly the data on that. But again, it's really important. Rehabilitation will play a significant role. Recently, the Lancet has published some articles showing the role of rehabilitation in COVID long haulers, and that will reduce the risk of avoidable hospitalization in that patient also, and improve the patient functional status and long-term recovery, and also preventing the post-COVID complication. So again, during the pandemic, WHO has recommended, doing some physical activities, at least 30 minutes a daily or an hour a daily for the young kids. And although, is even no matter whether if we are having a pandemic or not pandemic, the physical activity definitely is helpful in improving the health outcomes of any individual patient. So again, some studies has shown up that role of physical activity levels and prevalence of COVID. The study was done in Brazil and showing that dose response effect of physical activity, amount of physical activities with the lower prevalence of COVID-19 related hospitalization. So performing at least 150 minutes a week of moderate intensity of physical activity or 75 minutes of vigorous intensity of physical activity was associated with a 34% reduction in the prevalence of COVID-related hospitalizations. That was a big difference. So again, I would from here, from base of my own experience with using all these different studies, and I can see we should recommend our patient and our community folks for more physical activities. Again, there was another study so physical inactivity associated with a higher risk of severe COVID-19. Again, the study was found that higher amount of physical activity was strongly associated with the reduced risk of severe COVID-19 outcomes among infected adults. And so again, as Dr. Vasis said, one best thing came out from this pandemic was again, telehealth. And I want to tell you here, so from the last 35 years, American Physical Therapy Association was lobbying to Center for Medicare, Medicaid, CMS, we call it. They are the one who makes the policy.
Sorry to interrupt you, but we are running out of time. So please wind up fast. I request you to wind up fast.
Yeah, thank you very much. So that was the one thing came out, and CMS during this emergency, they passed the law, and tele-rehabilitation was reimbursed, started getting reimbursed from the insurance company. So, but again, there was several challenges with the implementation of tele-rehabilitation, especially in the rural areas. And so again, so here's the, I would like to conclude my presentation, as we are moving from a, outpatient to telehealth visits, we will have to be very, very cautious, in terms of health equity. And so here I will stop myself, and thank you for your time and your consideration. Any questions is welcome.
Any questions? Thank you, sir.
All right.
Thank you, Amit. It was a nice presentation. And I hope that this will benefit the audience here, whatever experience you have shared here. So thank you for joining. So now our next speaker is Dr. Vandana Dua. She is a physiotherapist in Department of Neurology, All India Institute of Medical Sciences, having 10 years of experience. कितना ज़्यादा है उससे? 12 years of experience. Earlier, she was working as a assistant professor in a spinal cord injury center, Delhi.
Good evening, everybody. Thank you, GAPT, for giving me this opportunity to be here. I'll be talking about early mobility in neurocritical care. The presentation. Some issue with the slide. Anyways, I'll be talking about early mobility in neurocritical care. So यहाँ से transit नहीं हो. आप next slide कर दीजिए. Go to the next slide. Well, this is what a neurocritical care looks like virtually. I'll be focusing both on neurological and neurosurgical cases here. We have a wide plethora of diagnosis, including various tumors, traumas and infections, neurodevelopmental, neurodegenerative disorders, cerebrovascular accidents, post-tumor resection patients and all, which are present in a neurocritical care and which I'll be focusing on. Next slide. I can do it. It's okay. Okay. So let's talk about early mobility. Early mobility is not a new concept. It has been there in the literature as early as in 1942, though the interest died off after 1970. And now in 21st century, there had been a renewed interest among the researchers and the clinicians about this. And there had been actually a flood of researchers in this particular area. And the major reason of this renewed interest is that because of the medical advancements, we have better survival rates. So we have a huge number of critical care patients which are there with us, which are not only a challenge for us as a clinicians, but also is leading to a huge economic burden to the society. So why are we talking about early mobility is because we want to combat the deleterious effect of an inactivity. Why do we have these deleterious effects? Because we know that 2/3 of our body consists of water and which is subjected to gravitational stress. And as soon as we bring the patients to a recumbent position, that gravitational stress is gone. And the intravascular, the extracellular fluid, it goes into the thoracic cavity and which cannot be combated by any kind of bed exercise unless and until an upright position is assumed. this deleterious effects on the of this inactivity or bed rest per se, it can lead to deleterious effect in almost each and every organ system of a body, be it respiratory, cardiovascular, hematologic, metabolic, it can be gastrointestinal and everything. But I'll be focusing upon IC acquired weakness. So what is IC acquired weakness? IC acquired weakness is that any weakness which cannot be correlated with any reason prior to the ICU admission. So it is acquired within the ICU itself. It can be in a neuropathic or a myopathic pattern or a mixed type of pattern, on the basis of which it is being termed as critical induced myopathy, critical induced neuropathy, or critical induced neuromyopathy. So not able to change. Okay, so what can we do to combat this bed rest? The answer is a multidisciplinary approach of an early mobility. It is a multidisciplinary approach. It is a team of a physiotherapist, an intensivist, a physician, a nurse, and a hospital attendant which can take care of this. So what is early mobility? Well, as the name suggests, it is mobility as early as possible. So it is about mobilizing a patient as early as possible. So we are targeting a patient when the patient is under is intubated and is undergoing a mechanical ventilation itself only. Then we are targeting their mobility. It can be in various phases. It starts from as soon as we bring the patient to a head up or a propped up position. That is the first stage of early mobility is being achieved. So if we go through this flow chart, it starts from in bed activities, the head of bed or elevation, the ankle toe pumps, which we do, and the passive exercises, gradually progressing to active assisted and active, then going to the bedside exercises, edge of bed exercises, and then out of bed exercises, and then followed by ambulation with or without assistance. So these are the various phases of early mobility per se, and the entire comes under the umbrella term of early mobility. Next slide. Okay, the early mobility, the path of early mobility has a lot of barriers to be overcome. The literature has reported a lot of barriers. The most stubborn of them is the attitude of the staff, primarily because of the lack of knowledge in the training. Then second, which is very commonly seen in a neurocritical care, is the sedation practices. Here in neurocritical care, the sedation practices is being used for various therapeutic purposes, like maybe to reduce the intracranial pressure, to promote the cerebral perfusion pressure, or maybe the patient is too agitated, is fighting with ventilator, to decrease the work of breathing of such patients, that we are doing it. But in turn, it is hampering our early mobility. And then there are other factors like patient's pain, discomfort, hemodynamic instability, safety of tubings, catheters, and other devices, personnel and equipment resources which are required to mobilize or intubated patient. Then patient size itself may be a hindrance at times. And then timing, valuing, and prioritizing mobilization over a lot of when the lot of critical care procedures is being done. But the literature clear cut says that the benefits of an early mobility outrightly outweigh the barriers. So we must attempt it. The benefits include that it increases the cardiopulmonary endurance and the muscle strength, improves the functional status, decreases the economic burden, decreases the evidence of, the incidences of pressure sores, and in turn, it all leads to decrease in the duration of mechanical ventilation and the length of ICU stay, improves the quality of life of the patient, and a positive outlook in the patient is generated. Now, to overcome barriers and to actually exploit the benefits, we need to have certain strategies. One such strategy, which is reported to be efficient, is ABCDE bundle. So ABCDE is actually a mnemonic which stands for ABC. A, that is awakening, that is giving a break to the sedation whenever possible, and breathing, B for breathing, C for coordination. So we are actually coordinating the awakening trials with the breathing coordination, maybe giving spontaneous breathing trials if possible, and along with delirium management. So if a patient is not under delirium, he is conscious enough to obey our commands, it gives an added advantage. And then we are attempting, E stands for early mobility. So it is awakening and breathing coordination with delirium management, and hence attempting early exercise on early mobility. Now, we know what to do, but at times we are not able to do because we don't know what are the what are the actual patients we can actually, or the potential candidates which can undergo early mobility. So that for that we need to have a comprehensive assessment of patient. We must assess for the patient's vitals, their hemodynamic stability, the patient's higher mental functions, and the physical strength. And we have various standardized tools now available for this. Like we have this PERME ICU mobility score, which is shown in this. Then we have ICU mobility score, functional status score for intensive care unit. For a neurocritical care, we have a specific tool which is referred to as readiness questionnaire for early mobility in neurological ICU, which clear cut says that if all these things are met, there is a yes to all these questions, only then we attempt for early mobility. Here, early mobility means the out of bed activities which we are targeting on. Then more importantly, in a clinical situation, we should know when not to attempt. That is, what are the contraindications to it. So if a patient is unconscious or under delirium, or if a patient has a recent myocardial infarction, is hemodynamically unstable, maybe the patient is having bradycardia of less than 40 or more than tachycardia of more than 130 beats per minute, a patient has a mean arterial pressure less than 60 or more than 110 millimeter mercury, has an intracranial pressure more than 20 millimeter mercury, the patient is desaturating even with the oxygen support, or a patient has a low respiratory reserve of less than 200, or the patient is ventilated with a higher mode of ventilation having FiO2 more than 60 or PEEP more than 10, and then if the patient is tachypneic, or a patient is undergoing an active sepsis, or a patient is in evident respiratory distress, anemia of less than 7 gram per deciliter, or patient is having a platelet count less than 20,000 meter, or if the patient is stable but is on high inotropic support, then also we must delay our mobilization per se. Or if patient is a hypothermic or hyperthermic, the patient has a spine which is unstable, is actively bleeding, or has an acute DVT, or if the patient is undergoing dialysis, or if a patient is an ongoing intravenous sedation. So these are the contraindications. Now we know the indications, we know the contraindication, but we have attempted mobilization, so we should know then when to stop. During our session itself, if any of these features are met, we have to stop. That is, we have to terminate the session. So it is important to know the termination criteria. If the patient starts desaturating, even if with the supplemental oxygen or with the existing mode of ventilation which the patient is getting, the patient starts desaturating or develops respiratory distress, we must stop. Or if the patient develops hypotension, tachycardia, any new kind of arrhythmias the patient develops, or if the patient is reporting to be extremely fatigued, having chest pain, or having an intolerable dyspnea, excessive pallor or flushing, or just simply if the patient is requesting us to stop, then we must terminate our session there and then. Now, we should also have this in mind that yes, early mobilization is very much important, but it is far more than just exercise in an ICU setup. And our goal is not to rebuild something which the patient has lost at that time, but our main goal is a modest retention of function. So we should not be over enthusiastic also. Now, there are various adjuncts of early mobility reported in literature like cycle ergometry, electrical muscle stimulation, functional electrical stimulation, which are there in the evidence, but they are at very naive stage. We are actually waiting for a good, robust RCT to prove this so that we can put them into clinical practice. Now, coming to special consideration in a neurological setup. First of all, I will be talking about early mobility in stroke. In stroke, we have one unique indication, that is we have to prevent learned non-use of a affected extremity in case of stroke. We know that in the stroke, we have an acute window period, which we can actually exploit to gain maximum benefits. And the patient once develops this learned non-use of an affected extremity, it is very difficult to go back or to reverse that condition. So it is recommended that early mobility should commence within 24 to 48 hours post-stroke, but it should be dependent upon the type and severity of the stroke. For this, there was an AVERT trial. It was a robust or large RCT which was done in 2017 on 2,100 patients across 5 countries, and it found that if the mobilization is done within 48 hours of onset, it led to less of adverse events and low rate of mortality. Then there was another trial called HEAD-POST trial. There is another controversy, especially in ischemic stroke, that there is a notion which is being said that the patient must lie supine for first 48 hours after ischemic stroke so as to facilitate circulation to the penumbra, which is still active. This was addressed in this particular trial. What did they do? That for the first 24 hours, they randomly divided the patients into 2 groups. First, they kept the patients into 30-degree propped up, and second, they kept it in supine. And they found that the disability outcomes were similar. There was no significant difference between the 2 groups. Then coming to the hemorrhagic stroke. In the hemorrhagic stroke, early mobility is, yes, important, but we must wait for the hemorrhagic volume to stabilize for at least 24 hours. Only then we should attempt for mobilizing these patients. And early mobility is considered safe and feasible in patients who have received RTPA as well, but yes, with close monitoring. Now coming to SAH, subarachnoid hemorrhage. In subarachnoid hemorrhage, as soon as the patient, what's happening? Go to the previous slide. Subarachnoid hemorrhage, as soon as the aneurysm is being clipped, we can start off with the bed activities and we can go for ambulation the very next day. And the mobilization can even be done in patients who have an EVD in situ, provided that EVD is secured and is clamped during the session, and ICP is kept below 20 millimeter mercury without an active administration of mannitol or the hypertonic saline. Next slide. Now coming to the spinal cord injury. In a spinal cord injury patient, if in case the spine is stabilized, we can attempt early mobilization, provided that we are taking care of the secondary issues like autonomic dysreflexia and orthostatic hypertension. And in case of practical limitation, the use of mental imagery can be used. This is a systematic review done by our team itself, which says that yes, the mental imagery can actually be benefited in patients with the practical limitation. This is our own experience in our own setup. We tried to mobilize the patients who were mechanically ventilated with myasthenia crisis. So there were 30 patients with myasthenia crisis grade 5, and they were randomly allocated into this early mobility group or usual care group. And we found that yes, it is feasible. The early mobilization of mechanically ventilated patient with myasthenia crisis is feasible. It is safe, and it leads to decrease in the duration of mechanical ventilation, thereby decreases the length of ICU stay. But yes, it requires diligent monitoring and supervision during the ambulation. So we have also tried to summarize the same in a chapter by Springer. Here is the clinical pearls. I've tried to summarize the important points, the important clinical issues. That first says that early mobility is safe and feasible in intubated neuro patient, and what we need to take care is that the ICP should be less than 10, mean arterial blood pressure should be in the range of 80 to 90, and the cerebral perfusion pressure more than 70 millimeter mercury. It must be maintained throughout the session. The ambulation in 24 to 48 hours of stroke onset, it leads to better functional outcomes and lower mortality. And early mobilization is considered safe and feasible in patients who have received RTPA, but yes, with close monitoring. And it's even safe in patients with femoral catheter in situ. Next. In craniotomy patients where the bone flap is not there, we should take care of a direct pressure on the brain tissue so that we can use protective equipments like helmets, etc. during the session. And if in case we have any CSF leak from nose, ear, or any incision site, we should report to the competent authority as soon as possible. And no movement is advisable in acute DVT without an anticoagulant cover. And ambulation can be resumed on the day of surgery itself in the cases of discectomy and laminectomy. Thank you. Questions? Are there any questions you want to ask something? Yes. Oh, thank you. Thank you.
Thank you so much, ma'am. It was really informative session. Now I would like to call our next speaker, Dr. Shurab Khan, sir, Associate Professor, Department of Rehabilitation Science, Jamia Hamdard, New Delhi. Sir, please come.
Thank you. Respected Chairperson, Dr. Prabhat, Dr. Poonam, and all other available left student. I'm not going to bore you more because I'm last in the presentation. So kindly you start my presentation. I'm not going to discuss anything new, but as all the chief guest and guest of honor has advised us to go for more and more promotion of our profession in community, okay? Because our senior like Dr. Prabhat, Dr. Pushkar, they all are doing a great job in creating awareness for the physiotherapy and how we can be a better therapist. They are doing their job, okay? But our job is we have to go to community and create awareness among the society how much important we are for them, okay? So my message to the student is that we should go to the community, our neighborhood, our park, okay? We can collect them and teach them small things, okay? With the help of some slides, some diagram, it will help us in promoting ourselves as well as our profession, okay? So in my presentation, I'm going to discuss very common problem, which is common everyone. Nowadays, it is common from the second decade of life to 70, 80 years of age, okay? Everybody is having all these problems. Whether they're having symptom or not, but they all may have sign. If we will gather data from 100 people, out of 190 will have at least some problem related to musculoskeletal problem, okay? Please, next slide. So my topic is musculoskeletal disorder. Very common problem. Next. All the structure, muscle, ligament, tendon, bone, cartilage, fascia, bursa, they all are having some problem and they can be represented in form of musculoskeletal problem. And the data is very alarming. It is the second most disabling cause of the worldwide, okay? And I would like to tell you, muscle is the owner of the whole body. Mitochondria is available in muscle and the energy is produced in mitochondria. So all the structures are dependent upon the mitochondria. If there is any problem in muscle, they may be in trouble. So if we will have a research on all these topics, we will see most of the urban people are having diabetes, thyroidism, cancer. All these kind of problem is more common among the urban population. And one of the more risk factor is they all are having insufficient muscle because of poor posture, long sitting hours, great stress. All these things are leading some impairment in muscle. And because of muscular impairment, because the functioning, they all are moving. And for movement, they need ATP. And most of the maximum ATP is formed in mitochondria. And we have maximal muscle. Okay. So if we will have research on this topic, we'll found that the heart disease, kidney disease, liver disease, they all may have some correlation with the muscle impairment. So you can see the data. Lancet shows millions of people are suffering from low back pain, knee pain, neck pain, and there is no cure for available till now. Only the hope is physiotherapy. So we can take a lead. If we are able to tell the population we are the only professional, only person who is going to make your life better, pain-free life, dependent life, without you don't need any support. If you will take advice from us, so we can have a lot of patient and we can have a lot of name and fame. Next slide, please. So, and you know, our profession is basically based on muscle. As a physiotherapist, we have maximum role on muscle. And if we can improve the muscle performance, that is muscle strength, flexibility, and endurance. We can't have much role on the bone, don't have much role on the ligament, capsule, cartilage, because they all have the capability of repair and their healing capacity is very poor. Even after making a lot of effort, we could not optimize the healing of ligament, fascia, and bursa. But muscle is the only tissue which can be strengthened up to any strength. Muscle is the only tissue which can increase up to any endurance. Muscle can be made flexible up to any extent. You can see the gymnast, you can see the weightlifter, okay? They have unlimited strength. So muscle, and there is no doctor for muscle except physiotherapist. We have a full command over muscle, and muscle is the only tissue which is going to rehabilitate, which is going to make a person independent, which is going to make a person healthy. Next slide. So we will discuss one by one because I'm in very hurry. It is last presentation. You will be in hurry. So the first and major abnormal culprit is the misalignment and imbalance. Okay. We all know area is inversely proportional to the stress. Okay. And we all are sitting in awkward posture. If you analyze over here, everybody sitting in flexion posture. Okay. Your knees are bent. Hip is bent, okay, elbow is bent. It means one group of muscle remain in shortened position for a long time, and the antagonists are lengthened. It can create imbalance because we all know muscle is having property of adaptation. If we maintain the muscle posture in one position for a long time, one group will be for the shortening and other will be for the lengthening. And physiology says whether sarcomere is shortened or lengthened, muscle will be insufficient. Ultimately, for any work, if we need to use only one motor unit because of muscle insufficiency, we can use 5 motor units for the same work. It means somewhere we are losing ATP. And if we are losing ATP, it means we are over-stressing our vital structure. So if our heart, liver, lung, and kidney, they will be overburdened, they will be exhausted early, and we will have all these diseases. So the other things you may be aware: obesity, inactivity, low capacity imbalance. I will like to discuss the third one, low capacity imbalance. Okay, nowadays, if you go through the histology, God has made male and female, and God has given 80% type 1 fiber to female and 20% type 2 fiber to female. Okay, and male is being reversed. He has been given 80% strength fiber and 20% endurance fiber. Okay, but nowadays, if you see the lifestyle, whether male or female, even female are more exerted. They have to work at home as well as in the office. Whereas male are working throughout sitting, they are working in sitting posture. They need more and more endurance in their body, and their body is having more and more strength. So they have to train their body according to their job requirement. Okay. But what they are doing, whoever is more health conscious, they are going to gym and going for weight training. So still they are converting their type 1 fiber into type 2 fiber. Okay. So their job demand is endurance, and they are training their body for the strength, and the problem arises from here. Same as a lot of patient is coming to my clinic, youngster, they are having disc bulge, shoulder injury, back injury, knee injury after gym. What happened in gym? If they are doing gym not for the health, they are doing gym for the show off. They are focusing on the front of the body. Okay, ki abs ban jaye, cheesy biceps ban jaye, and they ignore the back one. So body is working on the principle of alignment. When you over exercise front muscle, it will having more strength as compared to back one, and your spine will be misaligned. Ultimately, what happened? One area will have more pressure, and that will be degenerated. Okay. Mental stress we all are knowing. Go back to next back side. Okay. Wearing improper footwear, we are all aware. Okay, how it is going to affect your whole pelvic obliquity and ultimately affecting the whole body kinematics and having problem. Repetitive work and overuse of soft tissues. Nowadays, if you analyze your whole week activity, you will came to know 80% activity you are repeating every day. Okay, it means you are overusing one group of your body muscle, ligament, tendon, etc., etc. Okay, and the other group is being unused. This is also causing imbalance. Prolonged sitting is as more disastrous than smoking. This research says smoking is better than prolonged sitting, and we all are working at least, we are spending our whole day in 16 to 14 hours sitting. Okay, monotonous, constant, and faulty posture, we all are knowing about this. Physical inactivity, overexercise, very common pattern nowadays. Okay, everybody is saying I'm exercising every day, but they don't know how to exercise. They should come to physiotherapy. Exercise is not a automatic thing. It should be prescribed like medicine. Exercise is medicine. Okay, and it should be prescribed by the physiotherapist. So we have to create awareness among the society. If you want to exercise, you must come to us. One important thing, I'm not saying anything bad about yoga, but nowadays people are doing yoga. The difference between yoga and physiotherapy, as I think, yoga is like speaking English by reading Rapidex. Okay, and physiotherapy is like speaking English going through nursery, KG, then vocabulary, words, grammar, then you are speaking English. Okay, so this is the difference between yoga and physiotherapy. Yoga, they are performing posture, and if one person is good enough, healthy, okay, he is having all balanced muscle or everything is balanced, yoga may be good for them. But if they are performing any posture with imbalanced muscle, with degeneration, yoga may harm them. After every intense yoga day, our OPD increased by 20 times. Okay, they came with the injuries. किसी ने योगासन कर लिया, शीर्षासन कर लिया, and they have a lot of injuries. Okay, so yoga is not good if your body is not aligning, if your body is not flexible. Okay, don't go for yoga. First, go for physiotherapy. Make your body fitter, make your body balanced, then perform yoga. Okay. Then painkiller, सबसे खतरनाक चीज. Okay, painkiller. Pain is not a disease. Pain is an informer to our body structure, our brain. Something is wrong. Okay, and we should be careful if something is wrong, and we should try to find out the problem and cure it. But what nowadays people are doing? They are taking painkiller and they are killing their informer, who is informing themselves for their bad thing, who is informing about their damage. They are killing them. So we have to create awareness. It is not about the side effect. The main thing, we should create awareness among society कि भाई painkiller नहीं लेना है. You are masking your problem. आपको दबा रहे हो. And what happen? What will happen? If you are taking painkiller, it means you have decrease the pain, depress the pain, and the load has been transferred to other structure. So your joint is working with less capacity. So what happened? After some time, you will have again more injury, and that can be more harmful to you. And the preferring curative over prevention. Physiotherapy is still lacking in prevention management. Okay, we should provide prevention more and more. That's why I'm saying go to community. आपके बगल में पार्क है, आप जाइए, चार लोगों को बुलाइए कि मेरा नाम ये है, मैं physiotherapist हूँ या student हूँ, and I'm going to teach you about your how to save your knee from injury, further how to prevent it from further deterioration, how to prevent your back. Okay, they will listen you and they will give you a lot of respect. So I'm requesting all of my students कि when you go to your neighbors, your park, आप metro में बैठे हैं, बगल में बात करिए, कोई बात नहीं, आप बात करें कि you are telling something good to them. Okay, so ये हमारा ये attitude होना होगा. अगर हम खाली ऐसे कमरों में बैठ के बातें करेंगे बड़ी-बड़ी conference में ना, तो we will never be able to propagate ourselves. The ultimate need of this time is we have to go to community. Ultimately, we have to work with them. We are here to give them some benefit. Okay, so ultimately, what is our role? Physiotherapy is not a very big thing. It is very simple. We have only 4 roles. First role is we should try to promote healing, quality and quantity of healing. Okay, if someone is having pain, swelling, spasm, so these are good things. Okay, but nowadays we have some alternate to prevent all these things. जिसके लिए spasm था कि movement नहीं करना, मुझे पता है, I have sling, I will not move. Okay, so we can control pain, we can control spasm on the first day of injury. So if we will control the inflammation of first day of injury, it means we have promote the healing. जो next stage होगी, जो 4 दिन बाद शुरू होती है, वो शुरू हो जाएगी. Okay, so we can speed up the healing. Secondly, we can improve the quality of healing. How can I explain you? Earlier, the patient was referred to physiotherapist when they were having complete evidence of healing. But nowadays, they are referring us immediately on the same day of injury. Because we all know if we start physiotherapy from the second stage of healing, we can prevent fibrosis, we can reduce the scar formation, we can Dr. Vandana told us how early immobilization is important. So early immobilization is always good. It can prevent lot of complication of immobilization. Okay. So first role is, as a physiotherapist, we are going to prevent and promote healing in terms of quality and quantity. Second role, if anyhow, because we know lot of structure healed by repair, they could not achieve optimal. So what can we do? Second role is compensation. We as a physiotherapist, we are trying to produce some compensation for that loss. Okay, अगर एक हाथ कमजोर हो गया, we will try to improve the strength of the wrist and shoulder. Elbow problem हो गई, तो we will increase strength of wrist and shoulder. Okay, if the whole arm has gone, I can try to over strengthen the other one. So second role of physiotherapy is try to produce compensation for the loss which could not be regained by your all available intervention. This is second role of physiotherapy. Third role is even after doing all these things, we could not produce compensation. Third one is the ergonomics and orthosis. Okay, with the help of ergonomics and orthosis, we can avoid excessive loading over the weakened structure, as well as by providing orthosis, we can support the weakened structure. This is the third role. And fourth role is, if we will not be able to do, we can ask the patient to avoid some activities which are going to harm your body. Okay, so ultimately we have gone through all these things, and we all know we have a lot of role in all these things. Obesity, earlier we are saying to patient, bhai वजन बढ़ गया, कम करो. But वजन बढ़ना सिर्फ खाने से नहीं होता. There are a number of factor how it can increase your weight. So we have to assess what are the reversal factor, what are the irreversible. Okay, so we could decrease some weight. Nowadays beside decreasing weight, we should try to strengthen the body to carry out more load. अगर आप एग्जांपल देखें, पुराने जमाने में घर बनते थे ना, तो 2 फीट गड्ढा खोदा और घर बना दिया, because they know they will not go for more than 2 floors. But nowadays they are going 3 floors down, making a strong foundation with the concrete and iron bars, because they have to go to 20 floors. So what that is shows, either keep the foundation strong or keep the load low. Nowadays it is very difficult to keep the load low, so we have to make our body strong and strong. And the need of nowadays strength is not a power. The nowadays strength is flexibility of the body. Okay, the more flexible body will be able to absorb more and more stress. Okay, so don't work for the strength. I'm not saying in case of athlete, but in case of normal population, we should work on the flexibility and endurance. Okay, same as all these things, we all are aware about things. I'm not going to discuss everything, but my message is only this: we have to go to community and create awareness among society how important we are and how we can educate them by telling all these things to prevent them from musculoskeletal disorder. Thank you so much. I'm sorry, I was in hurry.
But it was very good.
Yes, ma'am. Please need it or ma'am. Everyone is suffering now.
Gym injuries and all.
Yes, ma'am.
Even in trauma, we are also facing the same thing.
Yes, ma'am.
Youngsters, 16-year, 17-year boys and girls are going to gym and they are doing injuries and coming to us again.
I mean, all the trainers are qualified enough. Okay, they did gym and they become trainer. Okay, they don't have any body mechanics knowledge. Okay, so and we should train, we should teach our youngsters. भैया क्या कर रहे हो तुम लोग है ना? और जो लोग ये MNC वाले ना मैम, they are very health conscious. I am going to gym 2 hours and weight dumpling कर रहे हैं ना, फिर 10 घंटा बैठ के कंप्यूटर चला रहे हैं. तो it is not matching your body demand. Okay, आपको रहना इंडिया में, पढ़ना है फ्रेंच में, फायदा क्या होगा? आप हिंदी पढ़िए ना, सर्वाइव करेंगे. यस यस, वही तो कर रहा हूँ मैम. यस, लेकिन यार इंडिया में नहीं, इंडिया में नहीं सर, इंडिया में हिंदी पढ़ना है. ठीक है सर, वो तो ठीक है, लेकिन जो है फॉर अकेजनल सर, योगा बहुत खतरनाक चीज है, बहुत खतरनाक चीज. आई एम नॉट सपोर्टिंग योगा सर. योगा जब करें, जब आप बचपन से करें, ठीक है. एक बार अगर बॉडी में इम्बैलेंस हो गया, आपने किया, तो वो और इम्बैलेंस क्या करें. हमने कहा ना, रैपिड पढ़ के अंग्रेजी बोलना. यस, फ्लेक्सिबिलिटी इज द नीड ऑफ आवर. आज के जमाने में फ्लेक्सिबिलिटी जरूर सर, है ना. थैंक यू सर.
Thank you, sir, for such delightful session. Now I would like to request Dr. Rahul, sir, to please facilitate our speaker, Dr. Sharab, sir.
Prachi. Prachi.
I would like to request Dr. Kriti and Dr. Tanya to please felicitate Dr. Vandana Dua, ma'am. I request Dr. Vandana Dua, ma'am, to please come up on the stage.
Chairperson.
Thank you, ma'am. Now, I would like to request Dr. Poonam ma'am to please felicitate our chairperson. I request Dr. Kirti Agrawal ma'am to please come forward. Thank you, ma'am. I would like to request Dr. Tanya Gujral ma'am to please come forward. I request Dr. Poonam ma'am to please felicitate. Thank you, ma'am. Thank you, ma'am. I request Dr. Poonam ma'am to please felicitate Dr. Rahul sir. I request Dr. Vandana ma'am to please join Dr. Poonam on stage. Thank you so much, ma'am. So now we came to the end of the day. I really thank to all the speakers, all the chairpersons and all the delegates for your cooperation, and we'll end today and tomorrow we'll start our session at sharp 9 a.m. Okay, thank you.